Everyone, on behalf of the organizing committee of Aprasocon 2025, I welcome you all, and I thank our distinguished faculties, Dr. Subodh Singh sir and Vijay Kumar sir, to have dedicated such time for us for the next 2 days. I welcome you all at the sacred and auspicious land of Lord Jagannath for the next 2 days, and I hope that the next 2 days for you will be enjoyable and everyone will be having something to take away from it. We have put our heart and soul into it. I hope the next 2 days are really good for you. Thank you. Yeah. And with this, I would like to invite Dr. Prithviraj Singh sir and Dr. Devidat Mahande as chairpersons for this starting session, and Dr. Mahesh Mandal to start with the talk, please. Please, sir.
लैपटॉप एटी आने ना अच्छा स्लाइड
Hello. Hello. Good morning, everyone, and one warm welcome to Aprasocon 11. Our first speaker is Dr. Mahesh Mandal. He is assistant professor at Bhimsar, Burla, and his topic is on my experience in the management of head and neck BCC with local flaps in Bhimsar, Burla. Dr. Mahesh, now you can start your presentation.
Thank you, Chairperson. Good morning, everyone. Respected Chairperson Singh sir and Devi sir, then my teachers and my seniors and all the respected delegates from all over India. Today I am going to present my topic on my experience on management of BCC patient in head and neck region in Bhimsar, Burla. Basal cell carcinoma is most common cutaneous malignancy, and 80% of skin cancer are due to basal cell carcinoma. And BCC most commonly affect in head and neck region, and BCC locally aggressive tumor with low mortality rate. So I have started my study to study the epidemiological profile of BCC patient admitted in and operated in Bhimsar, Burla in last 2-year period. So time period from June 2022 to June 2024. Patients are evaluated in form of age, sex, and site of lesion, size of lesion, types of BCC, margin status achieved after excision of the lesion, and recurrence rate. And diagnosis confirmed by FNAC or scratch site lesion where ulceration occurs in the ulcerative variety. In all cases, 0.5 to 1 centimeter margins are taken, and different type of flaps are used like forehead flap and scalp rotation flap, rotation advancement flap, rhomboid flap, local transposition flap, mustard cheek rotation flap, etc. After discharge, patient will follow up every 2 weeks for first 1 month, then every monthly for 3 months, then every 2 monthly for 6 months. Total 40 patients are included in our study, and females are most commonly affected in 60% of patients. Most common age group is 61 to 80 years. The oldest patient I have operated is 91 years, and average size was 1 to 2 centimeter. Nodular variety is most common type. Nodular variety with ulceration was most common type. Since most of the patients are ignorant about the disease, when the patient first present with nodular variety, they think it is just small size lesion, it is not do any harm to me. So they remain stay for any treatment for 5 to 6 years. After ulceration develops, then patient concerned about the disease. So also say, since I stay in the western parts of Odisha, where people are think that going to Cuttack or Bhubaneswar, very difficult to come there and treat the patient. So most of them neglect the patient. Whenever the surgeons refer him or her to higher center, they refuse. And marginal margin status was negative in 92% cases. Only 8% of cases margin status was positive. So I have to reoperate that patient, and margin clearance occurs. And marginal flap occurring in 5% patient. Recurrence rate was nil, and mortality rate was nil. Coming to defend my clinical cases. This is a case of basal cell carcinoma involving left side of the side wall of the nose and also part of ala, where wide local external lesion done and local transfusion from nasolabial area to cover the defect. This is post-op day 3 photograph. This is post-op day 7 photograph. This is a patient, poor lady, who presented with ulceration of the forehead area. It remained for around 10 years. So it invaded the outer table of the frontal bone. So we have to remove 1 centimeter, around size of the defect lesion was around 6 into 8 centimeter. We have to excise very large size of defect. So we have to reconstruct with first all the calvera, both outer and inner calvera has to be removed and reconstructed with silicone titanium mesh by the neurosurgeon. Then I cover the defect with local transfusion flap, extend from the large flap from the skull vision and cover the large defect over the nasal bridge also. And the patient recover easily without any complication. This patient presented with basal cell carcinoma of the temporoparietal lesion and wide local excision of lesion done and rotation flap was done to cover the defect. This patient presented with BCC over just below the lower eyelid, where wide local excision of the lesion done, then local transfusion flap on nasal level area is done to cover the defect. This is a post-op day, 1 week post-op period. This is a superficial spreading type of BCC, which involves the upper eyelid also. So we have to remove the almost all part of the upper eyelid, and this is the defect after excision of the lesion. Then forehead flap was planned to cover the both upper eyelid and the defect. Then this is the post-op period, and patient is happy about the lesion, about the eye opening. I told him that I should do surgery to debulk that area, but he said that, okay sir, I am doing everything, I have no complaint about it, so I will not do any surgery further. And margin status is also normal. This patient presented with BCC over the left side frontal lesion. This is where wide local excision lesion done with rhomboid flap done to cover the defect. This is the 1 week post-op period. This lady, 87-year-old lady, who presented with basal cell carcinoma of the right side nasolabial fold just below the medial canthus and also from left side nasolabial fold, where wide local excision of the lesion done. Then mustard cheek rotation flap was done to cover the defect. This is the intra post-op period, and after it is 2 week post-op period, patient is happy about the surgery. This patient presented with BCC over the right side, ala and side wall of the nose. This is patient presented external lesion done, then forehead flaps are done. This is debulking after flap division. This patient
sorry
presented
to
with
interrupt, Dr. Mahesh. I think time is over.
2 minutes.
Two more questions. Okay, fine. Just so two more cases.
Okay, sir. This patient, okay, sir. This patient presented with BCC over the dorsal nose involved in the underlying bone also. So I have and both upper and lower, middle and the upper and lower I did on the right side, where wide local excision of the lesion done, then local fur flap to done to cover the defect. This is post-op period. This patient also presented with right side facial lesion, BCC or right side facial lesion, and wide local excision lesion followed by local transfusion flap was done. This is a 2 weeks post-op period without any complication. So I am going to conclude a topic that basal cell carcinoma is locally advanced malignant tumor without distant spread. So it is curable with low rate of mortality. Awareness among patients should be done with early diagnosis and treatment should be done. With proper planning, all defect after excision can be reconstructed with local flap. Thank you, sir.
So thank you, Dr. Mahesh. Really, it's a wonderful presentation, I would like to say. I think the volume of work also you have shown within a very short span of, say, 2 years is
Sir, 2 years.
very much, I think, appreciable.
Thank you, sir.
And now it's open to the audience.
No, sir, no, sir. In our department, no frozen sex facility available. Then I will do reoperate the patient. That is a problem with in our department. Thank you, sir. Sir. Thank you, sir.
Yeah, thank you.
Okay, sir.
Jai Jagannath, good morning, respected chairpersons and invited faculties. It's my pleasure to come to my homeland to present in the Plastic Surgery Association. So, my talk will be on reconstruction of post-mucormycosis head and neck defects. It need a multidisciplinary management to manage all these patients and give result. I work here, Jaipur National University Medical College. I have started my work after completion of my MCS in 2016, and now it's a full-page department. So, mucormycosis is a rare but serious infection. We all come to know more about this disease after COVID-19 infection. So, this infection caused by Rhizopus, mucor and Listeria. Rhino-orbitocerebral is the most common type. Next is pulmonary. But most commonly, we plastic surgeons face these patients. Those are rhino-orbitocerebral, means facial involvement. These often affects COVID-19, diabetics and immunocompromised individuals. So the pathogenesis involve exposure of mucous membrane to the spores, then it undergoes rapid proliferation and angioinvasion, so that it lead to venous thrombosis. So it present with non-healing progressive ulcer with bony destruction. Usually the diagnosis is clinical. If we wait for fungal culture or any biopsy, we'll lose 2 to 3 days at least for biopsy, and fungal culture will lose some days. So the clinical, high degree of clinical suspicion and timely management is the key. So investigation includes cranial CT, MRI and endoscopy. So since 2021, after COVID-19, we have operated around 72 cases and more in line. So we have done immediate reconstruction in 16 patients and delayed reconstruction in 56 patients. So we have done with prefibula osteocutaneous, then ALT and radial forearm. The recipient vessels are usually superficial temporal or facial vessels. We have done re-exploration in 5 cases and failed 2 fibula. Those are failed flaps due to venous thrombosis. So coming to management protocol, basically it starts from medical management and radical debridement, immediate or delayed reconstruction. We prefer immediate reconstruction for surface defects which involve outer skin, and delayed for intraoral and mucosal defects. Then dental rehabilitation and prosthesis. So European Confederation of Medical Mycology recommends one world, one guideline initiative. So liposomal amphotericin B, 5 to 10 mg per kg is the drug of choice for 3 to 6 weeks. Pasoconazole, 800 mg slow release tablets are also given. Response assessment on weekly basis. We continue for 3 to 6 weeks at least. This is my team of anesthetists and ENT and other plastic surgeon. Then we prefer radical debridement, which was usually done by the ENT surgeons. 3 goals: disease control, histopathological assessment and microbiological diagnosis. But we don't wait for the diagnosis to be established by culture. So now coming to immediate reconstruction. This is the case of right-sided cheek and maxillary involvement and also involvement of the orbit. This is the excised specimen. And this is the defect after excision. We have to give the mucosal lining and the outer cover also. So we have done a free ALT flap to cover the orbit and intraoral mucosa and outer lining. This is another patient with scalp mucormycosis after excision of the bone also, frontal bone also, and this ALT microvascular flap, and this is post-op. And this is another case of scalp defect following mucormycosis excision and covered by ALT. This is left maxillectomy defect. It is covered by ALT. This is another defect after right orbital extension and maxillectomy. Free ALT flap cover was done, which cover the orbit and maxillary area. This is another extensive case, left maxillectomy. So we have done, tried to save the eye in this patient, and this is the post-op. He is having deformity due to absence of infraorbital rim. Then coming to delayed reconstruction, our priority, if there is no mucosal, no external skin defect, we try to do delayed reconstruction. This is another case of orbital extension. We have done radial forearm free flap to cover this eye. Then this is the total maxillectomy defect. We have done prefibula osteocutaneous flap for the lining and the fibula for maxilla. You can see the 4-month post-op result, contouring of the face. This is another post-central maxillectomy and right orbital extension defect. This is a composite defect. We have to do a chimeric flap for orbit and also bone for maxilla and inner lining. This central maxillectomy defect, prefibula osteocutaneous flap. This is post reconstruction. You can appreciate the advancement of the maxilla and contouring of the face. This is another case of total maxillectomy after reconstruction with fibula. This is post left hemimaxillectomy defect, fistula closure was done by turnover mucosal flap, and a single defect was created, and reconstruction was done with fibula osteocutaneous flap. Then coming to dental rehabilitation, it's very important to this is a post-maxillectomy defect. We have operated for fibula osteocutaneous flap, but dental rehabilitation was not done that time. Then we have put the implants. We take help of dental colleagues, and in this case also, you can see the result after post-dental rehabilitation. The patient can able to smile. So we have to take help of dental colleagues and dental prosthetics also. Now coming to prosthesis. In some cases, this is a partial maxillectomy defect covered with this prosthesis. We take help of prosthodontics colleagues, and you can see very good result also after prosthesis. This is after prosthetic rehabilitation. This is also after maxillary prosthesis. So we can do microvascular flap, we can do local flaps, and we have to do dental rehabilitation, and also we can go for prosthesis. So we have to take everyone with us to give patient a better result. So take home message is, we have to do 5D reconstruction, form, function and aesthetic, 1 artery and 2 vein, usually recipient artery, superficial, temporal and facial. Soft tissue or composite defect, free ALT flap or radial forearm flap for small defects. Complex defect requiring bone and lining and cover, free fibula osteocutaneous flap. And for outer skin defects, immediate reconstruction, and inner mucosal lining defects, delayed reconstruction. And maintain relationship with facial aesthetic also. From 2021, in span of 2 years, we have 40,000 cases of mucormycosis reported. That time there was a surge in mucormycosis cases, and 3,000 patients died of this disease. Now after resection, many survivors need reconstruction, they need us. So we have to go for delayed reconstruction in those patients. This is my guru and my mentor, Dr. Pradeep Goyal, with whom now I have a chance to work in my institute also. And from Jaipur National University and Rajasthan Association of Plastic Surgeons, I welcome you all and invite you all for the rhinoplastic cadaveric workshop. We are organizing on 31st and 1st of February. Thank you.
Well, thank you very much for your nice elaboratives on mucormycosis, Dr. Satyavrat. I have a question, when the reconstruction is ideal to do it? Because most of the patients, when they survived at off late, they have been gone for reconstructions. So it is possible that primarily, after a couple of days of the disease, the reconstruction process should have been given. Because most of the cases where the intracranial involvement was there, they expired after that. So what is your say after the experience of so many cases, that how early the reconstruction could have been done?
Sir, we can't leave the outer defect open. We can't leave the brain material or orbit or maxilla open. So we have to do the reconstruction in outer defect. If there is skin or outer defect, we have to reconstruct immediately or within some days. One general anesthesia we prefer, in one general anesthesia we reconstruct also. That will take around 2 hours extra after ENT surgery, if patient is stable. For inner lining bony defect, we can go for delayed reconstruction.
But what I believe now, if you do a early excision, good debridement and do a early reconstruction, that will give a better outcome of
Yes.
the patient's life.
Yes,
Is a
actually
life
some
at stake.
patients are referred to us after excision by ENT surgeons. If ENT surgeons feel, they don't come to us primarily.
That is the problem with
That
the
is the
plastic
problem,
surgeons.
yes.
We are late surgeons
Yes.
because this, we are referred by us.
So if the-
why I am telling you
Yes.
this, in most of the cases, the plastic surgeons should reach to the earliest so that a good decision can be taken for the benefit of the patient. That is my point.
Yes. That awareness should be created among the patients. Among the doctors also. Yes.
How do you ensure mucus-free margins in case of acute reconstruction?
Sir, we have to take, we don't have any biopsy or any, in case of malignancy, we have frozen section. So clean margin, we prefer clean margin. And if there is also some remnant disease, we can, we are giving liposomal amphotericin B in those patients. That will control some disease if there is a good vascularity in that area. We believe that if there is a good vascularity, drug will reach to that area and that area will be cured. If there is some marginal, it's not like a malignancy, but we have to treat it like a malignancy.
Thank you.
No, nothing. No cases. Actually, in malignancy cases, that is the difference. In malignancies, usually some, after neck dissection, some veins are damaged. That's why we could not get adequate length. But in this case, this mostly affected part is the upper part of the face. So neck is usually spared. So we don't require any vein graft in those patients.
Thank you, Satyabrat, for such a nice presentation.
Thank you, sir.
Now we welcome Dr. Asmiranjan Mohanty. He will be presenting on reconstruction of challenging mandibular defects with free fibula grafts. Welcome, Rashmi.
Very good morning to all of you, respected Chaudhary sir, Singh sir, Devi bhai, all the seniors, colleagues and juniors. I am going to present the challenging cases of mandibular reconstruction. These are mainly cancer, post-cancer excision cases. So, following mandibular excision post reconstruction is required because when it involves the central part of the mandible, it generally leads to tongue fall and respiratory obstruction. And if it involves the lateral part of the mandible, then it leads to deviation of the remnant of the rest of the mandible, leading to malocclusion. Patient has to restrict to soft diet and cosmetic anomaly. So different reconstructive procedures, bony reconstructions are available like fibula, iliac crests, scapula, radius, rib, or second metatarsals. Everyone has their own merits and demerits. But advantages of fibula flap is it has adequate bone and pedicle length, receptive dental implant placement quality is very high, and also availability of large skin paddle. Other than that, due to, we know that fibula has endosteal and periosteal blood supply, so you can do segmental osteotomy so that you can shape the straight fibula into the shape of the mandible. So I am going to present the challenges we faced in mandibular reconstruction. What are the challenges? Normally when fibula excised, it is normally leads to three types of defect. One is simple defect, where only bone is excised. Second is compound defect, when along with bone you have to excise the mucosa or skin. And when it involves the both skin and mucosa along with the bone, it is called composite defect. So when it involves the central part of the mandible with composite defect or lateral composite defect, or it is a recurrent case where there is absence of vessels on the operated side, or when it is a complete mandibular reconstruction, along with mandible, if it involves the tongue, or post-CTRT cases. These are the challenges we face. So planning is very, very important in this case. What are the planning? Before harvesting the fibula, you have to know which side of the leg you have to harvest the bone. along with how much skin paddle you require for lining, for cover, and the exact pedicle length. Otherwise, you have to use vein graft if you don't calculate the length, pedicle length, and exact site of deepthelialization, site of osteotomy, and which donor vessels you can use. So to know this, you have to know what is posterior anastomosis, what is anterior anastomosis. When the vessel passes posterior to the fibula, it is called posterior anastomosis. When it passes anteriorly, it is called anterior anastomosis. Why it is important? Suppose a defect is on the right side of the cheek, you want to do posterior anastomosis, then you have to take the left side leg fibula because it will act as a lining. If you want to cover the defect, if the defect is mainly outer skin, then you have to take the fibula from the same side leg. So I am presenting some cases. This is a case where there is a central part of the mandible is involved along with mucosa and outer skin. You can see the tumor is mainly, though it involves the central part of the chin, it mainly extends on the right side, leading to huge outer skin defect and inner lining defect. But luckily the lip area is spared in this case. So for planning, because the tumor is mainly on the right side, so left side leg is used to harvest the skin flap, fibula flap, and exact how much lining is required. This part is used for lining. This middle area is used for deepthelialization, and this is the outer skin defect. And why I said fibula is required for central mandibular reconstruction, because it you have to tie the base of the tongue to the fibula and also strap muscles to hitch the fibula. It will prevent tongue fall along with aspiration. And this is the immediate and late post-op picture of the patient. You can see such a large defect can be covered by only single flap. This is another case. This is a recurrent case. Patient was previously operated on the left side. Now patient presented with complete mandibular involvement and also skin involvement. Only right side ramus is spared in this case because patient was previously operated on the left side. So right side vessels were used in the anastomosis. This is the skin paddle taken in this case along with osteotomy, multiple osteotomy, and this is the immediate and a late post-op picture of the patient. Again, when it involves the tongue along with the fibula, this is a case where segmental mandibulectomy done along with hemiglossectomy, and the patient was previously operated, so left side vessels are not available. In this case, right side vessels were used. So this is the skin paddle used in this case. This part is used for lining the buccal mucosa. This is for tongue, and soleus muscle was taken along with the fibula to increase the bulk of the tongue. This is how the vessel, this is the soleus muscle, how it gets blood supply from the peroneal vessel. And this is the immediate post-op picture. You can see the bulk of the tongue is very good in this case. And this is again another case where mainly the defect is outer skin along with a small lining defect. So here except longitudinal, the horizontally raised skin was used because the defect is mainly on the outer skin. So same side leg is used because it will act as a lining, a cover. This is immediate post-op picture of the patient. Again, this is another case where the inner lining is larger than outer cover. So posterior anastomosis along with opposite side leg is used. And this is what I said, this is called posterior anastomosis because the vessel passes posteriorly. And this is the immediate and the late post-op picture of the patient. When it involves the angle of the mandible, you can plan that such a way that the fibula can be harvested proximally so that distal skin can be used by deepthelialization to create the commissure. This is how this is used as a commissure, and the distal skin can be used to cover the defect. Sometimes when the lateral part of the mandible is involved and the defect does not involve the commissure, so in those cases, you can plan such that two skin paddles can be used. One, and we can split the vessel the skin paddle so that one part can be used for lining cover and another part can be used for lining. This is how we split the skin paddle. This part is used as a lining and this outer part is used as cover. And this is the post-op picture of the patient. And sometimes when the defect is very large, you cannot cover it with a single flap. In those cases, regional flaps can be used. Either you can use deltopectoral flap as it is used in this case, or you can use, this is another case where you can use pectoralis major myocutaneous flap. In a DP flap, you have to use two-stage procedure. After 21 days, you have to detach the flap. But when you use PMMC, it is a single-stage procedure. But you have to take care of one thing, that you can anastomose the vessels on the opposite side, so that when you use the PMMC flap, suppose re-exploration is required, then you can explore the opposite side. Otherwise, it will be difficult when you use the same side vessel in case of PMMC flap. Thank you.
Well, Rashmi, this is a very versatile osteocutaneous flap.
Sir.
So, I will ask you a little difficult, not difficult, but little tricky question. What differences you make in a public or in a private hospital when you do this reconstruction? Could you follow my point?
No, sir.
In a public hospital, in a government setup, or in a private setup, what is the difference you find in doing this flap?
No difference, sir. Disease is same, treatment is same, so forum cannot change the pattern of treatment. Though privately cost will...
This is ideal of talking. We sometimes talk very ideal, no? But in reality, the reality is, in government setup, you have to do a lot of planning. You have to be a good anesthesiologist, you have to do good planning on the case, repeatedly you have to see the patient. All these things has to be done. Because I realize it's not that easy in a government system. So the number of cases must have been in outside than in the government system. Well, how can you use this as a chimeric flap? You understand what is chimeric flap?
Yes.
So how can you use this osteocutaneous flap as a chimeric flap?
I have seen one case where I used soleus muscle along with fibula flap. That can be used as a chimeric flap. Or when you require more bulk, you can use whole of the soleus muscle in those cases also.
Okay.
I think we want questions from the audience.
Do you mark the perforators preoperatively or
Yes,
is
yes,
it intraoperative
preoperatively when you plan such a large defect preoperatively with a handheld Doppler, it will help in marking those perforators, and you can know exactly how much of where you have to do osteotomy and where how much skin can be used for lining and cover.
When you do multiple skin paddles, so is it an intraoperative decision or you plan it preoperatively?
If you have to split the flap skin paddle, then you have to plan it preoperatively. But if you want to use deepthelialization, so what you can do, you can take the maximum perforators possible along with this muscle, soleus muscle, that can include musculocutaneous perforator to the skin paddle. So that increase the angiosomes more to the distal skin.
Well, I hope a dental surgeon should be involved in your planning. If you want to do a dental afterwards or reconstructions for the
Yes,
dental part
post-op.
of it. I think they should have been involved in these cases.
Yes.
And CAD and CAM technology with AI, which is coming up, it should be also involved to get a better result.
Thank you, Rasmi, for a wonderful presentation.
Now I welcome Dr. Shantanu Subha. He will be presenting a case report He's an associate professor in AIMS. He will be presenting a case report on augmentation rhinoplasty on binder syndrome.
এই কোথায়? Morning, respected chairperson and my seniors and my colleagues. Today I am going to talk about a rhinoplasty in a binder syndrome. With the patient's consent, we are going to present this case. It's a case report. This is a 22-year-old female patient presented to us with a depressed nasal bridge and wide nasal base, alar base, and with a retruded mid face. So this is the planning. You can see that we have measured, and this is what we are planning. This is a 3D reconstruction, 3D CT, where you can see that we have planned here as a this augmentation of piriformis and the osteotomy. This is what we have done an open rhinoplasty with a transcolumnar and infracartilaginous incision, and to augment the piriform, we gave an upper gingivobuccal sulcus incision, and then we harvested a rib from right side of the costal cartilage, and then we have made those ribs into slices and augmented. While exploration, there was there was a no septum or remnant of septum. So what we did, we put an we did an bilateral spreader graft, and then with the caudal extension and this caudal septal strut, and then augmented the dorsum of the nose with an onlay cartilage graft over the dorsum, and then we gave an horseshoe-shaped cartilage through the upper gingivobuccal sulcus bilaterally, and then we closed the wound. I have got a video, you can see. Sorry, the video is not playing. This is the what post-op period, preoperative and immediate post-op. As you can see that the nose has been elevated, and the dorsum of the nose is become in the midline, and it is quite basal vision is also very good. The septum looks good. You can see that this is the post-op period, and this is the pre-op, where you can see this is a depressed nasal bridge, and this is how the basal nose is there. And the patient is also very happy, and this is the video. You can see now constructed this corrected nose, and that's it. This is our team. We are going to have a live workshop on coming 7th of February, 7th to 9th. So we invite every of you to get registered and come to our cartilage workshop. Thank you.
This is a rare entity. Dr. Shubha,
Yes,
how
sir.
many cases have been reported in the literature?
Literature, I don't know, but I did, it's a very difficult and in the same, I didn't find any this thing letter where the upper GBS buccal sulcus as well as the augmentation of the pyriform is being done in a rhino. So that's why I'm
No, that will
reporting
give,
this
because
one.
it has to be published in the paper, and you get a better impact factor if you are showing us something rarest of the rare. Thank you very
sir.
much.
Thank you, sir.
Dr. Suba, one more question. Usually binder syndrome, some patients have both nasal and maxillary hypoplasia. Can we do maxillary advancement along with the same procedure of rhinoplasty, or it can be postponed to a later date?
I believe, sir, first we should be do the floor first, the base work first. So to do a rhinoplasty, good base is needed. So that's why the osteotomy and advancement should be done prior to the rhinoplasty to get a good result. Simultaneously, it will be very difficult to assess and adjust. So it is better to do an osteotomy first and then settle the tissues and all that, and then you decide what sort of rhinoplasty you want to go ahead with.
The framework should be constructed first.
Yes. Yes.
Thank you. Any more questions from the audience?
Sir.
What about the skin if it falls out over the columnar region?
Sir, we should not be very optimistic to give a very high and tall, sharp tip and all that. So there should not be any stretch in the transcolumnar incision and all that. If at all, so then we can have a bit advancement, like a VY advancement from the columnar or the skin to the columnar.
Thank you.
Thank you, sir. Yes, here in this case the occlusion, even in the binders, the occlusion might be same, but in hypoplastic this thing, mid face, you may require the advancement of the mid face. So that is the thing. And to augment with the cartilage, with the bone, again with the prosthesis also you can augment the pyriform if you want to do an onlay augmentation. We did a cartilaginous augmentation by putting a bilateral horseshoe-shaped cartilage bilaterally in the pyriform by the upper gingival sulcus incision. Dice cartilage, you'll have to wrap it with some fascia and all that, and it never gives toughness. What you can see that here in my presentation, I have fixed the cartilage and those cartilage through the transcutaneous suturing. So that is how you can fix it for 3 weeks and later on it fixes by itself. But in case of dice cartilage with a wrapping, it may migrate somewhere or it may, shape may be altered. So it is better to give an, I believe it is better to give an sliced onlay cartilage graft.
Thank you, Dr. Suba.
If there is time, can I put a question?
Yes, sir.
Please, sir.
Since there is time. Okay, Dr. Suba,
Sir.
excellent presentation, very rare cases. Even though I had the fortune of doing couple of cases when I started my practice.
Yes, sir.
So, basically it is a deficiency of the base of the nose.
Yes, sir.
So you have tried to put skin, bone graft on it. And you also said that columnar lengthening is essential. So why not think about the standard procedure of columnar lengthening by Cronin's technique that we do in bilateral cleft lip and palate?
Sir, Cronin's technique in primary rhinoplasty, as the columella is well developed here, so you may not require to recruit the skin more by doing a bilateral Cronin incision and recruiting the skin into the columella. If you are doing so, then columella will be widen up and might looks bad. So it is better to keep the columella skin into the columella and the lip skin into the lip to give a good harmony and the aesthetic results.
Okay. Dr. Suba, one last question. So, in any, have you ever encountered any case of loss of columella due to binders or that is atrophic rhinitis?
Sir,
No.
binders में तो नहीं मिला, but yes, we have seen a lot of infants having an this columella loss, this thing, loss of columella.
It's a beautiful presentation. Thank you, Dr. Suba.
Thank you, sir.
So our next speaker is Dr. Prashant Bal, Assistant Professor from Acharya Harihara Postgraduate Institute of Oncology. And his topic of presentation is Tricks and Innovation in Wide Cleft Palate Repair. Welcome, Dr. Prashant.
Respected Chairperson Dr. Chaudhary sir, Singh sir, Devi bhai, and my teachers and seniors and my juniors. Now I am going to present some tricks and innovations in wide cleft palate repair. Actually, I have chosen this topic because nowadays clefts are only restricted to smile trend setups and some German cleft and other things. And most of the teaching hospitals are lagging these cases. So students are also not getting ample of opportunity to learn these clefts. Yes, next. Nasal layer closure in wide cleft palate is a challenge for surgeons. During that, most of the difficult part is radical dissection of levator belly palate muscle and mobilization of either release of tensor belly palate or mobilization of lateral pharyngeal wall and lateral nasal wall for tension-free closure of the nasal layer. Next. Yes, these are different tricks for nasal layer closure of the wide cleft palate. First is skeletonization of the greater palatine artery. So it allows medial mobilization of mucoperiosteal flap. In proper intravelar veloplasty means proper horizontalization of the levator belly sling, mostly placed posteriorly, and release of tensor belly palate so that it releases tensor over soft palate and allows medial mobilization of the nasal layer and mobilization of nasal wall and pharyngeal wall for closure of very wide cleft palates. Use of sometimes myomucosal buccal flaps are used for closure of cleft palates. Next. This is skeletonization of greater palatine artery. After lateral release incision, we will dissect and see the greater palatine artery and give a gradual, steady traction just posterior to the greater palatine so that it will release and skeletonization of greater palatine artery will be there and we will get some length and it will allow us free movement of mucoperiosteal flap medially and sometimes additional perivascular tetherings can be dissected with scissors. Advantage is allows complete medial movement of the mucoperiosteal flaps, but jerky movement at the release is not allowed because it may sometimes injure the greater palatine artery. We have not encountered, but I have seen one case of greater palatine artery injury by other surgeon. Okay, next. History. Sometimes previously some surgeons used to do widening of the greater palatine foramen in order to get the extra length of greater palatine artery so that medial mobilization of mucoperiosteal flap can be possible. But nowadays it is not done because in order to avoid midfacial bony growth. Next. Here you can see we have clearly dissected, we are giving gentle gradual traction posterior to the greater palatine artery. It allows medial mobilization of mucoperiosteal flap. Next. Yes, I have put a background behind the greater palatine artery. You can clearly see greater palatine artery. Next. Yes, intravelar veloplasty. Radical dissection of levator veli palati, which is usually oriented vertically along the cleft margin, and we have to dissect it properly and place horizontally, mostly in posterior part of the soft palate, so that it will have a better speech in future, and also it will immediately allows tensor-free closure of the soft palate, and it will avoid some fistula in the mainly in posterior part of the palate. Next. You can see this is we used to give a continuous suture in nasal layer. Here you can see yes, but in book it is written interrupted suture with the placement of not in the posterior aspect, but I have done around 2,000 palate cases, and my mentor Vibhuti Naik also done around 7,000-8,000 of palate. He is also doing a continuous suture. We have learned it from sir, and we have not encountered any problem in dealing with these cases. Next. Here I have dissected left levator veli palati muscle. Next. And I have placed this levator veli, just showing it complete horizontalization of left levator veli palati. Next. After proper intravelar veloplasty, you can see the levator sling is lying posteriorly, and it is in the straight line, with means horizontally it is placed. And there is a classification of intravelar veloplasty is there. Means this is a proper one. Sometimes they also used to do levator just like a obliquely. So that is not a proper intravelar veloplasty. That will not allow proper mobilization of subpalate. Next. Next. Release of tensor veli palati. This is a very important step in case of wide cleft, because tensor veli palati release allows, normally tensor veli arises from scaphoid bone, and it hooks around, hook up a hamate, and gives tension to the soft palate, and also help in closure of eustachian tube. But release of tensor veli palati allows release of tensor over soft palate and medial mobilization. Previously, hook up hamulus was break by some surgeons in history, but nowadays it is avoided to prevent midfacial hypoplasia. Next. Here you can see that tense glistening tensor veli palati muscle I am holding, and I am releasing it. In another video it is clearly done. Next. Yes, you can see. This is glistening tensor, tense and anteriorly placed. And this is breaking up a hook of hamlet, which allows release of tensor veli palati. But this is not done nowadays because of better anatomical knowledge and skeletonization of greater palatine artery and easily release of tensor veli palati from medial side of the dissection. Next. Yes, you can see. Yes. This is release of tensor veli palati. Next. Yes. Mobilization of lateral pharyngeal wall and lateral nasal wall. This is useful in very large clefts, wide cleft, because of positioning of pharynx this way. If you will release greater palatine artery, lateral pharyngeal wall and lateral nasal wall, it will come this thing at the cost of pharyngeal width. Yes. But advantage is nasal layer closure of very wide cleft palate can be possible, but disadvantage is subperiosteal dissection helps in, leads to hamper in bony growth. Next. 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 Yes. Our innovations. This is published in IJPS and mucoperiosteal flip-flop for closure of anterior part of U-shaped secondary cleft palates. Similarly, distal-based mucoperiosteal flap mainly is flipped for the anterior U-shaped portion of the cleft closure. Next. This is a U-shaped cleft palate. Next. You can see the anterior portion flap is marked and this is flipped so that easy closure of the anterior portion of the U-shaped cleft palate can be possible. This is post-op geometry. Next. This is marking of the anterior portion of the wide cleft. Next. Yes. You can see flipping of the mucoperiosteal flap based anteriorly. Okay. Next. Yes. After closure of nasal layer, you can see this U-shaped flap is flipped and used for closure of tension-free closure of the anterior portion of the U-shaped cleft palate. Next. This is post-op picture. Okay. And another innovation. This is bipedical medial nasal mucosal flap. Another option for closure of very wide cleft palate. Next. This is geometry of bipedical flap. Next. Yes. After adequate infiltration of adrenaline and proper dissection of the mucoperiosteal, elevation of mucoperiosteal flaps. Just one.
Yeah, just
Yes.
speed up.
Yes. Radical dissection of levator veli palate is done and 1.5 centimeter wide medial nasal mucosal flap created by giving releasing incision parallel to the cleft margin and whose anterior posterior extension depends upon easy closure of the medial midline closure of the soft palate. Next. Next. Yes, you can see here releasing incision is given so that defect will be lying somewhat lateral to the midline. Next. Next. Yes. And next. And this will lead to so that a defect will means releasing defect will be lying just lateral to midline, so that superimposition of the defect will be not there, so that fistula rate will be less in this in this case in very wide cleft palate. Next. Our procedure avoids lateral nasal wall and pharyngeal wall defect mobilization, so that mid-face bony growth will be not hampered, and less chance of junctional fistula is there because of non-superimposition of defect in midline and lateral releasing defects. Next. Yes. Above tricks and innovations are very useful for wide cleft palate repair. Combination of 2-3 procedures are required in a case, but surgeons with mastery in different tricks will not face difficulty in closure of wide cleft palates. Thanks.
May I request our President APHI, Dr. Shubhat Singh, because he has a vast knowledge, not only experience of handling such varieties of patients. So I think the whole audience can have a glimpse of your experience.
Excellent presentation with a great experience that your team has. So any surgeon who does a lot of clefts encounters these problems and develops some tricks. So over the years, over the last 32 years that I've been practicing clefts, so I have experience, I've tried many techniques developed by others, and I've developed some of my own. So some of those techniques are similar to what you have said, but something like enlarging the greater palatine foramina and trying to tease it out, this should never be done. I mean, I've done it so many times, right? So this is something that you should never do. One thing that he has done, a teaching and skeletalization of the greater palatine artery, that is the best technique that every cleft surgeon should learn. And as is shown, I will just demonstrate. So if this is the greater palatine artery, you have to go from medially and laterally. Yes. You have to go behind it with a straight dissector. You have to do the gentle persuasive strokes because the artery is on the underside of the mucoperiosteal flap and it is lying like this. So you have to go into that with a gentle, I call it gentle persuasive stroke. Gently, little by little, you have to elongate it. This is one technique that you learn. No cleft will ever be wide for you. And I mean, many surgeons do, but I do not particularly either break the hook of humulus, which we learned as residents, to make a green stick fracture. And I also do not tease off the tensor palatini because it is a functional muscle there and will give rise to more otitis media and other problems. So, but this was an excellent presentation. Many techniques were used. And as for the U-shaped flap, U-shaped cleft is concerned and giving a turnover flap or a flip flap kind of thing. So many of such flap, which we must remember that many of such defects will have a submucous part in the most anterior region. And if you dissect there, you will develop a fistula there. So what I do, if I get a submucous flap, I make it complete till I hit the bone. I never make a U-shaped incision for the submucous flap because I develop many fistula there. So I make it complete as long as it goes till I hit the bone, and then I raise the nasal layers and the mucoperiosteal layers. So, thank you so much.
Sir, yeah. Sometimes also, sir, in U-shaped palate, Langenbeck is not possible. One side elevation is required.
If the cleft is wide and difficult, Langenbeck should be avoided, yes. Right? You should do a two flap, yes. Right? So the exposure will be better. You will be able to do a better muscle dissection and avoid Langenbeck because it will restrict you and you will struggle. So I always do that. I always avoid that. So
sir, combination, one side attached, another
what I do particularly is if there is a wide flap, I go on an oral side. I will take 2 or 3 millimeter and slowly dissect it, tease it off, add it with the nasal layer so that nasal layer closes in midline without any tension. It is extremely important to close the nasal line without any tension. Oral line, flaps, you will anyway can close without any tension if you can do that gentle persuasive stroke to lengthen the greater palatine pedicle.
Thank you very much.
Can I have a small little intervention here, Dr. Subodh and Dr. Prasant? Interesting presentation. But do you really have to push hemulotomy to history at this point of time?
It is history, and for me, it is history. I do not disregard the surgeons who developed it and who continue to do this, but just for one reason I can say this should be history, that it is not required in any kind of cleft palate repair. But with the habit that we have developed, many people continue to do that, and they get good result, of course. The results are not a problem because we are not following up. These patients are not doing comparative studies on speech as well as otitis media development. So we do not know what is happening, but we certainly get good result, tension-free sutures in the midline when we break the hook of humulus.
Well, Subrat, yeah.
My question is, I have seen that your nasal layer, you are repairing in the continuous.
Yes.
But mostly if one somewhere it will break, means whole of this one will
Yes, sir.
break.
But
I think better option will be the interrupted.
But, sir, continue. It is in book. It is written that interrupted suture is ideal. But as my mentor and I am using this thing for last 10 years, and also encountering no problem because we are dissecting levator veli palati muscle 2-3 millimeter away from midline. So we are careful and we are not injuring sutures so that no opening is there.
Yes, yes. On interrupted sutures and continuous sutures, so I have also repaired thousands of palate with continuous sutures. So I give one or two more knots in the entire distance, and in palate, I mean whether you're giving an interrupted or continuous with interrupted, you must put at least 6 knots if you're using Vicryl. So giving 3 or 4 knots, it is likely to open. So give multiple knots. So nasal layer can be done safely with the continuous sutures.
Sir, it also
No, no locking. But I tie sutures like in 2 or 3 places, right? So just a little bit of continuous, then a knot, and again continuous, then a knot.
continuous interrupted.
And uvula, always interrupted. So never, I mean, I fall short about 1.5 centimeters from the uvula and then continuous sutures.
Otherwise, it will retract.
Yeah, it will give a good shape, otherwise it will retract.
Sir, we are not giving continuous suture in uvula portion. We are giving around 3 to 5 suture interruptedly in uvula so that it will not have a traction effect.
Yeah, that's what I
Anterior.
said,
Yes.
yeah.
Yes.
So what we really do in practice, Prashant, you must have seen. So I started a bit early than you. So we do a continuous in between couple of interrupted sutures. I think that is the best, no fighting, okay? So coming to the hamulotomy thing, we recently concluded a project, a fellowship by oral and maxillofacial surgeons, is impedance audiometry before, with and without hamulotomy. Dr. Ruchi Gupta was the mentor of this work. So we noticed that in about how many cases? Can you just tell about this? Because this is for the knowledge of all our people. If something goes wrong with hamulotomy.
Sir, thank you, sir. So recently we had a pilot study of 20 patients, of which we had done that if the gap is wider than 1.5, then we will not do, we will do the hamulotomy. Otherwise, we were not doing the hamulotomy. And we saw the effect of it by audiometry on the pressure in the eustachian tube. So we found that there was not much significantly difference in the pressure of the following the hamulotomy or no hamulotomy. I feel that by hamulotomy, we can bring down the nasal layer more to the medially, and there is much more tension-free closure. So we can be more comfortable with this thing following hamulotomy. I have also learned cleft palate from Dr. Jana, and we have been practicing it till now. And I see the cases because my other counterpart, she is not doing the hamulotomies. But I feel that we get more tension-free closure once we do the hamulotomy and we bring out the nasal layer from the lateral wall. And another thing is, I feel that the pharyngeal space is also decreased.
Excuse me.
By doing that.
Dr. Ruchi madam. Sorry to interrupt. But again, for the sake of completion of the discussion, I would like to know from Professor Dr. Subodh Singh sir.
What is your comment on it, sir?
Just okay, ma'am. He will give answer to both my question and yours. It's regarding continuous and interrupted sutures. Sir, what is your experience? Suppose there is a nasal layer breach. There is a rent. You cannot close it. but the robust mucoperiosteal flap can close it. So have you ever noticed fistulas in those cases? If at all you have encountered those.
First, interrupted and continuous. And as Dr. Jena said, continuous with interruption in between. So that's what I do now. And if there is a rent, I will not be happy just covering it with the mucoperiosteal flap in the hard palate area. In the soft palate area, I don't mind. In the soft palate area, if there is a breach anywhere in the nasal layer, I don't mind, right? But in a hard palate area, if there is a breach, right, I would first try to close it somehow. Sometimes from the margin of the hard palatine bone on the medial side, there is a rent while you're dissecting. What I will do, I will take a 20 gauge needle, make a hole in the hard palate and take a suture. But I will make all the efforts to close any rent in the hard palate area, right? So in the nasal layer I'm talking about, right? So if that is not possible, I will go ahead and take a bucco-myomucosal flap to close that defect, right? But I will not leave it as such, because if you leave a defect in the nasal layer there, the fistula will be very common in that area.
I think Subodh, it is welcome during your leisure times. You can take advantage having questions from you. We go ahead. Thank you, Dr. Bala.
Thank you, Prashant, for an excellent presentation. Actually, we are running short of time, so please request the participants to finish in time. Next, I would like to invite Dr. Bhartendu sir. He is the founder of Akara Asha Hospital in Hyderabad. Sir is going to present a topic on opercular approach to the reconstruction after orbital exenteration for mucormycosis. Welcome, sir.
So, this presentation is all about post-mucor reconstruction of the orbit and how we have gravitated from complex to simpler approaches. I think, how do I do this? Yeah. So, different etiologies, but this presentation is all about mucor. You know that, almost 28,000 plus cases of mucor reported in 2021 by the Ministry of Health. And most of them had a COVID-19 history and diabetes. So this is a typically opthal point of view, bony loss in post-mucor reconstruction. So type 1, 2, and 4 are typically covered by what I call the orbicular approach. So you got to look at the orbital mucosa, the eyelids, communication with nasal and oral cavity, and periorbital scarring. Evaluation, basic evaluation, look for residual disease. We normally look at a 6-month period between the last posaconazole dosage and the surgical intervention. Any barrier needs. So I think very important to separate oral and nasal cavities. And we need to look at the orbit itself, soft tissues around the orbit. Now when we consider doing any treatment, we need to look at the forehead, cheek, temporalis, superficial temporal vessels, and palate, tongue and cheek mucosa. Many times there's a facial palsy and a trigeminal nerve palsy because it's a nerve avid fungus. So we got to look out for that. Cheek defects and cranial base defects, they can actually complicate the picture. So the options are loco-regional flaps, free tissue transfers, and implants. These facial-maxillary surgeons are very keen to put in implants and without an understanding of lining and cover, and we land up in problems trying to sort them out. So basic principles, we shouldn't have any residual disease, adequate tissue clearance. There should be a separation between oral and nasal cavities. Most importantly, bilaminar. So there are two approaches. Basic approach is plug the orbital cavity. How we evolved is by providing a wall. So this involves inner lining and a cover. And since we have walled off the orbit, it's a large cavity now, comprising orbit, nasal cavity, and antrum. So it's a one big space. So post-operative surveillance sometimes is necessary because of crusting. We do nasendoscopy. And we retain the options of either bone-anchored or external prosthesis. This is the first case done. I think Amrish will remember this. We had a workshop in November 2021, and we did this anterolateral thigh flap, and looks very nice, but post-operatively this is what happened. And this was a lesson for us that we shouldn't step in too early, because COVID-19 thrombotic post-operative episodes do happen. And the next case again, you succumb to the temptation of doing both the palate and the orbit at the same time. Here's a case. And so we did a gracilis, very sleek gracilis flap, broke it up into 3 segments, and looks nice intraoperatively, post-operatively, edema. And you can see that we lost a bit of the external, how do I focus this? A bit of the external paddle, and then, did a rhomboid flap, and there she is on her way to healing. But all this taught us, that we should not do this. We should separate the two, the palatal reconstruction and the orbit reconstruction. So I'll just give you one by one how we proceeded. Initially, I looked at just filling up the orbital cavity, slapping on a radial forearm flap, trisegmental, looking at the septum as well. And then I changed. So initially, take a nasolabial flap for lining, and take a good, well-mobilized nasolabial flap, forehead flap for lining and nasolabial flap for cover. And then started looking at other ways. Initially planned the same way, but we could mobilize the orbital mucoperiosteum to form a lining, and swung I initially planned for a nasolabial, but after mobilization, it became a cheek flap. Same thing we kept doing, and here I encountered the orbit doesn't have a major outlet. So if I do a hinge flap, the secretions from the mucosa would accumulate. So I had to revise my strategy, knock off the orbital mucosa, do a turnover deepithelialized nasolabial flap, and lateral cheek mobilized to cover. This is another case with a facial and trigeminal palsy, where we used a lateral arm, and in the second stage split the flap, mobilized the medial canthus, and then we actually came down to a simplistic rendition of orbital reconstruction, where we do a orbital hinge flap and nasolabial advancement. And this is 1.5 years later. He's gone back to farming. Yet another case, clearly visible how we mobilize. And again, about a year later, he's a priest, works at Shirdi Sai temple. And you can follow up. You can see that the top layer, that region is completely healed nicely. That is the hinge flap, the mucosal aspect of it. And now, sometimes you have little things on the way where the eyelids are present. What do you do? So we did a forehead flap for lining, and I moved the nasolabial under the lower eyelid and deepithelialized that segment. This is a case which we did recently. So to summarize, if you have a blind orbit, simple orbicular approach, even if you have a nasoantral fistula and orbital, one of the caveats in anesthesia is you have to plug the orbit. Otherwise, the gas will escape, so you got to plug the orbit during the intubation process. And if you have intact eyelids, you can do the same. So this is what happens. There's a celebrity occupant of an orbit which has left. So what do? Create a wall so that you can hang a picture. Thank you.
So just a small comment, just an excellent presentation. This presentation clearly shows that complex problems often have simple answers. So we should think of all the local and loco-regional reconstruction possibilities before we embark upon the more complex reconstruction procedures. Thank you.
Thanks.
Okay, it is always the old wine in new bottle. I don't think old should be taken off from our market of having the reconstructions. So even the old methods can be practiced, as he has shown, that it can be practiced in cases. So not necessarily the recent and the best method is the recent ones. So thank you very much, Dr. Swami, for a nice presentation. I have a question from Dr. Baliar Singh.
Sir, excuse me. See, the orbit problems, actually not one. So often what happens is, we will have an opening to the nasal cavity and the antrum, and also sometimes if it is too much, then the palate will go. So if you understand the logic, so antrum we can't fill with a flap, because you have to find a way to drain the antrum to the nasal cavity, and sometimes also you have to isolate the oral cavity. And on the way that if it is not done, then the problems will continue. Discharge, everything will continue, and there will be again fistulae will continue. And failure of the flap, I agree. That could be a technical failure, because we all have failure. So if I say that I do 100% foolproof technique, I don't think that is correct. So, and second thing is, often what flap we choose, that also is important, because sometimes it's a very small area. So you have to use a thinner flap. So that is because many times if you do an interlateral thigh flap, say for the orbit and all, for a young thin boy, maybe it may work well, but not for a very thick boy, because flaps are thick, and many times when we are adjusting these flaps, probably the perforators to the skin, they are getting compressed and having necrosis. That part also should be looked into. And local flaps, I don't deny, they are there, but they are standbys. Because if we do a free flap, only scar you have is around the orbit where the flap is inset, not anywhere in the face. And if you do any other flap, that will have a scar over the forehead, scar over the face, I think that should be avoided. If somebody is there to do a reconstructive, reconstruction with a good understanding of microsurgery, I think that should be attempted. If it fails, then local flaps, whatever can be done, probably. That will be my approach for all this kind. Thank you.
Thank you.
Thank you very much for your feedback, Dr. Baliar Singh. Now I call upon Professor Dr. Amresh Baliar Singh. He is very close to our heart, and he almost travels so many times to Orissa, and every time he contributes some of his experience and knowledge to our young plastic surgeons. So nevertheless, this time also he will be giving a very good lecture for us. So Dr. Baliar Singh, it is your platform.
Thank you very much, sir, for kind introduction. Respected chairpersons and distinguished delegates, I shall be talking about aesthetic consideration in head and neck reconstruction. So slide on. Anatomy is complex. If you look at it, naturally thickness and the shape of the bone and the soft tissue vary in different areas. And skeletal framework, they provide stability to soft tissues. And also if it is excision is done, if you can preserve soft tissues, they will retain function and also will retain external appearance. And in excision will involve soft tissues, bone and soft tissues, and also the extent of deformity will depend what is excised, how much is excised, and what regions are excised. And why it is important is because anticipating deformity following treatment is distressing and causes anxiety. And also this disfigurement and dysfunction associated with treatment will always affect quality of life. And with reconstructive surgery, you can minimize the deformities. And initially what happened is when the consideration is given for reconstruction, we consider two things, cover and the retention of the function. And the aesthetic appearance is given a backseat. And always when you do, primary reconstruction is better because the tissues are soft and pliable, and avoid secondary reconstruction because the tissues are contracted and dissection of the recipient vessels are difficult, and overall outcome also is difficult and also compromised. And when we do reconstruction, we can't avoid scar or deformity, but what we should attempt is to reduce the severity so that it becomes less noticeable, because you can't avoid, but you have to make it less noticeable as possible. And these are many studies done, they said that deformity affects quality of life, and it is almost like goes to number 1 or number 2 thing which affect the quality of life after the operation. So naturally aesthetic deformity no patient will accept, and we should attempt whatever way to reduce the deformity. And naturally these are the causes like loss of skeleton, then the long incisions, whatever is excised, where it is excised, and also if the external skin is excised, there will be color mismatch and there will be definitely deformities. And if there is more than one aesthetic unit is excised, deformity again will be much more. And as I had told you, soft tissues, they are mainly used for mucosal cover or the skin defect. Sometimes also this can be used for contour correction, as you will see in my subsequent presentations. And the region like malar region, temporal, and malar parotid mastoid area, these are the areas where the deformity will be much more seen than other areas. And of course in the lymph node dissection also will cause depletion in the neck. And with understanding of the flap physiology and anatomy, many structures can be incorporated like bone, skin, fat, fascia, muscle, so that it can be used as a component wise for the reconstruction. You can see that soft tissues you can do either with bone like DCIA flap or fibula, or even that is scapula flap also can be used. And in the muscle also you can see that you can take muscle, you can take a skin paddle, you can take even the skin paddle also you can take depithelize it, and also you can incorporate fat and fascia to cover up different areas. And as a reconstructive surgeon, one must understand is anatomy and physiology of the head and neck, and also aesthetics he must understand, and the disease, the type of disease that leads to this kind of defect, and also the vascular anatomy and type of flaps available for the reconstruction, and also to choose an appropriate technique for reconstruction, because there are techniques are many, but you have to choose what is the most appropriate. And there are various flaps like radial artery, which is a thin flap, anterolateral thigh flap, medial sural artery perforator flap, or lateral arm flap, which are thick, And you can also use a bone flap like fibula, scapula or DCIA, and also muscles like lat dorsi or gracilis also can be used for reconstruction. And coming to buccal mucosa defect, this patient had carcinoma of the left cheek, only had a wide excision of buccal mucosa and marginal mandibulectomy, and you had reconstruction done with radial artery forearm flap. So you can see that mucosa excision, minimum bulk, radial artery suited well, but most important what he was done is, he doesn't have any scar over the face. It was excised with any incision on the face. Naturally the aesthetics are better maintained. If you can avoid a incision, that is always better. And coming to this patient which had a bite excision, that is maxillary alveolectomy and hemimandibulectomy, and also part of the mucosa of the lip was also excised. You can see that various components you have used. We have used a fat fossa flap for the mandibular defect, and also used part of the flap for the filling the mastoid area defect, and also lip mucosa was covered also with the part of the flap. And these are the intraoperative appearance of the patient. You can see that after radiotherapy, more or less patient has a good contour, but with gravity you can't help. You can see that some of this flap sags down, but if you can hitch it, the fossa with higher up, naturally the sagging is little less. And coming to, see, this patient was reconstructed with folded radial artery forearm flap. You can see that on the left side of the picture there is a depression because there was volume replacement was low. On the right, because with correct amount of volume replacement, it looks as a patch, but the appearance is much better, deformity is less noticeable. So naturally in reconstruction you have to fill up adequate volume. And sometimes with the excision of the bone, we also excise lot of soft tissues like lymph node dissection, that also need to be filled. And this is a patient with bite excision, that is maxillary alveolectomy, hemimandibulectomy, and also full thickness cheek. What you had done is, you had used a folded anterolateral thigh flap for the skin and mucosa cover, and also used the deflexurized terminal part of the flap to fill up the neck area to give a good contour. The bottom right picture shows fullness over the cheek area and also in the neck area. And in coming to mandible reconstruction, there could be bone, there could be mucosa, and mucosa with the skin also. And always we try to get a good contour, achieve good alveolar height. And this is a patient, secondary mandible reconstruction done with fibula flap. It's a hemimandible defect. And we had used a model to contour the reconstruction plate. These are the intraoperative picture, contouring of the bone is seen, and this is the postoperative appearance. I always use a reconstruction plate because I feel that contouring the reconstruction plate gives a precise shape. And this is the patient with middle third ameloblastoma. We had done it without giving external incision, because external incision will again aid to deformity. This is the pre-op picture and also the X-rays and excised specimen. We had done double barrel reconstruction, 3 segments for the upper barrel and 3 segments for the lower part, and this is how it was fixed and shows good alveolar healing. And this is following dental OPG following dental rehabilitation. These are the following dental rehabilitation, prosthetic teeth and the lower jaw. This is the post-operative appearance. You can see that symmetry is well maintained of the lower third of the face, and also it could be done because the only scar he had is for the vascular anastomosis, about a 2.5 centimeter. And this is another patient. You can use sometimes technology to your advantage to give a precise shape. This patient had an ameloblastoma of the right body and the ramus area. So you had to use CAD-CAM technology to prepare and cutting guides to excise and also to plan the fibula segments, osteotomies, and these are how it was placed. These are the digital images, okay? And this is how it was intraoperative picture, how it was performed, and This is the post-operative picture showing OPG and intraoral healing is good, and this is the post-operative appearance. Even you can use technology to your advantage in difficult cases. And now coming to, this was reconstructed with radial artery forearm flap. What I want to show is, you can see that the deformity is seen because he had an external incision. And this patient had to almost near total glossectomy reconstruction done. Though excision and reconstruction was difficult, you can see that post-operative appearance is extremely good for this patient. And coming to mid-face defect, sometimes mid-face defect can be small or large. This patient had adenoid cystic carcinoma and also resulted in excision of the leading to nasal cavity and external skin, and we had used a folded radial artery forearm flap. This is immediate postoperative appearance. You can see that if you can choose a thin flap and also thin it little more, you can get a good appearance. And now coming to maxillary alveolus. So this patient had adenoid cystic carcinoma because of the patient had to undergo postoperative radiotherapy. You had done reconstruction only with skin flap, that is folded anterolateral thigh flap. This is the plan of the operation, and you can see that projection is well maintained because you had used a little extra flap, bigger flap, so projection also is well maintained in this patient. This patient, you had recurrent adenoid cystic carcinoma, you had used osteochondritis fibula flap, though you can see these are the OPG, postoperative OPG and the intraoperative picture, and this is the postoperative appearance. Though it looks good, but if you see at the close view, the Weber-Ferguson incision was taken at the lateral filtral column, which causes the deformity. The incision should be appropriate, that should be in the midline, otherwise it will lead to deformity. And this is a patient with secondary maxillar reconstruction with a DCIA flap. And this is the intraoperative picture, and this is the postoperative OPG. And initially the flap was bulky, we debulked it, and subsequently had dental rehabilitation. And this is the postoperative appearance. But what is you can appreciate is, it is the proper incision is taken through the midline of the philtrum, so that deformity is not seen. Naturally, what you have to do is, you have to take the incision also properly. Many times we modify without understanding why the incision is to be also taken. And this is a patient with lower and upper lip excision. So what you had used is a radial artery forearm flap with extension on both upper and lower lip, because we had appropriately designed the flap. Postoperative appearance is better. It doesn't give a bulge at the angle of the mouth. This is the patient, if you have to construct a part of the aesthetic unit, maybe not be good, appropriate. This patient had entire lip reconstruction. You can see that it is acceptable results. And this patient is hemifacial microsomia, hemifacial atrophy. What you have done is anterolateral thigh fat and fossa flap. And this is subsequently needed liposuction in certain areas and fat grafting around the orbit. And next was rhinoplasty was done. And this is after the rhinoplasty, front views. These are the chin-up view and side views. And this is the patient had secondary mandible reconstruction. So he wanted a volume replacement. So what we have done is, we have done an anterolateral thigh flap to correct the soft tissue loss. And this is the postoperative appearance of the patient. And you can see that best way to avoid deformity is to understand the defect to be reconstructed and what type of flap you use, and appropriately design it, where you need to thick or sometimes you need a thicker flap. And also many times other areas need to be addressed, like mastoid area, this parotid gland areas and maxillary area also need to be filled. That also, and also submandibular area also need to be filled. That also to be taken care of. And also, if you can do a operation reducing a incision or avoiding a incision, it's better. That gives the maximum aesthetic, appearance. And also, not one operation may not be enough. many times ancillary procedures may be needed. And also what we should try is to have, do a reconstruction to provide a better quality of life for the patient. And how can that be possible? So you have to have a good understanding of craniofacial, microsurgery and basic general plastic principles to arrive at a better result. Thank you very much.
Thank you very much for a lucid presentation, Dr. Baliar Singh. I have a simple question because most of us take care of the form and function as well, but the form also includes the aesthetic part. So how do you, when you use so much of flaps of different varieties in the spectrum of reconstruction, how do you make a thinning of these flaps later on for a secondary surgery? Because aesthetic part, sometimes the patient, suppose you take a LT flap, it's a too big flap sometimes in the face. So how do you thin out these flaps or debulk these flaps?
See, we all understand primary thinning is as much possible is done because we know the vasculature of the ALT flap, because the moment the perforator enters, it's like an umbrella, it goes up and all. So naturally keeping the main pedicle up and almost like you can keep the superficial layer of fat, resting can be trimmed off from the flap. But even if it cannot be done, secondarily after the patient, one thing I didn't tell here is, whatever the soft tissue flap is put, it undergoes volume loss by 10 to 15% volume loss happens. And with any patient undergoes radiotherapy, almost up to 35, even 40% volume depletion happens. So initially it may look bulky, but if the patient is undergoing radiotherapy, wait till radiotherapy is over and then wait for another at least a year after completion of the radiotherapy to get the final picture, then you can plan debulking or anything you are planning to do.
So what is the safe period for free flaps when after some period you can be very sure, well, I'm not going to have a complication or problem? I mean, it's 6 months,
flap.
1 year, 2 years. What is your experience? How many years after you can be sure about the microvascular?
Because you all wait. After the completion of the radiotherapy, 1 year to wait. That is safe, unless it is an emergency operation to be done. So I think 1 year is a safe period, but many patients are oncologically tricky, means they may have a chance of recurrence or higher chance of recurrence. For those patients, it is doing secondary surgeries or no, till they cover a longer period of follow-up, maybe 2 years or 4 years at least. Because many patients will have concomitant recurrences. So that should be avoided.
Sir, you do use these reconstruction plates in all the cases, especially post the patients who will undergo post-op radiotherapy versus mini plates, because the hardware, the amount is more in case of reconstruction plates.
There are actually, if you broadly classify, there are 3 types of plate and screws used for reconstruction. One is the mini plate, other is the 2 mm reconstruction plate, and the 2.4 or 2.7 reconstruction thickness reconstruction plate. If I had to do a benign reconstruction, I will use a thicker plate, which is 2.4 or 2.7 mm thick reconstruction plate. That will have a lot of hardware. But if I had any patient undergoing radiotherapy, I use a thinner reconstruction plate, which is 2 mm reconstruction plate. I always use 2 reconstruction plate. I feel for 2 reasons I use. One thing is they provide greater stability, which is essential for healing, and they maintain the shape better than the mini plate. Because mini plate, you are left to your imagination unless you have used CAD-CAM technology. For the mini plate, those fixation with the mini plates. And I feel probably any mandible segment, more than one segment need to be reconstructed, is better to do with a reconstruction plate than mini plate. One segment, one may use mini plates.
Thank you, sir. Thank you very much for your very informative presentation. And I think...
Thank you, sir.
Thank you, sir.
Thank you.
Oh, thank you very much for your patience hearing. And all these speakers, I thank them very much from close from my heart that they have all spoken out, they shared their good knowledge. And obviously, we are in the little late, but I think it is manageable. And we are missing the last speaker. He was our past patient, Dr. Ramesh Das. He would have given a very different out-of-box presentation as he always gives. So thank you very much for your patience hearing, and let's go for the tea, I think.
Thank you, sir.
Good afternoon to everyone present over here. Now we are moving towards to our second session that will be focused on our video presentation. For that, I would like to request Dr. Akshay Raut, Dr. Bishwadit Mishra sir, and Professor Dr. Jayant Kumar Das sir to come to the podium to chair the session. Please, sir.
Good morning, everybody. The session for this topic is Dr. Subodh Singh, Lippert 1 osteotomy and maxillary hypoplasia in cleft lip. Dr. Subodh Singh.
Respected chairpersons and distinguished delegates. So after some of the presentations about cleft lip and palate, and one of the complications of doing cleft surgeries is maxillary hypoplasia. So I will speak on Lippert 1 osteotomy for maxillary hypoplasia in cleft lip and palate. So the maxillary hypoplasia is the most commonly encountered secondary deformity as a result of cleft lip and palate, and reported incidence is between 15 to 50%. It can occur because of the intrinsic factor or developmental deficiencies, or because of the iatrogenic factors like multiple surgeries performed in the cleft lip and palate patients. So it is estimated that around 25% of the patients with unilateral facial clefts have a class 3 malocclusion and mid-face deficiency requiring surgical intervention. And it is the mid-face hypoplasia is almost always a direct consequence of multiple surgeries performed as a staged repair of the cleft lip and palate. And every surgical procedure which is taken up, whether for functional reason or aesthetic reason, creates scar tissue. And the deficiency is not just limited to the maxilla here, but it goes up into the alveolus, but also extends to paranasal, nasal, infraorbital, and other adjacent bone in the entire facial region. So the mandibular growth is often unaffected, and cleft lip and palate patients commonly present with anterior open bite and a steep mandibular plane. The decreased posterior facial height is noted, and which results in appearance of a long anterior face. So it produces structural imbalance, functional insufficiency, and aesthetic disharmony. So the treatment is either non-surgical or surgical. In a non-surgical treatment, you can do orthodontics alone or through orthopedic protraction using headgears, or in surgical, you can do either distraction osteogenesis or conventional orthognathic surgeries, Lippert 1 level osteotomy and advancement, and this is what I will be talking about today. So it is important for the clinician to understand that the psychological impact of a cleft deformity is great on the patient, and it usually starts appearing after the age of 8 or 9 years, or it becomes more pronounced by the age of 13 or 14 years. Apart from the obvious aesthetic need of the surgical intervention, there are several functional problems also that require surgical attention. The mid-face deficiency often leads to problems with the speech, nasal respiration, olfaction, and hearing. And therefore, the goal of treatment should be to achieve overall aesthetic as well as functional improvement. The timing for maxillary advancement is between 15 to 17 years in male or 14 to 16 years in female, and usually after the completion of the growth. And to plan the surgery, you should make accurate dental model, face bow transfers, intraoral and extraoral photos, lateral cephalometric analysis, and OPGs should be taken for an adequate treatment planning. Alveolar bone grafting should be done between the age of 9 and 11 years to get the maxilla in one piece, and cephalometric analysis should be done, and pre-orthognathic orthodontics should also be done for alignment and leveling of the arch, and also for the decompensation, creating a space between the upper and the lower anterior teeth by correcting their inclination so that the jaw can be advanced forward without any hindrance. And arch coordination should also be done. Arch should be expanded usually to correct the transverse discrepancy, as the maxillary arch is often collapsed. So this is how you can see in these pictures that the dental crowding has been removed. Lower and upper incisors are now straight and not proclined. Both the arches are flat with upper arch wider than the lower arch, and after the proper expansion is achieved. And there also exists a space between the upper and lower jaw anterior teeth, thus enabling Leaford 1 advancement to occur. So then you also do the cephalometric analysis and compare various points with the regional normal points. So what kind of corrective surgeries can be done? A retuded maxillary, hypoplastic maxilla can be addressed by a variety of techniques, and one is Leaford 1 advancement, which I'm going to show now, and other is maxillary distraction when the discrepancy is more than 8 millimeters, and sometimes you need to do a bi-jaw surgery where you do a BSSO and also Leaford 1 advancement. When to distract and when to do a bi-jaw surgery. Historically, if the mid-face discrepancy was more than 8 millimeter, many surgeons used to split and reposition the mandible posteriorly, achieving class 1 occlusion. But as a rule determined by cephalometric analysis, if the mandible is at its normal anteroposterior position, then it should not be repositioned, and a distraction protocol is rather employed to achieve a stable advancement with gradual stretching of the soft tissue. So the cleft patient also, as I discussed earlier, the cleft patient also have a paranasal hollowing, and therefore a high Leaford 1 osteotomy should be done rather than doing a low Leaford 1 osteotomy, not here but here. So this will also address the hollowing here in this area. And surgical simulation should be done before the actual surgery. Conventionally, you have a model and you can keep it on an articulator and assess how much of advancement is required. You can also do it using the virtual surgical softwares. There are many of them available, and you can put the patient CT data and intraoral scan data and create a 3D image, and you can perform the virtual surgery, and you will know exactly what planes and what places you need to make incision and how much of advancement you want to do, and you can also prepare the final dental splint using the 3D printing. So now we will see the surgery performed, the incision and the exposure, and there is a sound in it. Sound? Okay,
I start with the circumvestibular incision extending from molars to molars on each side. Before a traditional circumvestibular incision can be given, it is important to ensure that there are no anterior palatal fistulas. And allular bone grafting was done, creating a continuity of the allular bone and the labial mucosa. It is important for the vascularity of premaxilla in bilateral clefts. The mucoperiosteum is carefully reflected from the anterior wall of the maxilla. It is then reflected from the nasal spine to visualize the attachment of the nasal septum to the spine for the osteotomy later on. Subperiosteal dissection that extends, exposing the lateral wall of the maxilla. It is important that we stay subperiosteal as we approach the lateral wall of the maxilla. Reverse Langenbach retractors are then put on both sides, which help in visualization of the lateral maxillary wall for the osteotomy later on. It is important to note that in a traditional FO1, the mucosa can be easily reflected from the nasal floor, but in cleft maxilla, because of the absence of the palatal shelves, the nasal layer is confluent with the palatal mucosa. Therefore, the nasal floor is incised and separated from the palatal mucosa, and while we do, we have to be careful not to disrupt the palatal continuity. The nasal mucosa is then reflected from the lateral nasal wall to facilitate the nasal osteotomy later on. Before the osteotomy and down fracture of maxilla, I prefer to stabilize the segmented maxilla with a continuous 2 mm plate. It helps in advancing the maxilla as a single unit. This was first suggested by Posnick. In cleft patients, a significant paranasal hollowing is observed, and to compensate for it, I usually perform a high LFO1. The osteotomy design is high on the anterior wall of the maxilla. It then steps down and becomes parallel to the occlusal plane on the lateral wall of maxilla, just above the roots of the molars.
So the marking is taken here, not the lower down, to address this hollowing also. This is a high incision given here. But when you come to the midline, you come here.
I start the osteotomy with the lateral wall of the maxilla. The saw blade is kept parallel to the occlusal plane, following the osteotomy design. The reverse Langenbachs safely retract the mucosa away and also act as a stop to prevent the saw blade from going deep behind the maxilla. For step design of the osteotomy, I prefer to switch to a micromotor with a 7-knot burr, as it gives me better control in my hands. I then proceed to complete the osteotomy on the anterior wall. A periosteal elevator is used to safely retract the mucosa from the lateral nasal wall to prevent any injury and bleeding from the saw.
So thus the osteotomy is completed here on one side, and it will be done similarly on the other side.
The same osteotomies are then performed on the other side of the maxilla.
So this
It
is
is
the
important the reverse
osteotomy is here
Langenbach
shown in this
engaged
model.
behind the maxillary tuberosity to prevent the saw from slipping and injuring the pterygoid plexus or any other vital structures. Again, switching over to micromotor handpiece for better control for the step osteotomy.
Initially using the fine burr and then the osteotomy is used to separate
Note the
it.
position of the periosteal elevator retracting the nasal mucosa to prevent injury from the saw blade.
When the complete osteotomy is done, you should be able to mobilize it with the pressure of your thumb, and you may not have to
The
need
osteotomies on the lateral
instruments,
wall of
or a
maxilla
rose,
are completed using a straight
disinfector
osteotome
there.
and mallet. I hammer the
There are soft
osteotome,
tissues which
keeping
are
it parallel to the occlusal plane
adherent there,
until it goes
and
and
because
hits
in
the
the
blade of the
anterior
reverse
part,
landing back retractor.
especially in the middle, there is no palatine bone. So the nasal layer is attached to the palatal mucoperiosteum, and you should
The
carefully separate it
pterygomaxillary
from there.
disjunction is achieved using a curved pterygoid chisel, which is engaged at the pterygomaxillary junction as shown in the diagram beside the video. The chisel can be kept parallel to the occlusal plane and directed medially or directed inferiorly and medially. The chisel is hammered slowly till the blade of the chisel can be palpated digitally inside the mouth behind the maxillary tuberosity. There could be some bleeding from the pterygoid plexus after the pterygomaxillary disjunction, which can be easily handled by packing before moving on to the other sites. The osteotomy of the lateral wall of the nose is completed using a nasal osteotome directed laterally and inferiorly. Similar steps with osteotomes are followed on the other side of the maxilla, completing the osteotomies of the lateral maxillary wall, anterior maxillary wall, lateral nasal wall, along with pterygomaxillary disjunction. Pterygomaxillary disjunction is essentially a blind procedure, and your only guide to perform it correctly is to direct the osteotome correctly and digital palpation of its blade from inside the oral cavity, as could be seen in the video.
So after you have ensured that the osteotomy is complete, you start mobilizing it.
In
with gentle
non-cleft maxilla,
pressure.
the pedicle of the descending palatine vessel is around 25 to 30 millimeters from the piriform rim. In cleft maxilla, this distance could be less, and thus the osteotomes should be stopped at around 20 millimeters to prevent any bleeding from the pedicle. If the osteotomies have been performed well, the maxilla can be downfractured using digital pressure. I
you
do
can
not
easily
use any
downfracture
other
it here.
instruments like Rose disimpaction forceps to forcibly downfracture the maxilla, as it can lead to unfavorable fracture lines. I then move on to pack the maxilla for some time to stop any bleeding.
So after we have downfractured it and mobilized the maxilla, you can
To
just
facilitate
pull
advancement,
pull
the
it
soft
here. You
tissue
can see
should
how
be
easily it
stretched in a
moves.
progressive manner, as the scar tissues, due to repeated cleft surgeries, are not very compliant. For this, a Tassier maxillary mobilizer or Rose disimpaction forceps can be used. Make sure the Rose forceps are not closed tightly to prevent any untowards injury or trauma to the palatal tissue.
So if you
The
are using
maxilla
it
is
to
stretched in
mobilize,
all
be very
planes
careful.
till a passive floating maxilla, which can be easily advanced, is achieved. The splint is then fixed to the upper jaw. A properly mobilized maxilla is one which sits passively over mandible after advancement. If any tension remains, or you have to struggle to get the maxilla forward, that means soft tissue attachments are not completely removed, or pterygomaxillary disjunction hasn't happened thoroughly.
So the splint are prepared in
IMF
advance
using
and then
wires or
they're
elastic is
fixed
done,
and before we
and
go on
advanced maxilla
to
is
do the
stabilized
plating
in
in the
position
maxilla to
using
fix
mini
the
plates,
bones.
just as we
And-
do
and
in
then
normal
close the,
any trauma cases.
close the soft tissues there. So as the time is finishing, so this is how we close it. These are some of the cases that you can see. The upper lip is behind the lower lip is everted, and there is a retruded midface. This is 6 months after the surgery. Another case here, you can see the midface retrusion, and this is 6 months after the surgery. This is post-op, sorry. This everywhere it is. This is pre-op, this is 6 months post-op. This is pre-op, this is 6 months post-op. Again, in this patient, a bijaw surgery was done because there was a severely prognathic mandible and retruded maxilla. The mandible was retropositioned for 5 millimeters and the maxilla was advanced to 8 millimeters. This is a recent case, just 1 month post-op. So the complications can be bleeding, infection, soft tissue necrosis, speech impediment, there can be paresthesia or relapse, and rare complications include blindness and a stroke from the Leaford 1 down fracture. So it is important, it is an important component of a comprehensive cleft care patient. So initially when you start doing the cleft surgeries, all results look good, but when they come after 8 or 10 years, you see many of them have maxillary retrusion. And the cleft patients share a commonality in their midface anatomy that is characterized by a 3-dimensionally deficient maxilla and is often accompanied by constriction of the maxillary dental arch, and a well-coordinated multidisciplinary approach is required to plan and execute cleft orthodontic surgery. So there are various tools available to plan it, and relapse is often seen even in non-cleft orthodontic surgery because of the it is more often seen in the cleft patient compared to the non-cleft orthodontic surgery because of the scarring of the soft tissue, and therefore surgeons should overcorrect the deficiency to account for such relapse and explain to the attendants and patient that such relapse can happen. So I would like to invite you all, and I would request you all to register for the next National Conference Aprasocon 2025, which will be held between 12th to 16th November, and its website aprasocon2025.com is now live, and you can register there. And you can also contact me if you have any query. Thank you very much.
Hello. Thank you, our President, APSI, Dr. Singh. Nice presentation and a nice display of surgeries. Next topic is Dr. Subodh Singh only, video secondary cleft lip deformity corrections.
Yeah, there is a correction there. This is not a video because I have to show a lot of deformities in cleft lip. So it is not a video, it is rather a presentation, and I would try to do it quickly.
Sir, request keep timing.
Yeah, so earlier the timer was not set properly.
Okay, sir.
So although I shoot it by 2-3 minutes, but the timer was also not set.
Okay,
I
thank you.
got it corrected there. So I will try to finish it in time. So secondary deformities in lip is very common, and that can happen because of various reasons, because of some problems in technique, or because people doing the cleft surgeries are not well trained. It is always best to try to get the best results for the first time rather than going and revising others. So these, I encountered a lot of such cases which were obviously not done by qualified surgeons. So it's spoiling the lip forever or creating the deformity which is correctable. So the common deformities are scars on the lip, vermilion asymmetry, vermilion notch, loss of vermilion, loss of filtral structure which is very difficult to correct, loss of Cupid's bow, and loss of all the 3 philtrum, Cupid's bow and vermilion, or there can be tried frenum or frenulum, and there can be muscle dehiscence or incomplete dissection. Some of these are easy to repair, and some with philtral or Cupid's bow or vermilion losses are rather difficult. So you can encounter such kind of defects, the notching and scarring, or hypertrophic scarring, or loss of philtral structures here and the Cupid's bow structure, as you can see in this case, or loss of Cupid's bow here. Half of the Cupid's bow is present, but the rest half is lost. Or the poor planning and execution, although it looks bad, it is very easy to correct. Or notch and lack of proper muscle approximation here, they are also very easy to correct. So the common procedures which are done to correct secondary deformities are excision of the scars and repair, addition of a triangle, or dismantling and doing the rotation advancement repair, or dismantling and doing a triangular flap repair, combination of these, VY advancement, jet plasty, and muscle repair and plication whenever it is needed. With these techniques, you can correct almost all of the deformities. Here you can see there is a notch and there is a muscle deficiency also. Here again, there is a lot of scarring, lot of philtral tissue, and a big triangular flap corrects all that. Again here, there is a lot of scarring and loss of the philtral structures and a Cupid's bow that can also be corrected with the addition of a triangular flap. Here there is a notch and incomplete rotation of the flap there, which can be redone and corrected. If there is a vermilion notch, it is better to add a triangle, and it can happen because of the poor selection or execution of the technique. Then you should redo it. If there is a vermilion excess, you can correct it by excising. If there is a vermilion deficit, go a little lateral and add a triangle. If there is a scar contracture, do a non-surgical management of a scar, or sometimes you have to do surgery, or if there is infection, you have to do one of these. So in a scar contracture here, like a severe scar contracture and incomplete rotation and excessive loss can be there, or there can be incomplete rotation and too lateral positioning of the peak of the Cupid's bow. So there appears a notch there. And in this case, too much of vermilion was excised from the lateral side. Or there can be an incomplete rotation and vermilion notch that can be corrected by redoing it. Excess vermilion and a tissue retained on the cleft lateral side, this tissue that can be excised by redoing it. Or incomplete rotation, loss of vermilion on the medial side, and the scar that can be corrected by completing the rotation. Or if there is an incomplete rotation, you can do it again and make a balanced philtrum. If there is a loss of philtral structure, you must add a triangle, and you should rotate or advance it. Or loss of Cupid's bow structures are there here. Again, a triangle will be a big help in repairing this deformity. Another case. So here in this case, part of the Cupid's bow has been taken laterally as a triangular flap, and which can be corrected. Again here a large advancement flap has been taken. Here again there is a loss of Cupid's bow structure and some part of the philtrum that can be corrected by addition of a small triangle. If there is a wrong planning because of insufficient training in cleft surgery, or surgery is not performed by a plastic surgeon, you must redo it and use all your surgical skill. Here the vermilion is present here. You can just dismantle it and redo it. Again the vermilion and entire philtrum is available here. You have to redo it and repair it. Again here, although it looks bad, all structures are preserved, so you can repair it. If there is a no muscle repair done, or there is a dehiscence, you must redo it, or open it up and repair the muscle, or sometimes you just need to plicate it. Here it is. This is second position. So here you have to redo it and do the muscle repair and remove the excess vermilion here. Again here, the muscle dissection has to be done, especially in the pars marginalis area, and redo it. And again here, there is a muscle has not been repaired well, especially in the pars marginalis area. You need to open it, do application, repair the muscles in the pars marginalis. And when should you do a redo? If there is a wrong planning or execution, lack of muscle repair, or gross discrepancy of the skin and vermilion, like in this patient, you must safely redo it. You should have a low threshold for redoing cleft cases which are badly done. So nothing else works. So doing a jetplasty or something will not work. You should straight away go and redo it. And when you should add a triangle, when there is a notch in the skin or vermilion, there is a loss of filtral or a Cupid's bow structure. If there is a contracture of the scar or a scar hypertrophy tendency, or large difference in the filtral ridge height, like in these cases, I'm quickly going through these. So in these cases, it's better to add a small triangle, and a small triangle can correct most of the deformities. So scar and hypertrophic scarring, you should do a non-surgical scar management or add a triangle, or sometimes you need to redo it. Infections and injuries, sometimes if there is an infection, you have to do a delayed repair, but if there is an injury and wound is not infected, you can repair it again. Like in this patient, it was repaired well, but fell from the bed and it was repaired again. So some of the problems in bilateral. So the two common problems are retaining the prolabial mucosa or lateral lip skin between the philtrum and the vermilion. I will quickly show them. This looks worse. So you should never retain the vermilion in the prolabial area. You should excise all the vermilion, but it can be easily repaired. Again here, the vermilion has been retained. That can be excised and closed. Again here, not properly done, you have to redo it. Or lateral lip skin between the prolabium and the vermilion here. So this skin has to be excised. You should never retain skin from the lateral side. Again here, not only skin but also the vermilion has been retained here. You should redo these cases. And if they're badly done, you should straight away go and redo these cases. So with the scars and improper surgical technique, so you should dismantle it and redo it again. Again here in this case, dismantle, do a muscle repair and redo it. Again here, dismantle and redo it. Again here, not properly done, but you have to dismantle and redo it. Sometimes there happens the necrosis here, or it gives way, the projecting premaxilla comes out, but it can again be repaired well. Again here it is coming out, can be repaired well. Then in this case, it was bilateral lip was done, and there was a gaping on this side, and there was some infection. So, but you can still do the surgery, repair it. So the take-home messages are: master at least one technique. There is always a learning curve in cleft repair, as in any other surgery, and have a low threshold for redoing it. Dismantle and redo it whenever it is required. Do not hesitate to add a triangle. It saves you and the patient. Muscle repair is the key, and you should always properly do it. And the last is, but not the least, always operate upon a healthy baby. That will prevent most of the complications. Thank you.
Thanks, Dr. Subodh Singh. Now it's open for questions. Few questions can be taken by house.
Nice presentation.
Use the microphone, please.
Yeah, of course. Yeah, we do give hypotensive anesthesia, and especially when we reach posteriorly, there happens some bleeding, so we give hypotensive anesthesia, but we do not bring the blood pressure way down, so we keep it by 90 or 80. So we do that in some of the cases, but before we start closing it, we see to it that the blood pressure is brought to the normal range. BPI and also correction of BPI after maxillary advancement? Yes. So there was just one patient I noticed. We have done now about 50 such cases, 50 plus cases. So there was just one patient who said there is now a difference in his speech. But his speech evaluation wise, there was not much difference. But probably he was feeling the difference in the tonality of the speech rather than the velopharyngeal functions. There was no nasal escape or something, but it can happen.
Dr. Subodh, I have two small questions. If a patient requires maxillary advancement and secondary correction of the nose, left lip rhinoplasty, which one do you
I will do the
like?
advancement first.
Advancement
Nose will
first.
be the last.
Okay, excellent work. Did you ever have to take a B flap in any of the secondary corrections?
Yeah, lot many times. I did not show it there, but lot many times I use an AB flap.
There is a clear place for AB flap in secondary correction. Should have included some places.
Yeah, I missed those slides.
Okay.
So any
For the next
experience
time.
about distraction?
Now we have, very small experience in distractions. We have just started doing distractions. We have some experience in advancement, but not much in distraction. I think you people do a lot of distraction, yeah.
At our place, we are doing distraction only.
It provides, because it is slow advancement, it provides more stable, and in one of our patients which came back, there was a relapse. So I think there may be more relapse in maxillary advancement rather than distraction. So that's also a good technique.
Now, by this procedure, so how do you do that distraction of the soft tissue also? Because you are distracting the bone only, but what about shortening of the soft tissue?
Yeah, soft tissue can be mobilized to that extent. We are not advancing more than 8 millimeters. So that much of soft tissue can be mobilized. And you saw that we were doing a lot of maxillary movements to just to make the soft tissue a bit relaxed. But of course, a patient who has been operated multiple times will have scar tissue, and it is often difficult to distract them. And that is one reason why relapses can happen. And that is one reason why distraction osteogenesis can be a better choice in many of these cases.
And any chance of non-union?
Yeah, there is a chance, but fortunately we have a small experience. We have not faced any malunion in our last 50 plus cases, but it can happen as in any other fracture, it can happen. But these are flat bones, they heal very fast, so the chances are less.
Thank you. Thank you, Dr. Singh.
Thank you.
Any question?
We do not have an exact data, right? So we have not been analyzing, and we have started doing the maxillary dissection only for the last few years. So we are calling our older patients. So I think, it is, just a guesswork. So, but 15 to 25% patients of those who are having palate as well, they require maxillary advancement. This. Only few patients come for maxillary advancement, and many of the patients who come in follow-up and we notice, then we inform them that this is available, because they're not even aware that this can be done. They think that this is how it has grown, although they're very unhappy with their faces. But when we tell them that this can be done, they come forward and get it done.
My third question is about 50 cases of maxillary advancement. Did you notice any particular cleft palate technique where these patients required advancement more, or there was no specific observation like that?
We haven't analyzed it, but any patient who had multiple surgeries, like developed fistulas multiple times or was operated several times, or a bilateral complete case, they require more of advancement.
So basically multiple surgeries in your series.
Yeah.
Okay, thank you.
Thank you. And also, the cleft palate patients operated at a younger age will comparatively require more maxillary advancement compared to the patients who were operated at an older age, because starting in a big way in 2004, we were having patients who were aged 3 years, 4 years, 5 years, 10 years, 15 years. So we know from our own experiences that patients who were operated later age, later than 1.5 years, they had less maxillary retrusion compared to the other patients.
Thank you, Dr. Singh.
Thank you, sir. Now I call upon Professor Dr. Bijay Kumar, our Honorary Secretary of APSI, for his presentation on hyperbaric oxygen therapy in plastic surgery.
Thank you, Chairperson. First of all, I'll like to thank Dr. Lakshmi Mishra, Sanjay and Team Odisha for calling me. Last meeting I was not able to make it due to my health issues, but this time my topic is this hyperbaric oxygen therapy in plastic surgery. It's a new life. So what is hyperbaric oxygen therapy? It is 100% oxygen at higher pressure, and it is recently gaining the publicity over last 10 years. Only few centers are there in India. The problem is infrastructure-wise, it is high cost maintenance and staff training. So background is hyperbaric oxygen therapy provides an increased oxygen supply at cellular level, which improves the hypoxia associated with damage to organs. SbO2 is also effective in several conditions. Many remains and still emerging. So pure oxygen increased at oxygen level at blood, it known as hyperoxemia. Then it is tissue level, it is hyperoxia. Then it is, as I said, it is there are certain indications. It was initially used for decompressive air embolism, but in plastic surgery we are now using for necrotizing fasciitis, burn injuries, aesthetic purposes, sensory neural hearing loss. We are getting very good results. Then crush injury and radiation-induced injuries also. Then radiation-induced injuries, diabetic foot, ischemic strokes, sports injuries, and multiple sclerosis. We are getting good results. Then there are absolute contraindications. One is untreated pneumothorax. So we do ear examination done and X-ray chest to rule out these things, and other relative contraindications, but we can do with them also. And underlying respiratory pathologies like chronic COPD, asthma, even respiratory diseases. So we do screening. As I told you, we do detailed examination, patient examination, ear evaluation for the ear term checkup, pre-anesthetic checkup, rule out any contraindication on any psychiatric illness, because patient has to sit for 1 hour there. Then we do vital monitoring, patient comfort. When we take the history, when patient has last meal, we guide them to avoid meal before doing the hyperbaric. And first we do the 15 to 30 minutes test session, and we do monitoring where the patient is getting headache or earache. Then these are the types of modern days hyperbaric oxygen chamber, monoplace, multiplace, and this type of are there. This is monoplace chamber we are having. We are having one monoplace and one multiplace chamber, and this is multiplace chamber. We are having in these 3 chambers are there. But from outside this machine, everything is controlled. There is a video there, and this is the inside picture. One patient can lie and 2 can sit inside. This is the way the patient lies. This is the patient of burns undergoing the hyperbaric oxygen therapy. This hyperbaric therapy has helped management of mucor during COVID also. So this is how the patient lies there. The patient can sit there. This is a single. This is the way the two patients can sit here and one can lie here in our multiplace. And this is how we can monitor from outside. And the patient can be seeing here. We can see from outside. So basically the concentration, volume, pressure, this is the thing, the Henry law, increasing partial pressure of the oxygen in arterial blood supply during would improve the cellular actually the cellular delivery level of the oxygen is increased, and increasing the pressure will decrease the volume of the intravascular lesions. This is how the hyperbaric therapy works. Hyperoxemia, then decrease of hypoxia, ROS, and growth factors, neovascularization, and immunomodulatory properties. And it enhances the angiogenesis and enhances the antioxidant defenses and increase the number of circulating stem cells. It interferes with detrimental effects of cellular senescence, inhibits the telomere shortening, especially in the aging time. Then these are the indications in which plastic surgery we are doing. This is the pre-session of the mucormycosis after hyperbaric, 7 days. The patient was improved. In this also the patient improved. Then in burn injury we have conducted a study of 28 patients and 14 without hyperbaric and 14 with hyperbaric. This is how the patient has responded. The healing in the hyperbaric was very early. This is the hyperbaric patients, and we have done the biopsy also. So less number of monocytes were there and more monocytes were there in non-hyperbaric, and the basal cell regeneration and was there more in the hyperbaric patients, and more neovascularization was there in the hyperbaric patients in comparison to the non-hyperbaric patients. These are the results of our study. Then we have this for infection also we have done a study. We have done on 108 patients. Then mechanism of action I have told you. These are the results. Then I will show the photographs. Yes, this is the day 1, then day 7, day 14, and day 30. Then another patient. So these are the ulcers which are not responding to the dressings and not responding to the hair graft is also not taking well. So in these patients, the hyperbaric therapy is helping us. Then flap salvage. When we are getting the flap salvage, we also day 1 we released, and we on day 7 see the more darkening is more. But on day 14, the darkening improves. In another case, there is a darkening, the flap is going to fail, and then after hyperbaric 14 days, this improves. This is another case in where the injury was there, infection was there, and then after hyperbaric, the improvement was there. This is how it helps in chronic wound. It enhances the neovascularization, potentiates the antibiotic and antibacterial process, ameliorates ischemia per deperfusion injury, enhances antioxidant response, and activates the fibroblastic activities. These are the patients when we have been treated. Then in diabetic foot ulcers, this is also being used by us, and paper by Londage is also there. Sensory loss we have done on 40 patients. Sudden sensory loss, and after 5 sittings, the hearing improves, and it is also seen by the audiometry reports we have seen, and the very good result for the hearing loss. Then in aging, this HACMO has given a paper. A lot of paper are there. It happens the telomeres length of T cells and T cytotoxic thing they improve. In his paper he said potential anti-aging therapies are physical exercises, intermittent fasting, stem cell. These are not possible. So the advantage of hyperbaric is a healthy, include non-invasive, established safety profile and common clinical application in diverse populations. It helps in the brain improvement, lung, skin, skeletal, bone adipose tissue, and glycogen tissue. This is how the hyperoxia improves, and this wrinkle process is delayed. This was given in the paper by the blood post. This is the process. This Kaufu have told that this hyperbaric oxygenation helps at the this level, mitochondrial biogenesis level. Here, from here, the aging is delayed. In this paper, Hackmo has done pathological studies. He said the baseline and pre-hyperbaric study, elastic fiber changes. Following hyperbaric, there was a significant increase in elastic fibers numbers along with significant decrease in their fragmentation. So number of defragmentation number was decreased. And in biopsy also, he said papillary layer thickness changes following hyperbaric. There was a significant decrease in papillary layer thickness. So this papillary layer, he has demonstrated the benefit of hyperbaric with the biopsy reports. Then he has said there was a significant decrease in number of tissue senescent cells. So the hyperbaric, this is the patient, in our patient, one of the patient we have done in hyperbaric. You can see there is improvement here, there, and this is post hyperbaric. This is 30 days post hyperbaric. Then the same patient from the lateral profile, see, you can see the wrinkles and they are decrease in number. This is another profile of the same patient, and the improvement is there. See, you can see here the hanging and this reduced. So sun damage is a primary concern, and these are the things we have observed in our study. This actually we have done study on this for aesthetic purposes. We controlled with the chemical peeling, botox, and the hyperbaric. And though the number of study, the patients were less, 7 in each group, and we have seen improvement in hyperbaric patients, more improvement, and basically it was non-invasive also. This is the advantage of hyperbaric in anti-aging was hyperbaric oxygen delivery to skin cells promote cellular health and regeneration, enhanced oxygen level, stimulation, collagen production, improving the skin elasticity and reducing the wrinkles. Then hyperbaric also helps in reducing the hyperpigmentation leading to the more skin tones. So in other medical, they have been used in decompression sickness, air embolism, central retinal artery occlusion, carbon monoxide poisoning, severe anemias. These are the medical fellows they have used in ulcerative colitis. Then we are getting lot of patients post radiation after we do the free flap, and after radiation there is ulceration, and in those patients bone necrosis of the radiation necrosis of bone. These patients are having very good result by the hyperbaric oxygen at our center. Then necrotizing fasciitis, Fournier gangrene and gas gangrene. So lot of new areas are coming up. The patient, this is our publication of regarding the on the mucormycosis due to the hyperbaric oxygen we got. The future, we have got one patient where this patient was stage 4 operated CA breast, and it was the metastasis was there, but after giving 30 days of this hyperbaric, on PET scan, the disease little bit reversed. Then he stopped coming. Then again it is started. Then he restarted. He was told that his life expectancy is not more than 3 weeks, but now the patient is surviving for 8 months, regularly getting hyperbaric. But we are not believing the things of the patient. We are trying to make and study a model to see whether it will be helping in the cancer or not. Due to lack of time, I will stop here. Thank you very much. Last slide, laga do. Last slide. Last slide. On the behalf of the department and Navy, I would like to invite you for this second last laga. Second, isse pehle wala. For Navy, from 13th, 14th, 15th, we are organizing this NavyCon at Ayodhya, and you can combine this trip with Kumbh, Mahakumbh. So I welcome you all. Thank you very much. This is basically hyperbaric is a new technique coming, and very few centers like AIMS, New Delhi, Rishikesh, ourselves, and few other centers are there. And then Balakrishnan sir is also doing at Chennai. So we are coming out with the new indications for the plastic surgery.
Even in New Delhi, actually 10, 15 years back, only 3 centers were there. So my question is, how frequently actually, what is the dose means if it is a pressure ulcer patient? How many sessions it will be requiring and what time means?
Basically, what happens is in pressure cells, controlling the infection things and controlling the fibrosis, which is not helping us to treat the ulcer and the secretion is not getting. So at least 20 to 30 sittings are required. After 20 to 30 sittings, we can the secretion lessens and healing improves.
And frequency is every day?
Huh?
Every day patient has
every
to?
day we are actually at our center, being a medical government college, we are doing free of cost. So patient comes for 1 year day. Initially, when we start, we do sitting for 15 to 20 minutes study, whether the patient is able to tolerate or not. Because I will tell myself also, I also sat with my Dr. Brijesh and myself sat in the, but due to claustrophobic effect, we came out after 15
Even claustrophobic patients actually has to be excluded from this.
No, exclude, but for the treatment purpose they can,
Yes.
but then they come daily for, we are having one single chamber and one 3 chamber. So in the patient which require isolation, we go, keep them in single chamber. Those who require, we don't, the 3 patients can sit, the 3 patients together they sit. Then we allot them a slot, 10 a.m., 9 a.m., 8 a.m., then 11 a.m. So according to slot, the patients come and daily for 1 hour we are giving.
Thank you, sir. Actually, this facility, Odisha is not having hyperbaric oxygen chamber.
Sanjay Giri, I think, is coming out.
Yes, AIMS probably is getting one.
I think Dr. Vijay is a nice modality for our plastic surgeon burns. In fact, it started with gas gangrene, we know, but now with the children, it is possible to have this modality for
Yes,
child.
sir, children also they are sitting. We are treating the children also. They are sitting with them.
So
Because one of our technician, the 3 patients and 1 technician sits with them. Technician is not taking oxygen. The oxygen is taken by mask. The patient are given the oxygen therapy. The technician sits. We have made a rotation of the technician so that they can sit there.
So you have no experience of any side effects or problems with these patients?
The problems, they are complaining of the headache. Sometimes they are earache. And sometimes they are saying we are having a headache, then we reduce the pressure because we give the 2.5 pressure to 2 pressure. But when the patient is telling the headache and the treatment is necessary, we reduce the pressure to 1.5 atmospheric pressure.
So did you monitor with any blood profiles?
So monitoring is done there and patient are
Blood profile in ICUs, no? They do, no? Blood gas analysis, like that, do something?
So we are not doing that. Blood gas we are not doing. The patient is similarly observed on the basis of complaint. Yes, sir.
Okay.
Thank you, sir.
Thank you, Dr. Vijay ji. This was very enlightening for all of us who have just heard that HOT is there, hyperbaric oxygen therapy. We have had
my purpose was there to just...
Absolutely. Very well done. Just I was wondering how it could be of any help in sensory deafness.
Sir, sensory deafness, it is helping, and I have written due to paucity of time MLP, because sudden sensory loss where the neural is there, it is helping. And we are getting more VIP, like ministers are also coming us. And sensory loss, and one patient came from AIMS Patna. She was a wife of a resident, and in 5 days she went back.
In that case, will it help in Bell's palsy?
No. Bell's palsy, I have no experience. I am talking about when the patient is getting sudden sensory loss, sensory neuro hearing. In Bell's palsy, we are planning to have a study. I have collaborated, got the ethical clearance from the institute, and we have collaborated with the ENT colleague. He get hold of the Bell's palsy, patients, hearing patient and Bell's palsy patient. Then we are sir, coming up with making studies.
I was just wondering if there is something that HOT does to improve reduce the edema by increasing oxygenation. That could be one of the mechanism of benefit that we get in sensory deafness. In that case, Bell's palsy would be a right thing to try.
Yes, sir. We are planning the study, and we are also seeing that if the patient stops coming after 5 days, then he again gets. So at least at least 30 to 60 sitting are required for sensory.
Last question. I'm Dr. Palin
Yes,
from
sir.
Manipur. I'm
Yes,
in the
sir.
private sector.
Yes, sir.
And this is the first time we are hearing, because of course this is my area of interest for the last few decades. In Manipur, Regional Institute of Medical Sciences has got this hyperbaric oxygen therapy. But the price is prohibitive. I want to know about the economics.
Sir,
What is-
economics wise, the price that techno
Is it possible to install in the private sector? Because I want to know the price.
A lot of private sectors are coming slowly. In Lucknow, only 2 private sectors come and they are giving the this hyperbaric therapy for only aesthetic purposes. The people are stopping taking the Botox and other things, and they are preferring the hyperbaric because it's non-invasive, not doing any harm, and they are getting the benefits. So in Lucknow, 2 centers are there. They have come up. They are doing only for aesthetic purpose.
Okay. What's the price for 3 chamber in your
For
experience?
each chamber, sir, I have asked that techno person, because one of my friend in Aligarh wanted that. He has said around 1.5 CR.
For each chamber?
No, for three.
For the whole thing?
Multi.
Multi.
And you can increase the number of chambers. So we are having 3. We are planning to add 2 more. So we can add in this only. The chambers can be added. Mono chamber we have bought for 1 crore.
Thank you very much.
Thank you.
Thank you, sir. Now I call upon Professor Dr. Amresh Baliar Singh for his video presentation on medial spherolatry perfected flap.
Respected chairpersons and distinguished delegates. About the medial spheral artery perfected flap, part is little bit is PowerPoint presentation and dissection part is video. So these are the variation of the medial spheral artery. Of course, medial artery, lateral spheral artery and median spheral artery. There are 3. And there are also variation between them. But now I am talking about variation in the medial spheral artery. I am not talking about the other 2. So sometimes there can be 1, that is number 1. There could be 2, but the division is little higher up, and if it is a little division is little low below the knee joint, then it is type 2B. And 3, there are multiple branches of the medial spheral artery. And you can see this is the medial spheral artery, general topography. You can see that the medial part supplies the muscle, and there are branches which comes from the lateral branch of the medial spheral artery. And also we can plan chimerism depending on your requirement. Either you can take also muscle, you can take the skin paddle, a little bit thin amount of muscle, you can also take. These are the chimerism possible with the medial spheral artery. And coming to the flap planning, there are actually multiple studies. They are from multiple landmarks. But among the one point, the constant point is, that is they take the midpoint of the popliteal fossa in the case, that is, and the lateral malleolus, anterior border of the medial malleolus. And that is about 8 to 12 millimeter. In that, there is always a operator. That everybody agrees. These are the various studies they have done. But among all, these are the, you can see that most of it is actually, one is goes from the midpoint of the popliteal fossa to the midpoint of the tendoachilles near the calcaneus, and the other is goes to the anterior border of the medial malleolus, and always between the 8 and 12 centimeter there will be always a perforator. But among all, I find this study by Masahumi Otani is the most conclusive one, because they had done cadaveric studies and they had shown the number of perforators. I always depend on this. So whenever I give a midline, posterior of the popliteal crease, I give a line, and from 5 centimeter, that the first perforator will start coming, and again 12.5 from that point is all the perforators come, and from the midline up to 4.5 cm all the perforators lie. So this is the study I always follow this. Now this is a video for the dissection of the radial artery.
Recipient vessel dissection is being done in the neck. With the patient in the supine position, the popliteal fossa is marked. The posterior midline is then marked subsequently. The first row of perforators is situated about 5 to 7 centimeters from the popliteal fossa. While the second row of perforators is situated between 15 and 17 centimeters from the popliteal fossa, about 4.5 centimeters medial to the posterior midline. The flap is planned within the confines of this region. Perforators are marked with the help of a handheld Doppler. Final location of the perforators can be seen. Under tourniquet control, a medial exploratory incision is taken. The skin, subcutaneous tissue and fascia are incised to reach the gastrocnemius muscle. The fascia is then tacked to the skin to prevent shearing between the skin and the fascia. We then proceed with subfacial dissection to identify the perforators of suitable size. Perforators are observed to have a lengthy, tortuous intramuscular course and may drain in variable systems. Hence, a very patient and meticulous dissection with clipping of numerous branches is done to identify the system of perforators. The second perforator is being dissected towards the popliteal fossa. Several intramuscular branches are identified and clipped during the course of dissection. About 10 to 15 centimeters of pedicle is dissected free. As is evident, the proximal perforator is draining in a system separate from the one in which the other distal perforators are draining. It was hence decided to harvest the flap based on distal perforators. Based on the location of the perforators, the posterior incision is committed and the flap is harvested. The dermis of the flap is checked for satisfactory bright red bleeding. Pedicle is clipped and divided thereafter. Flap is delivered and taken to the head end for inset. Microvascular anastomosis is done with the facial artery and tributaries of the internal jugular vein. The final inset of the flap is done. There is a good color match and the facial skin and contour achieved was satisfactory. Donor site is closed primarily with an inconspicuous scar hidden posteriorly.
This is a patient with left cheek mucosa defect. She had also had hemimanubulectomy, and this is the defect, and you had used middle sural artery, and this is the secret why you use middle sural artery, because we couldn't do a ALT because it was too bulky, and that middle sural artery also provided enough bulk in this patient. So you can see these are the post-operative pictures. Patient had also undergone radiotherapy, and this is 6 months or something. That middle sural artery perforator thickness lies between the radial artery and the anterolateral thigh flap. One can judiciously plan to choose this one. Thank you very much. And only thing is sometimes there could be perforators coming from the posterior tibial artery through gastrocnemius also could be coming. And also the venous drainage sometimes may be draining to the short saphenous vein. If you can check that, you can take also short saphenous vein along with that for additional venous anastomosis in addition to middle sural accompanying vena communicatis. Thank you very much.
Sir, nice presentation, sir. Excellent result. So, since we are running behind the time, may I call upon for the next presentation our founder, president of Aprasocon, Professor Dr. Arun Kumar Chaudhary.
One of these, I invite all the national guests and our President APSI, Dr. Subodh Singh, and our Secretary, Dr. Vijay Kumar, and from Manipur also, Doctor, I'm very happy, Doctor, that you have attended this. So it became not just a state conference, it became almost a conference of the Eastern and Central region. So we are going to form the East Zone Plastic Surgery. First time we are going to have it. So the gathering is very much, and from Mumbai also, Dr. Baliar Singh just presented here. So with that, well, my topic is not focused on any particular surgery itself. It is mostly to make what today morning we are talking of, make sensitive of the patient and also the doctors of other departments that how a plastic surgeon can help a lot while deciding or planning. I think in India there may be 1 or 2 centers, maybe in the private setups they have organized with this, that the orthopedic and plastic surgeons and other neurosurgeons, cardiovascular, all they have been together, and that is the whole philosophy or holistic management of polytrauma cases. So that's why I told plastic surgeons in reintegration and reorientation in the management of polytrauma. So in our setups, obviously this has not been completely materialized. So many a times we face some problems. That problem, one or two problems I am going to highlight in my presentations. Well, these slides, many times you must have seen at national or in state conferences of Swami Vivekananda. Wisdom lies not on the amount of knowledge acquired, but on the degree of its application. Obviously, whatever you discuss, we talk about, it all depends. And by seeing what yesterday I was talking in the video, that if you see a picture doesn't mean you can be also Shah Rukh Khan. You can act. So video is there, okay, but you have to practice this by yourself. Then only you can be a master of that particular surgery or particular thing. So what is a polytrauma? Polytrauma we talk about, but polytrauma means a syndrome of multiple injuries with systemic reactions which may lead to dysfunction or failure of remote organs and vital systems. Worldwide, if you see the cause of death among the younger age groups, and we get a lot of brachial plexus lateron are 18 to 44 years. So polytrauma involvement is of more than one system: hand injuries, chest injuries, spinal injury, abdominal or pelvic injuries. Fortunately or unfortunately, I have been the state nodal officer for trauma. So we see in India, we are the third most having the maximum accident and mortality in the country. So there have been a lot of eye-raising issues by the Supreme Court of India. Why in a small state like Orissa having so much of mortality and morbidity in case of trauma cases? So that has to be introspected by all of us. So mortality in polytrauma, usually there are three peaks: first peak, second peak, and third peaks. So third peak is the immediate trauma, that the head injury, brain stem, high cord, heart, and major vessels. So we are, as a plastic surgeon, has to be present. It all depends to plan out and make a protocol of the treatment for that reason. Second peak, we have massive blood loss, intracranial bleeds, chest injuries, abdominal bleeds, pelvic bleeding, and multiple limb injuries. Now each of these injuries have specialized treatment has already started with the ICU cares. I think lot of patients are going to be saved and already been saved and going to be saved also in future. Third peak, mostly it happens in the latter stage where you have a sepsis or a organ failure. So aim of management will restore on back the patient into pre-injury state. That is the whole aim of objectives of all this management. Obviously, a plastic surgeon not given that importance in the earliest, because the life salvage is most important, where the other department take over. But there is a limb salvage which has a timeline. So the outcome of the whole treatment will depend on how early we have intervened. The salvage of total function is possible, and 70% of the preventable deaths, which can be increased to 80 or 90% depending on the golden hour, which I am going to tell afterwards. But there are 30% of cases, the patient dead body goes to the nearest hospital. So those cases may not be salvageable, but 70% are within our purview to make a difference. So advanced trauma life support. This is a rapid primary survey with simultaneous resuscitation can be done. Detailed secondary surgery that can be delayed, no problem. But constant re-evaluation of these patients are very, very important. The initiation of definite surgery or different care matters. Now, recent past, I think the SCB Medical College Hospital take the pride of, and with All India Institute Delhi, All India Institute Medical Science, Bhubaneswar, in managing all the train accidents that happen in Bahanaga, is one place in near Baleshwar district, and about 200 casualties were there. And there are a lot of patients who came and admitted to SCB Medical College, surgery or other department, including plastic surgery. So the treatment protocols are very, very important for individual patients. And when there is a mass casualty, the protocol has to be made in different ways, has been made by ATLS. This is the most important part what I have to highlight to the young general plastic surgeons. You have to be like an eagle. You have to reach. It is not eagle's eye only matters for a good surgeon. not a fingers of a lady's finger or a lion's. You have to be present whenever there is in last train accident, most of the plastic surgeons have been there when the patient just came down to our casualties. And that made a difference to many of the patients. So within 1 hour, that is the golden hour which makes a difference in the management of the patient. And 10 minutes is otherwise called the platinum hours, because that is the hour where the patient can be resuscitated properly and the life can be salvaged. And I think Glasgow coma score every one of us knows as a surgeon. Then after you have been a plastic surgeon, so you know the score, how it matters in the patient's salvaging the life of a patient. And this chart has been made for a plastic surgeon, how you have to handle with a hospitalized trauma patient involving plastic surgery specifically. Open injury needs microsurgery, obviously. And replantation, which matters with most of the plastic surgeons. I remember early 80s when we were doing our postgraduates in plastic surgery. Dr. Jena is very much there. Plastic surgery, micro was an experimental in the examination. We used to do microsurgery. But now it is not a scenario. Most of the centers, most of the places, including Manipur, I hope, you must be doing good of microsurgeries. So avulsion or crushing injury without distal pulsation has to be taken care. And all these surgeries better to do it within 12 hours. But there are some centers in the south, they are telling, yes, fingertip injuries or finger injuries with complete amputations can be taken after 24 hours. That is, or they are telling if it's coming in the late night, you better preserve in the fridge or a refrigerator in 4 degrees. Next morning you can operate. So there are different opinions and variations, and they have done a lot of cases. So it will all depend on how you are familiar with and what is your result that matters, rather than taking others' result as a guideline. So open wounds, open fracture, tendon, nerve, specials, injuries, and clean but severe wound and stab wound or dirty wounds, all these needs surgery within 24 hours. So no open wound, closed fractures within 7 days. So I think most of the orthopedic problem who take as the primary person for treating these traumas, their work doesn't start on the beginning, to be speaking specifically. After 1 week only they start, but they take the patients and they refer the case to a plastic surgeon after 1 month or maybe 3 weeks, sometime early. So, or he is known to you, he sends in early. So I hope that's why the young surgeons, they must develop that sense of reaching to the patient as early as possible and getting, I remember on 2 occasions, one CME in All India Institute, Bhubaneswar, other CME in SCB, on trauma CMEs, they have not called for the plastic surgeons. Somehow I entered there, I told, there is a lot of role of plastic surgeon at the earliest in managing the soft tissues and including the bone also. So the superintendent, medical superintendent told, is it that? We didn't know. So it all depends on how you are involved and how you have to propagate and promote. Sometimes I don't use marketing, but that is also needed. There are very few absolute contraindications for re-implantation of the limbs. As a plastic surgeon, I think you should, as a hand surgeon, you ought to know the details of doing it. It is not to orthopedic surgeon you wait for doing cases. That makes a lot of difference in the problem of the patient. There is no still better prosthesis alternative to even a crudely functioning sensor tripod. I think everybody knows, but still it is not within your purview or hands. If patient comes after 12, 24 hours from long distance, there may not be an option. But I remember in the last case of the railway accident, the last patient was admitted to SCB and discharged. We had a little function on that. Then you told who patient asked, I don't mind my replantation was not done, but I will definitely want that my treatment should be complete. So he was given a prosthetic lower limb. Lower limbs are always much better, and it was given by the government free of cost, and patient was from Bihar. So patient feels happy. So as a plastic surgeon, your job is not just do your work. You have to be a little more rational in giving the treatment. May not be you doing yourself, but you have to advise also. So that was the point I want to highlight here. Well, I don't have to go to details of how do we replantation, what is the warm ischemia, cold ischemia, and what is the time and all that. But obviously these qualities, most of the young surgeons, not the old ones, much they know, have that patient persistence, stamina and skill. So you should have a stamina professionally and mental and physical also. You have to be very fit enough if you want to be a good trauma surgeon. Well, this is one of the patients we treat, and there was a little problem which I want to morely highlight. The replantation was successful, but before that the patient when came to hospital was admitted to orthopedics, and they have given an external fixator on that while we wanted to do a replantation. So that was a big issue, a lot of time be invested on that. So all this has to be, bone has to be certain and to be fixed. So if you are conversant as a hand surgeon, even many your techniques you are learning, I think you can put a fixation of the bones after shortening it and do your microvascular job, and patient gets the maximum benefit out of it. So this was done by us, by plastic surgeon. The junior surgeon, junior residents from orthopedic could not do it. They have to remove the external fixator. We fixed a DCB plate, and the patient, and we did the replantations, and the patient was okay. Okay, only problem was because of the delay in everything, there have been a lot of problems. We have to put a blood transfusion and all these things have to be done.
Sorry to interrupt you.
Yeah,
Sir, please.
I'm going finishing. So this is another case also. The patient, they didn't shorten the bones, so we have to put a vein grafts. So these are few complications that can arise now because of not having the patient's cooperation as for the other department are concerned. So sometimes I told you promotion is required. When I was in Australia in this hospital, they have a system of heli ambulance and getting all these patients and getting operated at your hospital, because the helicopter lands on the top of the hospital, and these triage system of golden hour, platinum hours, and very much been audited so that everybody is aware of what to be done. So my take home message is the primary objective of any trauma is survival of the patients, and adequate soft tissue cover and secondary surgery improve the outcome of all soft tissue injuries requiring reconstructive surgery. A holistic approach to achieve the aesthetically pleasing and functionally useful limbs should be end goal. With increasing experience, better infrastructure, absolute contraindication of reconstructive surgery can be an indication for primary surgery along with multi-specialty trauma cases. All upper limb amputations should be replanted if adequate infrastructure and skill available, except a few selected absolute contraindication. Multidisciplinary monthly audit of all trauma cases. Make sure they are started in SCB. I am very happy that some audit system has started to know about the emergency cases, how they have been treated and what best can be done, as was done in Stanley, and Dr. Jena must have seen in Stanley it was a routine procedure to audit all these cases. So Jai Jagannath, I am so glad that we have been the land of Jagannath, and we are so happy that so many, I remember in 2016 Dr. Vijay Kumar must have attended this Navicon conference. So without your presence, without your presentation, without your sharing experience, this conference could not have been successful.
Thank you,
so
sir.
Thank you very much.
Thank you, sir, for the nice presentation. So may I call upon for the next presentation, Dr. Subrat Jena, newest technology in the negative pressure wound therapy.
I must personally thank my friend Dr. Chaudhary for having discussed something on polytrauma. So because we always know that the orthopedic surgeons take the lead role and the plastic surgeons are pushed to the periphery. So it is time we intercepted and make our presence felt. In fact, any amputation that an orthopedic surgeon is planning to do must take a plastic surgeon's opinion before doing so. That is the protocol. Thank you. So I'm talking about something which is so negative pressure wound therapy is not a new topic to a plastic surgeon because our basic function is wound therapy. So how many of us have not used negative pressure wound therapy in their career? I believe none, which means every one of us have used negative pressure wound therapy in some form or the other. The history is pretty old, more than 200 years. So from 1821, surgeons have been trying to understand and put into use negative pressure's effect on wound healing till today. The benefits of negative pressure wound therapy is known to all of us. But besides taking care of the load of infecting microorganisms, reducing the fluid exudate, it does help in angiogenesis and therefore prepares the wound bed ready for grafting or any skin cover, even if it is not healing or contracting the wound. So sometimes this vac therapy is also known as vacuum assisted wound closure. Like some of the small wounds would try to contract and heal secondarily provided this is given. But my discussion is on how does it help a wound to heal. So vascular endothelial growth factor, so this has been the largest study so far with more than 1,000 cases trying to find out in 14 animal models, 3 in vitro studies and 21 clinical trials. Is there a light in it? No, it's okay. So this was 21 clinical trials, 14 animal models, and they verified that NPW2 stimulates modulation of numerous local and circulating cytokines and growth factor expressions to promote an anti-inflammatory profile. This is most likely achieved by down-regulation of tumor necrosis factor alpha and up-regulation of VEGF, which is again a factor, TGF beta and fibronectins. Now it is well known that it helps in the enzymatic and cellular level in hastening of wound healing. So the evolution was initially it was a continuous negative pressure application. Then became intermittent negative pressure suction to a dry suction versus suction and irrigation. Continuous irrigation with intermittent suction. Continuous irrigation, intermittent suction. Intermittent installation systems with intermittent suction. This is where we are. So, in the latest proprietary version of negative pressure wound therapy, irrigation and a dwell, D for dwell, intermittent installation with a dwell time was added to negative pressure wound therapy. So the instilled solution was demonstrated to access areas of tunneling which is inaccessible to continuous installation systems. So what happens is if there is a continuous pressure, there are tunnels in the wound which is not approachable by a fluid unless it is made to dwell, be there for a while. So the fluid stays there for a while, opens up all those inaccessible areas, and then negative pressure is applied. So this added intermittent installation and dwell time has made a lot of benefit, and it has been presented in several clinical trials that this is the best in the negative pressure wound therapy system so far. So this is the newest machine, proprietary machine available, where there is a here which constantly irrigates, but not when the pressure is on. It is all intermittent. So whenever there is suction, this installation stops. So this is some AI or something. But this machine is very expensive. quite unaffordable. Maybe it will become cheaper. So what we have done is adoption of the central vacuum suction of the hospital for NPWT plus irrigation plus dual and plus TOT, topical oxygen therapy. So it's not HOT, not hyperbaric. It is normal oxygen to irrigate the wound. So this is the graphic diagram. This is the wound. This is the negative pressure suction, which is adjusted by a controlling valve. And then, once the negative pressure is applied, it would drop constantly unless we interrupt this system with a machine. So this is a very simple machine. And the most important part is this selenium valve. What is a selenium valve is that it's diagrammatically represented here, that when electric current passes through these coils, this piston moves up and allows the fluid to go in, and the electric current stops, it goes down. So this has been devised by a scientist at a very low cost, and then this has been added up. He also added up on a request a port for oxygen. So I'll show you, if this is little complicated, I'll show you what exactly we do. This is the wound. This is the suction canister which is attached to this one end of this wound, and the other end of this wound is attached to this interceptor, which in rhythm, which can be adjusted by these knobs, apply and release the pressure. So that how this constant suction is become an intermittent suction. And there is a port for oxygen which is connected to the wall unit, which gives in oxygen at 2 minutes per hour. Okay, 2 liters per hour. So this is what we do. There are several advantages which all of you know, but at this we have brought down the cost of operation to 500 rupees per sitting. All these suction connector, NG tubes, and PUF and transfer, everything is less than 500 rupees per sitting. Right now, the state health assurance scheme in our state gives an amount of 3,000 for NPWT. So you stand to gain 2,500. You could share a little small money, fraction of it with me, because I'm giving this idea to you. Okay. So these are some of the results, pre and post suction. All kinds of wounds are amenable to negative pressure wound therapy, upper limb, lower limb. So, okay, even if this is good, this is better. 5 days of negative pressure wound therapy application. And this is what I'll briefly tell you how, but this is all known to you. So all that I want you to know is that to add an interrupter, which is a selenium valve, provide an irrigation port, and provide an oxygen port for treatment. So these are the, is there no sound?
You must see and decide that how it is easy and how it's convenient.
Yes.
And you can irrigate the wound as much you can in a day, 2 to 3 times or 4 times through hydrogen peroxide, normal saline, and you can also provide low dose of oxygen supply to the wound for the better management. And this is only meant for IPT patients, those who are admitted, because it is not like commercial one. So let us start the video and I will explain how it works and how it can be set up
So these
properly.
2 ports you
This
see
is a
behind
deep
this,
injury
one
of
is
right
for
elbow,
oxygen, the other is for irrigation.
post-traumatic with no bony injury. Now we'll see how we will put here the things required for NPWT application. The upside 2 numbers of rails to 18 gauge, 1 transfer, sterile gauge, surgical care gloves, drip sheet, kidney tray, instrument tray, hydrogen peroxide, normal saline and stellium. And for the machine setup, we need sponge, machine and vacuum circuit and a circuit for oxygen supply. Before application of the NPWT, first of all you have to debride the wound as much as you can to remove all the debris, necrotic tissues. Then you can send the culture sensitivity. After that, a hydrogen peroxide was to be applied for cleaning of the wound. Now we will apply the sponge, which are spores of 0.03 micron. You place the sponge according to the size of the wound. Now we are going to place a rice tube with
you can stop
multiple holes.
here if you want. It is all known how to dress the wound and make it
the wound and for continuous suction.
So
this is the method.
Okay, so this is what is precisely done today, incorporating the irrigation dual system with a port for oxygen. If you have any questions, this machine, the manufacturing cost will not be known to you, but it is like 10,000-15,000 rupees. It is made to order. In fact, this has been developed by somebody whom I know. He's from Mumbai, so he has prepared it with my inputs. It is not commercially available, but if you want, we can always give you. It is very easy. Even your technicians can do it. You don't have to really help. But if you've seen the results, they're way different than the process of dressing and antibiotics, the traditional dressing and antibiotics. That I can say.
Well, these are very cost-effective methods, and as you told already, can be used most of the places. I have a question about the biofilms that have been done with these wounds mostly. In that case, when you put this particular one, how does it affect? Number one. Number two is the integrity value of the oxygen you are supplying. Because we know about our other fluids and all that, they are sterile. So what about the integrity of the oxygen you are supplying from the source?
Oxygen, it is the wall suction. You give it to the patient in ventilators. They don't go
That,
into
no, ventilator, there is not open wound, na? That's why I am telling you. So when you take in laminar flows, you have to put a HEPA filter.
Yes, of
So
course.
do you have such type of filter in your oxygen
Of course,
system?
there is a bacteriological filter added to this oxygen tube, of course.
Yeah.
Is there any evidence that the raw area absorbs the oxygen you are
Yes,
passing?
TOT, which is topical oxygen therapy, is totally different from HOT of Dr. Vijay Kumar. It is under normal pressure and it is surface irrigation of the wound. So there are papers which show that topical oxygen therapy helps in wound healing by providing more oxygen to the site, as simple as that. And there is a dwell time, of course, there is a dwell time which you can adjust. We usually give 5 minutes dwell time, 2 minutes of suction, and then 5 minutes dwell time, 2 minutes of suction.
Thank you, sir. Thank you,
Thank
sir.
you.
It's a nice presentation. So, for the next position, I would like to call upon Dr. Vibhuti Bhushan Naik, Head of the Department, Plastic Surgery, SC Medical College. It's a video presentation on primary bilateral cleft lip and nasal correction.
Respected Chairperson, dear colleagues, a very good afternoon to all of you. I think the cleft surgery is the one which shows the craftsmanship of a plastic surgeon. No other plastic surgery probably shows the craftsmanship, because many patients or many relatives have seen the cleft and seen the transformation, and the craftsmanship of the plastic surgeon is obvious in such cases. During my residency days, at least 2 or 3 cleft cases used to be in the OT table. And I think all my seniors have had adequate exposure to cleft. And few plastic surgeons down the lane also had adequate exposure to cleft. But the time has changed in the last 2 decades. And cleft is taking a backstage. I'm extremely happy there have been 4 cleft presentations today. And we have amongst us, not the king of cleft, but the emperor of cleft, Dr. Subodh Singh, who has had the highest series of cleft in the world. And I respect him so much because he is the one who is holding the fort of cleft surgery, and there we need many more like him to come forward and take up cleft surgery in a big way, just to see that it remains within the domain of plastic surgeons, which is under threat now. I still do a lot of cleft, though my domain is microsurgery, and I chose to speak on cleft because I know most of the conferences right now are not focusing on the cleft. So I'll just show you a video presentation of bilateral cleft lip, please.
Good afternoon. I'll be presenting bilateral cleft lip repair. So this is a case of complete bilateral cleft lip and cleft palate with a protruding and malrotated premaxilla. You can see the protrusion and malrotation, complete cleft lip palate. So the center of the Cupid's bow, 2 mm on either side, and the white roll being marked. Now 1.5 mm on either side. This is the filtral column. So 2 mm on the lower end, 1.5 mm at the upper end. 2 mm on either side of the filtral column. This is to incorporate deepthalized tissue to form the filtral column. Rudolph's point and 2 mm white roll flap for the left lateral element. This is the Vorpilian flap and mucocutaneous junction on the lateral element. This is the highest point on the left lateral element. Rudolph's point, the white roll flap, the Vorpilian flap for the Vorpilian tubercle, and this is the mucocutaneous junction and highest point on the right lateral element. So marking the incision for the anterior palate and the floor of the nostril. Now the mucocutaneous junction in the nostril. The alar rim markings for open rhinoplasty approach. I do open rhinoplasty at the time of bilateral lip repair. So infiltration 1 in 2 lakh adrenaline. Just reinforcing the markings, which are little so the reinforcing the marking, it will make it easier for the incisions to be taken. This is tissues to be deepthalized and used for the filtral column. Incising the filtrum. And deepthalizing the tissue lateral to the filtrum. So this deepthalized tissue will be the filtral column. It will augment the filtral column, so that is why we have extra tissue, we are then incorporating it. This is the prolabia being raised. The alar rim incision, 2 mm behind the alar rim. This is got access to the lip. Now the anterior palate and the nostril floor mucosa on the middle side being dissected. So here now the the lateral element being dissected, the vermiculum flap, the mucocutaneous junction being incised. This is the vestibule mucosal junction of the L flap of the left lateral element. Now releasing the orbicularis oris from the anterior surface of the maxilla and the piriform aperture. So here you can see the anterior surface of the maxilla. Here we are doing a subperistral dissection. This is the piriform aperture. You can see piriform aperture and the muscle being raised. Now dissecting the muscle from the lateral element, about 1 centimeter of the muscle being dissected on mucosal and skin side. So incising the right lateral element, releasing the vestibule and the L flap on the right side. Now again dissecting the anterior surface, dissecting the orbicularis oris from the anterior surface of the maxilla. Now you can see the intraorbital nerve, so we can go up to the zygomatic arch. Now the muscle being dissected in the lateral element, about 1 centimeter from its edge, from the mucosa and as well as the skin. Now raising the nasal mucosa and the vermicular mucosa from the medial side. The leaving behind a strip of vermicular mucosa so that the vascularity is maintained. Now we routinely do rhinoplasty in all my bilateral cleft lips. So dissecting the alar cartilages. This is the medial crura being dissected off. You can see the this genetic tissue in between the two crura. So that is what gives it a broad tip. This tissue is being dissected off. Bleeding in the prolabium. You can clearly see the vessel that is preserved to the prolabium. This is how the cartilages will come together. Now repairing the nostril floor and the anterior palate with a 4-row vehicle suture. This is on the right side, right nostril floor, anterior palate, and reinforcing it with L flap. So this is the bilamellar closure. So it will give protection, and the nostril floor being repaired on the left side, and the L flap again to protect the suture line. Now this is the alar stitch. It will move the nostrils close by and the orbicularis oris will be approximated at the base of the columella. You can see the alar stitch now. This is the most important stitch. Now trimming the pro-level mucosa to develop the sulcus, and this stitch will be taken close to the anterior nasal spine so that the sulcus is nice and high. We have a deep sulcus now. Now reconstructing the orbicularis oris with 4-row vehicle. The knots are being taken on the nasal side or the oral side. So once we get the sphincter reconstructed, now doing the rhinoplasty, we have dissected the cartilage, now getting the hip reconstructed, the crura being sutured. This is the midline stitch, lowest point of the cupid's bow, the highest point of the cupid's bow. Now you can see the deeply placed tissue, we have extra tissue on either side. This will give bulk at the filtral column enhancement after closure. So doing the skin closure. So here you can see that the nostril has moved medially, and here we are repairing the Barbilian tubercle, a closure of the Alladi incisions, all with 6-O-proline. If the patient is from far off, we prefer 6-O rapid micro. So the sulcus stitch. Now you can see the highest point of the cupid's bow, the philtrum on either side, and the filtral tubercle, well-formed filtral tubercle, the sulcus, deep sulcus, and the tip also is better. You have now the nose looking much better than what we started off with. So we put a stent prepared from the suction catheter, 16 number suction catheter, and fix it because while sneezing it might come out. This will be removed at the time of discharge. Now this is the post-op. You can see the nasal shape and the lip, the filtral column, filtral tubercle. Thank you for a patient healing. Good afternoon.
One question. Any question? Or comment?
So my purpose was to induce interest in the cleft. If there are no questions, it implies still the interest level is not that high in cleft.
No, the questions are not there because the video was so well self-explanatory. So this is, I would say this is one of the best technique to do bilateral cleft lip repair. So the bilateral cleft lip repair, unlike unilateral cleft lip repair, there are so many techniques. And there were so many techniques because people were not satisfied with any one of them. Right? So unilateral had initially 2 or 3. In McCarthy, when we were a student, there were 12 techniques described for bilateral. And from Manchester to Malikan, there are so many techniques. But none of those techniques get a good nasal appearance. But this primary open tip bilateral cleft lip repair gives a good nasal appearance as well and a good nasal airway. So I've been doing it for more than 15 years now. I have many long-term results as well. So I would say the worry that many cleft surgeons may have is that if you raise the prolabium up to the tip of the nose and beyond, what will happen to its vascularity? And I want to assure you, doing more than 1,000 bilateral cleft lip repair by this technique, that it has a robust blood supply. You have to be close to the bone premaxilla when you start, right, and keep a thick soft tissue in the prolabium, and there is a very good vascularity in the prolabium, and it will never ever necrose, never ever have a ischemia. So this is an extremely good technique, very well done. Thank you so much. My compliments.
I just want to add to this that secondary rhinoplasty in a bilateral cleft lip where you have got excellent lip result, it's extremely tricky. And you don't know where to borrow the skin and lengthen the columella. So the results with primary rhinoplasty are all superior than secondary cleft lip.
Thank you, sir.
We have a question. We have a patient. The grandmother and grandchild both were there, including the mother. The child had the surgery, routine surgery, and the mother also. But the grandmother came at the age of 53 years. So what is your take on those cases with a protruded premaxilla?
See, protruded premaxilla is always a challenging situation for a cleft surgeon. You will always feel comfortable if everything is in balance and repair becomes easy. So once you have protrusion, you have to use some methodology to get it back. If orthodontics do it, if you don't have, then mobilize the muscle and repair it even in a protruded premaxilla, because that is one which is going to mold the premaxilla over a period of time. That's a pure surgical orthopedics.
But this was a lady of 53 years, so that's why I asked.
Thank you, sir.
Yeah, in the 53-year growth is not an issue. We can do a premaxillary setback.
Thank you, sir. This concludes the session. I thank my co-chairperson. So now I may hand over the mic to the master of the ceremony.
Thank you, everyone. Now moving forward, I would like to request for the next session our founder, secretary and immediate past president of Apraso, Dr. Sunil Kumar Raut sir, for the presidential oration. Please, sir. I would like to request sir to the podium.
Raut, he was the past president, and he was in 2023-24, and he is now professor in the head of the department of KIMS Hospital. He did his MCS from. He is senior consultant professor plastic surgery in KIMS Hospital, ex associate professor head of the department Burns Plastic Surgery, AIMS Bhubaneswar, an alumni of PGI Chandigarh, APSI International Fellow in Craniofacial Surgery, author of 24 scientific articles, 2 chapters in PG levels, general surgery textbooks, associated editor and reviewers of the IJPS, is the founder, secretary and immediate past president Apraso 2023-24. I request Dr. Sunil to start the session. Presidential oration.
Respected chairpersons, my teachers, dear colleagues and students. I think I don't need any introduction to this house. Everybody almost knows me. So last year only we decided to start this presidential oration in all annual meetings of Apraso with the immediate past president to deliver this oration. So I feel fortunate to stand before you all and deliver this oration. This oration is nothing but the glimpse of my career so far as a message to the younger generation, particularly the younger surgeons and upcoming surgeons. To start with, when we were general surgery PG students, plastic surgery in Odisha was less known, and by coincidence, when I did my MS from VSS Medical College Burla, there was no plastic surgery department there. I thank Dr. Mahesh Mandal, who has started there recently, the department. So we just knew few names of our pioneer plastic surgeons like Professor Bina Das and Professor Narayan Nanda, Professor Vijay Lakshmi Madam, Professor Jagan Mohan Das, Sudarshan Baliyar Singh sir, Nilambar Acharya sir was practicing in Raurkela IGH, and Professor Falgun Rai sir. Apart from others of the next generation. So when I completed my MS and preferred to do in super specialty, so in fact I started working in CTBS first in Delhi, Ram Manohar Lohia Hospital as senior resident. At that time my friend Lakshmi was doing in the same hospital senior residency in plastic surgery in Ramanohar Loya, and both of us were preparing for these two different branches, but subsequently I found that I should not, for being futuristic, it's difficult to take up cardiothoracic surgery as a specialty. So I also choose to prepare for plastic surgery and take up, because it was interesting for me since our subject plastic surgery has the variety and also the adventure. And like Vibhuti sir was presenting just before me, the bilateral cleft lip and palate. So satisfying visible outcome. In many of the procedures in our specialty, we have satisfying visible outcome, at least for us. Then the subject is ever evolving. Of course, many other medical specialties, surgical specialties are also evolving, but our subject still, and even now also, has a great future ahead. The techniques are evolving. Bijay Kumar sir was showing hyperbaric oxygen therapy, and there are laser, robots, many things are coming up. And we can practice, we are free to practice many of our procedures even in the smallest of the setups, smallest of the towns. Not only the advantages, every thing has some disadvantages also. So we have demerits being not organ specific, so we need to explain every time people that what as a plastic surgeon we used to do. It's a common question even I personally facing from the first day of my practice. My neighborhood people ask, plastic surgery, what do you do here? In Bhubaneswar there is no cosmetic surgery. Plastic surgery means people know that cosmetic surgery. They immediately ask whether in Bhubaneswar or Odisha we have so much of demand for cosmetic surgery. You are working in a big hospital as a plastic surgeon. So we need to explain the people that other than cosmetic surgery, there are many lot of things we do in our specialty. And we have a lot of subspecialties. So even after MCH also, I am sure that our students will be wondering that what we will do next, and which subspecialty we will take up, and we will go for the further training. In practice, the most important thing is majority of our procedures are not covered under insurance or many government packages. So that is another hurdle for us. So still with that, our subject is lucrative. As of now, I don't find any demerit or any discouraging phenomenon not to take up plastic surgery as a subject. If my kid prefers to do plastic surgery, I will never say no, don't take. I will say yes, you take up plastic surgery as your career. So after completing my MCS, I was influenced by there are many people to influence, but at least from Odisha, when I came across and shared my feelings, my thought with seniors like Falgun Rai sir, Subrat sir, and even Vibhuti sir, when attending many conferences, these are the pictures mostly clicked outside when we go for conferences, because even if we were working in neighboring twin cities, still hardly we get any opportunity to interact. By that time, we didn't have this forum, we didn't have Aprasocon. So, apart from many other people, these seniors, teachers have become my inspiration and factors of encouraging in my practice. So coming to the training part, basic training is getting opportunity to be trained in a good institution is always a boon. So that way I was fortunate to be an alumnus of PGI Chandigarh because at that time probably it was one of the best institutions providing training opportunity to the MCS students. And of course hard work and sincerity is always necessary to achieve or to reach higher levels or next higher level. We need to update ourselves technologically because so many new techniques are coming, so many computer softwares are coming. So those are involved in the investigative area, treatment planning, surgical, photographic. There are so many things, and of course nowadays a lot of video libraries available, a lot of operative videos are available, so we have to be conversant so that we can obtain those and utilize it for our further progress in life. Guru Brahma, Guru Vishnu, Guru Deva Maheshwara. There is no second thought about that. So again, fortunate to be the student of some of the pioneer teachers of our country like Professor Ramesh Sharma, Professor Gautam Biswas, and this that bottom picture, maybe the junior people may not be knowing Bipul Nanda sir, who is now practicing in Delhi, had been my teacher and a great personality. And I always say that when we were trainees from 2002 to 2004 was the tenure of my MCS. At that time, he was one of the finest cleft surgeon of India, especially palate surgery. When Brian Summerlad was being invited to demonstrate his procedure of radical muscle dissection, he was doing and demonstrating, Bipul sir was demonstrating to us, the students there in our own theater. Of course, because he had been with Dr. Summerlad for about 6 months or so. So he had a fellowship with him. So before it was being popularized in the country, he was almost mastered in that technique. So we had a very good cleft training from PJ at that time under him. And apart from him, my veteran mentor Sudarshan Baliyar Singh sir is here. So I am fortunate again to be associated from the day one of my practice. After I passed my MCS, immediately I came down and joined in Kalinga Hospital, and sir was the main mentor for me. The quest for learning should not stop. It should continue. And I think it never dies. It should never die till we till we take our last breath. So in order to have the further training after getting the basic degree, one can learn the things by attending various conferences. One can learn further by attending operative workshops are very, very highly beneficial. Nowadays, if not possible, then at least operative video workshops. And visiting centers of excellence is equally or more beneficial. Watching experts performing a procedure, rehearsing with models, surgical videos, all these are the ways to fine-tune your training. So this was the early part of my practice. I had been to Taipei with Subodh sir and Vijay Kumar sir, many others we were meeting at that time, Arun Singh sir, the veteran cleft surgeons, teachers of that genre. And it was in Taipei. Vibhu sir is also there, Falguni sir is also there. So we had been from Odisha. So I got an opportunity to be with Dr. Samuel Nurdov. And these are the opportunities when we utilize to learn something, to ask some doubts, to clarify by the great surgeons. So we have to invest in our early part of the career, to visit different places and learn the things from the experts. Same way in other cleft conferences, cleft craniofacial conferences in Dallas that year with Dr. Ken Sellier, and in Fort my friend Lakshmi also joined me to Fortaleza. We had a nice time, and subsequently in cleft conference in Moscow. Then comes training, proper training wise. Had my first official fellowship in San Francisco University, hand and microvascular surgery for 1 month in the year 2008, when this young man was the head of the department of the chief microvascular surgeon of that hospital at that time, Dr. Hansen, Scott Hansen. We invited him to our Bhubaneswar Aprasocon in 2019, and I was there for 1 month, attending all his OPDs and OT, seeing the intra-op, post-op follow-up patients also. So I suggest any younger surgeon going for training to any center, good center, should spend some time so that you can have an opportunity to see the follow-up also and not only the intraoperative. Then it was another opportunity and blessings that I got selected as ASPS International Scholar in 2012 when I had my training in craniofacial fellowship and craniofacial surgery, and fortunate to spend 1 month with the veteran craniofacial surgeon of New York University. Everybody knows Dr. McCarthy. Now, coming into the business in Kalinga Hospital, by that time it was an approved Smile Trend Center, and it was the lone established tertiary care hospital at that time with all super specialties in the state, and a lot of CMF trauma and extremity trauma with operative microscope and all gadgets available. So blessed that way to start my career with all the good things, and over and above that with Baliar Singh sir, senior Baliar Singh sir as the mentor. So I got an opportunity to operate like a lot of cleft patients and lot of trauma. So these are some of the cleft children we operated at that time, and an example of unilateral cleft lip, bilateral cleft lip, palate. Some of the children after grown up, you can have nice speech. सुने क्या audio? क्या सुने? देख लेते हैं। ठीक है। Good. Okay. ठीक है। So it's a nice piece. Somehow the audio is not working. So okay, the audio is not coming. So some of the children I operated have grown up and become 20 years now, and they are doing well in their respective area. They have completed their studies and completed and going to be ready for the future, like job and other career. Then coming to microsurgery, started doing the like any beginner, the common surgeries like radial forearm and fibula. I want to mention here, I don't hesitate to express my failures. My first 3 consecutive free flaps in a corporate hospital, working in a corporate hospital, failed. Even after that, I didn't lose my courage, I didn't lose my interest. I continued, and these are the initial successful cases we did. And let me admit, even at this point of time also, I say everybody, in front of everybody, that still I have about 5% failure rate in microvascular surgery. Last week only, I lost a free ALT. So I don't hesitate to say that, because there is nothing wrong to accept your own failure. The failure can be because of so many factors in microsurgery, not only because of my technical fault. So it's a lesson to the younger generation that they should not hesitate or they should not stop doing something if having a complication in one area. A free fibula for mandible reconstruction at that time, almost a decade back. Then obviously in every area, in every career, every profession, once you mature or grow in seniority, you will take up the complex things in your career. So the pendulum shifted from pre-radial forearm fibula to DIA, medial femoral condyle, vascularized lymph node transfer, and similarly in cleft lip palate surgery, from primary lip repair, palate repair, secondary reconstruction to leaflet osteotomy, from CMF fracture fixation to difficult TMJ, ankylosis cases, distraction osteogenesis, craniosynostosis, from liposuction to autologous fat grafting, from simple congenital hand to complex congenital hand, from simple brachial plexus reconstruction to functioning muscle transfer. So things evolve like this, and same happened with me also. So this is the DI flap for, done for breast reconstruction in a case of post-mastectomy woman. The anastomosis is done with internal mammary vessels. This is interesting. For the first time I read from the book and did the medial femoral condyle, a small bone graft used for vascularized bone graft used for a case of avascular necrosis, scaphoid fracture non-union, and we confirmed in fact in this case there is a skin paddle based on a perforator of that artery. Based on the main vessel was from descending genicular branch of femoral artery, and also we did a radionuclide technetium scan to ascertain the vascularity of the transferred bone, and it was fine by after about 6 weeks. So then craniofacial surgery, similarly I would like to mention here that the dream of doing craniofacial surgery I cherished for almost more than a decade to start, almost like 15 years after my basic training and top-ups in the form of craniofacial fellowship, all these. We started craniofacial surgery, I started only after joining at AIMS, and we could do few cases of craniosynostosis and Le Fort and monoblock osteotomy. This is one example case of oxycephaly craniosynostosis case, pre-op and intra-op. This is the post-op outcome. Nice, smooth, the torricephaly is gone. Nice, smooth appearance of the scalp and the forehead as well as the vertex. Then distraction osteogenesis also, the huge number of CMF fracture treatment given me the boost to take up the distraction osteogenesis, and I did a fair number of distraction in mandible. In some cases variable distraction or differential distraction on both the sides. This is a post-traumatic case with severe retrusion of the chin, bilateral mandibular distraction. Then it's a case of Apert syndrome where I did the monoblock osteotomy and red distraction of the entire anterior face. This is the pre-op and post-op result. Of course, it's not the best thing I was expecting. TMJ ankylosis is another area we must, I would request our surgeons, all entire house, to keep in our clutch, because the thing is another thing which is going from our hand. So anybody, anytime find a case, it's I believe any beginner also can do this case. It's not like that something will have a massive complication. So we must keep doing these cases. This is one example of difficult TMJ ankylosis, recurrent TMJ ankylosis with bad deformity and mouth totally closed, and after 4 surgeries. First TMJ release with interposition arthroplasty, and next sitting distraction, mandibular distraction, both the sides, and it's a differential distraction, and finally distraction removal, 3rd surgery, and 4th one was autologous fat injection to whatever soft tissue deficiencies. So the final result came after 4 surgeries and of different types. This is a case of adolescent girl I operated for cleft lip and palate. The bad, very white cleft when she was an infant, and did the Le Fort osteotomy, Le Fort 3 osteotomy, and distraction with the red device. A case of congenital microsia of one side, ear reconstruction, total complete ear reconstruction was done with cartilage framework harvested, prepared from costal cartilage. Vascularized lymph node transfer, I got an opportunity from my onco team that they have a patient with massive edema, lymphedema of the right upper limb following radical axillary dissection and for a CA breast and brachytherapy, radiotherapy. So we did the first time we did the vascularized lymph node, free vascularized lymph node transfer from cervical area, supraclavicular lymph node based on transversocervical artery and veins, and implanted in the wrist area with anastomosing with radial artery and cephalic vein. Cosmetic surgery is a dream for every plastic surgeon, be it young or senior. So, got an opportunity to do several cases. One of the initial cases of breast augmentation in a female. Reduction mammoplasty again. I would like to mention here once again the first patient, the left one. That was my first reduction mammoplasty patient, and she was a married young woman by that time in her late 20s, 27, 28, 30, maybe just about to reach 30, and she was a lawyer by profession. So, for anybody to think about to start a procedure, that to cosmetic and in a lawyer, the patient herself is a lawyer. And she was doing her LLM at that time to aspiring to practice in Supreme Court. So somehow I dared to do, and the patient was very happy with the outcome, and there was no problem from her side at least, although I had a bit of superficial necrosis and hypopigmented area around the NAC. So if you can convince your patient, if you can take them into confidence, doesn't matter whoever he or she may be, and accept your failure. If you have some complication, explain to the patient that yes, complication is about to happen to some percentage of the patient, so unfortunately it is you. So I believe that way. So hardly any patient having complication have ever harassed me by that time, by this time, touch wood again. So another agenda in our early part of our career was my good friend Dr. Lakshmikant is here as the president of our association today, organizing this nice conference. It's in 2009-10, at that time when we were attending conferences together, we were very good friends, used to share the room. So in fact, it was, of course, it was in my mind still. Lakshmi first told me that, Sunil, why not we gather our seniors and start an association so that we will have a presence in the national or international scenario. So we tried from that time, and many people joined after that with the same interest, like Professor Chaudhary. Sanjay was a resident at that time in SCB. He also worked hard for the association, and ultimately I organized the last year's conference, that was the 10th annual conference, after officially being registered. Fortunately, this before registration we had a conference in Puri only, in a different hotel. So whatever number of consultants were there, surgeons were there in the state, we had our first meeting in Puri only, and today we are standing here again in the place of Lord Jagannath. With his blessings, we are conducting our 11th official conference after registration of the association. And we had a significant presence in the national meetings also. This is the picture of the last Coimbatore conference, Aprasocon. We had a big team, and with a good number of papers. I am very happy nowadays that we have a good number of papers. Our students are winning good number of prizes at national level. So all these are maybe the seeds were shown at that time. So I give all the credit to my dear friend Lakshmi for taking interest and bringing the association till this level. Leadership is another thing everybody must learn to have. This is an interesting picture I had during one of my US trip. So the master was standing behind, his shoes only seen. There is a dog over which a cat is sitting, and that white small thing is seen, that's a rat. So, the leader should be somebody like that who knows the strength of his teammates and utilizes wherever possible whoever fits to any role, rather than having an infight between all these mighty animal as well as the smallest animal in the team. So I don't know to what extent I performed my role as a leader by now. That is the other people to judge, whoever have worked with me. But I believe the leadership is this. And I am happy to say that I always prefer to be a team man. I never prefer to fight alone any battle. So that is how in Kalinga Hospital we had a team with Dr. Baliyar Singh sir senior, our mentor, and myself, and Dr. Devidat Mahanti is here only. He was the younger surgeon joined at that time, but we had a nice team. Again I went and joined AIIMS Bhubaneswar. There also we had a nice team. So we worked together. There also we worked as a team, never as a single man. And after leaving AIIMS, in KIMS also, Samir is missing in this picture. So he is present here. So now also we have a strong team of 5 consultants, and we take decisions combinedly for any decision regarding department, any departmental improvement, development, or any sort of thing, even clinical management also. We take the opinion of each other irrespective of the juniority or the seniority. So everyone's opinion matters. Finally, I believe honestly I enjoyed my teachership since I joined the AIIMS. So it's a very nice thing. Teaching is a very nice thing. Many of the seniors and colleagues present over here experience this. So I believe it's a sincere duty of all of us to pass on the baton to the next generation. Whatever we have experienced, whatever we have knowledge we have gained, so we must not hesitate to transfer it or transmit it to our younger generation. That way this beautiful earth evolves, and the technology evolves, and the treatment modality also. So many people, some of my good friends were scolding when I left my practice and entered into AIIMS as a faculty with a non-practicing faculty. So many people asked me at the end also when I left AIIMS that what did you gain? I tell them that these are my assets. So these young people whom I got an opportunity to train with me, Dr. Ratnakar here, there in the top picture, he was our first MCA student, passed from AIIMS. Dr. Aparna is here, Dr. Reena, and Samir is there. He was with us for about 6 months after his MCAs. And these are the present lot of students whom I almost taught 2 years. After that, they are completing MCAs right now. So I believe that they are my assets, and I still aspire that we'll have an MCS course in the present institution I am in. This is the last advice to my younger generations, that publications. So Subodh sir is here, Vijay Kumar sir is here from the National Association, Amrit sir is here, our past president, our proud fellow from Odisha. So one of our previous director of AIIMS used to say that publication is like currency in academics. So if you have 100 publications, that means you are $100,000 rich. If you have 5 presentations, then you are $5,000 rich. So that's a good way to take up. That we must encourage our younger generation to have more and more publications. Out of my 26 publication total by now, I have shown these 4 publications, first 4 publications, because these 4 publications I had before I entered into the academics, when I was in practice. So it should be there that we should feel that even if you are doing private practice, even if you are working in non-teaching hospital, So keep it in mind that, okay, you are doing lot of work, lot of good works. So why not publish it as a clinical series? You are doing regular daily, my younger friends, they are doing almost weekly or 2 or 3 free flaps. So why not keep the records only and publish it? So it will be a good matter and good material and learning material for the future generation. So then only you can, that desire should continue in your heart, so that you may end up like I recently ended up writing 2 chapters for a postgraduate level surgery textbook on plastic surgery. Innovative thinking is another thing everybody must nourish. I always think that when we work with the Dingman mouth gag for palate repair, in a case of unilateral lip repair, post-op. So the Dingman mouth gag doesn't fit well on both the sides of the alveolar hook. So you were using Dingman or some other, I don't know. But people who use Dingman, they might have experienced like me, and that one side arch is usually lower and one side is higher in unilateral cleft lips. So once the child still grows further, like 6 months we operate for lip and 1 year he comes back for palate. So then the Dingman doesn't fit nicely to that. So I always think that why not vertically we can adjust the height. Then I thought of that idea and did a modification to the Dingman. So this is the classical Dingman. Sorry, the voice is not coming. So I can show, this is the classical Dingman. Then what we did is this, I added this vertical plate to the alveolar hooks. So there is a spring, and so that even if the alveolar arches are at different level, so both side hooks can fit because the vertically you can play with. So I have got the patent for this also. By now it's not commercialized, but so I got a patent for that also. And you know, it was I did a lot of effort for that. First I drew with a pencil scale and submitted to some instrument manufacturing company to make a prototype for me and experiment in the patient. So it happens in any type of innovation. So my colleagues who have worked in AIMS with me, everybody has seen that instrument and have some experience with that. So for that innovation, I got the Best Innovation Award in Indo-Cleptcon 2023. Still the popular wordings of Robert Frost. I was sharing with Amresh Baliyar Singh sir that I just completed 2 decades of my practice after MCS. I just completed in 2004 December 31st and started my post-MCS career from 2005 January, and this is just 20 years complete. Still a lot to learn, a lot to do, a lot to share from others. So truly miles to go, and for that thank you all for listening to me. Thanks to all my teachers, friends, even my students who have given useful thoughts at times, and ultimately thanks Lord Jagannath for giving me such opportunities. Thank you all.
Hello. Nice presentation, and you have shared your lifetime experience to the juniors, and mostly it is important for the juniors. After completion of the MCS, they should think for the subspecialties like aesthetics, craniofacials, bones, etc., etc. I think Sunil will need a standing ovation. All will stand and have a applause to Dr. Sunil.
Thank you.
We will have our lunch 15 minutes break, and I request all the delegates to visit the stalls. Very important. Actually, all the sponsors are there. They wait for the delegates. If you get the time, within the time, please visit all the stalls. Now we will have 15 minutes for the break, for the lunch break soon, and we will start the sessions, aesthetic session after the lunch. Hello? Subhani. Good afternoon to all. Now we will start the third session, but before that we have a sponsor program on Triage Meditech, and he will talk on dermal substitute in diabetic foot. I will give 5 minutes for the talk. He will start the session now. Just.
Thank you, Odisha Plastic Surgery Association, for giving me opportunity to present my experience on dermal substitute in diabetic foot. I'm coming from South India. I work as a consultant plastic surgeon in Aster Medicity Kochi Hospital, and I started using this dermal substitutes in diabetic foot 4 years back. So the need for using the dermal substitute was the routine challenges we face in the management of diabetic foot defects. So I found it very interesting that a lot of people, the geriatric population, is coming to us with the chronic wounds, and none of us, we are even including plastic surgeons, we were able to provide the options to cover these defects. The challenges we face in this, apart from the old age, is the PAOD, peripheral arterial occlusive disease, smoking. These patients are usually end-stage renal disease and on dialysis, and also they have a chronic venous insufficiency, coronary and cerebral artery and the coronary artery disease, and the anemia. So with all these challenges, it is very difficult to look for the flap options in the diabetic foot ulcers, because we have limited options for foot reconstruction with the local flaps. And if we are using free flaps in these patients, there is a high chances of failure, and also planning any prolonged surgery requires a prolonged anesthesia and carries the high risk. So another problem we face with the skin graft is that we have a problem of repeated skin breakdown and it may require multiple procedures. So I'll be talking about allograft, which is a dermacell, human acellular dermal matrix. What does it mean? It's basically the technology is that they prepare this by removing the immunogenic cells, that is epidermal and dermal cells, and they preserve the ECM. Now this ECM is very important. In chronic wounds, the ECM is damaged, and the products like this allograft, they help in rebuilding this ECM over the chronic wounds. Now these are very important terminologies. When we are choosing these products, we have to go through the sterility assurance level. There is a standard sterility assurance level which this product have to pass. So any ideal ADM should be having 97% of the donor DNA removed, and it should have a terminal sterilization with SAL more than 10/6. Well, just quickly, I know that this is I have been squeezing the routine schedule, but I am coming from a far place. I have got a flight to catch. I'll just quickly rush through my slides. So all this patient category, they are all 70 plus, 80 plus, and they have all of them, they have come with the exposed bone. Now this is the first debridement, and you can see the base of the metatarsal, the first metatarsal body and shaft has been exposed. And routinely I subject this patient for the angioplasty to get the revascularization done, and after that I use negative pressure wound therapy. And this was and then I build up the wound by using the another products like Metridum, Integra or Polino. But then with this also, finally the bone was not covered. Now what do we do in this scenario? Can we do any flaps? In such an elderly patient who is on dialysis, can we do any flaps with the atherosclerosis vessel? So I started using, this is my first case where I started using this product Dermacell, and to my surprise, within 3 months time, this is after 2 months, the wound is granulating, and the wound is granulating without contraction. So at the end of the 3 months, the patient is happy, and patient doesn't have to come necessarily to your clinic to do the dressings. The patient can do the dressings at home to manage these wounds. Again, the same profile, This fellow unfortunately had a BK amputation on the other side. So this side he was not allowing me to touch, even take a graft, and he is asking me, can you cover this? Now usually standard protocol, I mean after debriding this is the exposed calcaneum. Now can somebody tell me what flap can be used in such kind of patient, 72-year-old male? I'm just curious how many people in Odisha use ADMs. We kept talking about the microvascular surgery and the cleft lip palate which is dying down. I personally encountered these products 4 years back, and I feel this is the future for all the plastic surgeons. So this is the patient. Now I'll say that I achieved this result at the end of it. Now I started from here and I came to this level, and I did not use any skin graft and I did not use any flap. This whole thing has come up with the use of the different type of ADMs where we have covered the bone. I had used metridum in this case and covered the bone, and after that I have used the dermacell, and you can see there is no contracture anything here, and the wound has healed. Coming to other patient, 90-year-old person, this patient we had partly covered the entire area with the graft, but then the small area where the joint was exposed, and I suggested the patient to do a fillet flap. But the patient was adamant that he doesn't want to do any flaps. Can he allow it to heal by some other method? So again, I used another ADM to build up the granulation tissue, and at the end of it I used the dermacell, and you can see where the joint area is also covered. I mean, it was not only the exposed bone, the entire joint area is also covered. So at the end of the 2 months, we are achieving this result in a 90-year-old gentleman who has been facing this chronic wound for so many months. Coming to the case 4, now after seeing this 3-4 cases, I got little courageous, and this patient actually, I did not advise him any ADMs. I told him straight away go for a graft, but this is a Arab patient coming from Oman demanding that he doesn't want to use any graft from his body. Can I do something different? So again I built up this case with the metridum, and I used a dermacell in it, and this is a person who's doing the dressings on his own. Last Aprasocon when I presented this, people asked me how do they manage the dressings. I mean, there are various modes, simple dressings which people can do it at home on their own, and this is after the second month and 3 months. You can see the entire wound has granulated. You can see the center, some area is to be healed, but this is the wound which has healed on its own without any contracture. Now coming to the last case, this is a case where the 85-year-old gentleman, he had a heat burns. He was again an international patient from Oman. A car got stuck in the road, and he was on the road for 2 hours, and the entire skin had become ash scar. He was debrided multiple times in his country, but when he came to us, he had a thick ash scars over this bony prominence. You can see these are after the debridement, you can see there are 3 places in which the bone is exposed. One is at the medial malleolus, another at the tarsus, and at the first TMT joint. I again built up this area with the metridum, did the negative pressure wound therapy, and I did a simultaneous skin grafting, and at the time of skin grafting I used the dermacell. And this is the last month when I saw this patient. He has completely healed except this small area over the exposed medial malleolus. I think that area where we could not trim too much of the cortex from the bone. Otherwise, if you take out the little bit cortex from that area also, the wound will heal fast. So this is after 3 months where you can see where we started and where we have reached, in the 85-year-old gentleman. So I feel as a plastic surgeon, I started attending podiatry meetings, I started attending DFSI, and I understood that we plastic surgeons ignore this territory which we can easily and nicely make it heal. Being advanced in wound care, nowadays in DFSI con I see plain MBBS, internal medicine doctor and general surgeons labeling themselves as a podiatrist. They are doing this kind of a job, and I don't have any shame in saying that I learned all these techniques from them 4 years back, and now I am regularly using it in my practice, and I have helped a lot of geriatric population in saving their limbs. Many people, they have come for the amputation in such kind of a scenario where they are not able to do anything, and surprisingly many plastic surgeons, they don't know how to use this product. And I think like microsurgery was something in 80s, the dermal matrices is something which we need to learn and which we need to put it in practice for the patient's benefits. So this is a short video of how do we use this product. I don't have much time, so I'll just quickly go through my protocol. So any patient who comes to me as a diabetic foot ulcer, first thing, I mean, you do whatever you want to do. If you don't augment that arteries by doing any kind of a vascular intervention, be it as an angioplasty or be it as a bypass, you are not going to reach anywhere. So vascular augmentation is the first thing. Nowadays I have started using stem cell injection into the calf in the patients where we can't do any angioplasties, and that has also given me a good result. The next thing is, as a plastic surgeon, where we come into play is that I have seen many podiatrists, they keep on playing around with this wound by doing some bedside debridements. But as a plastic surgeon, if we do a thorough debridement of these wounds, proper fasciotomy, proper tissue cultures, we can get this area covered very well. So after doing the debridement, I use all the patients, I use negative pressure wound therapy to avoid the biofilm formation. I build up the area by using one of these three methods. And at the end of it, if the patient, nowadays I myself offer the patient, instead of skin graft, dermacell option, provided they are ready to manage themselves at home. They necessarily should not come to the hospital. They can come just once in a month, and we can get a good result. So these are the key to success to achieve the good wound healing in the dermal matrix. So those who have come late, I just would like to show this final side. I always get thrilled to see this patient all the time, because if I would have been during my residency, my HOD would have told me to do a reverse oral flap, which has got a high percentage of failure. But this is without using a flap and without using a graft, we have achieved this kind of a result. Okay, thank you once again. Now I saw some people sitting here. So thank you Odisha Association for the opportunity to give a talk.
Thank you, Dr. Manoj. You have said you have a lot of experience in the dermacell. Dermacell, actually, I have also used one cases recently, and I am waiting for the result of this dermacell. And I think your results are fantastic, and we will use. I request all my delegates can use also this one, this triage. Thank you very much. Now request Ruchismita to start the session, aesthetic session. Huh?
Warm good afternoon. This is Sangeeta. Yes. Yes. As we successfully completed our 2 sessions this morning, now we are heading towards the 3rd session of this day on aesthetic surgery, and for that I would like to call the chairperson to the podium. Please welcome Professor Dr. Falguni Rai ma'am. Sir, sorry. Please welcome Professor Dr. Falguni Rai sir. My mistake. Please welcome Dr. Subrat Jena sir and Dr. Satya Swarup Tripathi sir to the podium. Let's have a huge round of applause for our chairpersons. Over to you, sir.
Now we are going to start the 3rd session. Already we are late by 1 hour. So we have to keep in mind the exact timing. So now I request Dr. Akhay Raut. Where is he? Dr. Akhay Raut, please. Dr. Raut doesn't need any introduction. You can straightway go to your presentation.
Respected chairpersons, esteemed delegates, very good afternoon everybody. My topic of discussion today is augmentation rhinoplasty in relation to ethnicity. Next. Ethnic rhinoplasty is a cosmetic nose surgery. Reshapes the nose to enhance the facial features while preserving a patient's cultural identity. Okay. And it is a specialized procedure that focuses on harmony and individuality. Uh, I should say that when we are dealing with the rhinoplasty, patients are coming, they are saying that, sir, do my nose like Amir Khan or Aishwarya Rai. Because we are from eastern zones, so our facial profiles should match to the nose. And that should not be shown that it is like placed a artificial nose on the face. So my topic of discussion, the gist is we should keep the ethnicity intact and giving the identity and individuality of the zone. So eastern zone people should look like eastern patients. So rhinoplasty accordingly to be planned. And technique achieve desired result. I usually use cartilage graft either from ear or rib, conchal or costal cartilage, and bridge the augmentation. Synthetic material or autologous tissue used to enhance nasal bridge. And it is patient specific. Outcomes are based on patient's unique characteristics and goals, include relationship of forehead to the nose, the shape of eyes, cheek and mouth, and width of the nose. And this is the typical Odisha type nose, eastern zone, and that is post-op picture. And this is also another keeping the ethnicity in intact. And this is our typical ethnic nose, that is depressed bridge, depressed radix. There is hardly any nasal bone available, and the tip is wide and depressed. So I usually do open approach. Open approach is most effective way to perform the ethnic nose. It allows careful evaluation of underlying nasal framework and accurate reshaping. And type of procedures, either augmentation or reduction. And today I am presenting about augmentation only. And rhinoplasty on Indian nose, especially Eastern India, involves custom approach due to their unique nasal structure. Indian nose often have thicker skin, thick bone, and that easy to perform, easy to give the shape and result, and requires surgeon's precise skill in refining and give the precision. And there are three main factors surgeons should consider while doing the nose: dorsal height, tip projection, and alar base. And this is the incision given at the narrowest part of the columella, and it is the external approach after injecting the adrenaline saline. I give that dissection going on, and there is little bit bleeding is there because that is not hypoanesthetic anesthesia is given, so hypotensive anesthesia not given because of some issue with the patients. A little bit faster. Sound is not there. Sound is not there. So this is the cartilage framework has been deglobed and so on. And make that skin envelope as thin as possible so that it will be easy to re-drape later on. And in that process you will encounter the Pittangi ligament. It's a purely a preservative surgery, so that Pittangi ligament can be kept intact so that later on there will be not a drooping of the nasal tip. अरे ठीक है फास्ट कराओ. पिक्चर देखिए पूरा अलग same thing is going on, na? So that is the pitting ligament that has to be kept preserved so that will keep that tip elevated and up. And that is the coastal cartilage that has been harvested. And this is the cartilage has been to prevent the warping, that it be small pieces that has been cut. I use that skin grafting blade, half of the skin grafting blade I use. And that has been sutured together to make it a material for the augmentations. And this has been so tightened to make it a one block. And that has been wrapped with fascia. That fascia has been harvested and that has to be wrapped up. That has to be cleaned properly, otherwise that will the source of infection only. So for that reason that has been cleaned absolutely. Next is the conchal cartilage I used to take. I'll show that.
Is it last one?
This is last.
Last.
Then, sir, only I will show some clinical cases. That is last. This is the pre-op nose, and this is the result after augmentation rhinoplasty. This is a ethnic nose, tribal nose, and that has been augmented. This is another one that has got augmented. This is also a typical nose augmented with costal cartilage. This is another one, and this is typical that depressed and bulbous deep nose that has been augmented. This is another one. This is also another one. This is a boy having crooked nose that has been corrected. This is another tribal girl that nose has been corrected. And this is with conchal graft. Another conchal graft has been used. This is a northeast girl that has been augmented. This is another girl. This is another one that has been augmented. And everything is not a bed of rose only. So sometimes it happens when you give silicone implant also that got extruded and that has to be removed. And the two cases I got the complications. So challenges are there. The ethnic rhinoplasty, that is wide range of facial structures, nasal shapes, aesthetic preferences to be taken into consideration. And in conclusion, the cornerstone of augmentation rhinoplasty employs either autologous graft or alloplastic material. Augmentation rhinoplasty particularly beneficial for people with thicker skin where nose natural contour may be less defined. Understanding nasal anatomy, nasal facial aesthetics ratio, availability of augmentation materials has to be taken into consideration and gives a predictable result. Surgery has become more predictable over the years, and future and controversy is there. There is a liquid rhinoplasty that is also people are doing with fillers, but new non-autologous material available, and that is a fibroblast suspended Restylane. Restylane is a filler that has been used and that gives equally a good result, but not sustainable. It may sustain for 1 or 2 years, and long-lasting fillers like calcium hydroxyapatite also people are using, and that gives a good result. Thank you all.
Thank you. We wish we could give you some questions. Will you like to have some questions here, or you can catch up with him later after this, because we are getting a little late. Is that okay? So I would request anyone who would like to discuss the details of the steps of augmentation rhinoplasty, Dr. Akshay will be available.
Okay, thank you.
Thank you very much. Before I call the next speaker, I would like to say that there are some changes in the session. The fourth paper of Dr. Lakshmikant Mishra, he has been kind enough to swap his paper with Dr. Satyaswarup Tripathi, and he will be talking in place of Dr. Lakshmikant Mishra. Is that all right? And topic is there. Topic is as before. No? Anyway, and Dr. Santosh Panigrahi also has been magnanimous to give his space to Dr. Devi Prasad Mahapatra. So Dr. Devi Prasad Mahapatra will come in his place. So may I now call Dr. Ruchi Gupta to make her presentations? Is Dr. Bhartendu ready, or? Okay. Okay, sorry Dr. Gupta. The first paper is coming in from Prabhasi Odia, Dr. Bhartendu Swai. Okay. So we have our Prabhasi Odia, excellent plastic surgeon, Dr. Bhartendu Swai, will be presenting on an extremely important topic for the young and old alike, endoscopy in plastic surgery. Thank you.
Okay. Honorable Chairpersons, friends. This is a topic which might interest you and you would like to take up. So, sorry. So, when you're up against something new, takes some patience and stamina. And my story starts on New Year's Eve, 2002, when this grandfather came with this child and said, I don't want a scar. Now the standard thing then was to do a suprabrow incision and take it out. It's an external angular dermoid. So somehow the hairline was too close and too tempting. So I caught hold of my colleague, GI colleague, to put a scope in and dissect it out. So this is the incision, zigzag follicle sparing incision, and what's happening? It's not moving. So this is the video made in 2002 December on VHS cassette. So the quality will be a little blurred, but I think you can overall make out that it's very easy to dissect out, and you're going subsurface, and you can pull out everything. But you must understand, this is all single port. We don't do, unlike a cavitary endoscopic where you employ multiple ports. I've done everything by single port because single surgeon. So I can't expect someone else to handle the scope. So we do all this. Sped up a little bit. Yeah. So the first time it took me almost an hour and a half. But at the end of it, the most gratifying thing is that the grandfather says, how did you do the surgery? So, that's what it is. We all know, but for a patient, it's something else entirely. Similarly, another middle-aged lady came with frontal osteoma and, doesn't want scars. So you just make a subperiosteal approach, osteotomize the osteoma completely and stitch it back. So you can see okay. So that's the excised specimen, and this is the lady minus the swelling. Similarly, young lady, software engineer, wanted to get married, but this was coming in her way. This blue, not able to. So this blue thing on the right, so I did a color Doppler and came out as a vascular malformation. So she wanted no scars. So that was the challenge, intraoral route. And so this is the endoscopic view. You can see the malformation. It's a bit of a struggle because getting mid-cheek is not easy. So you'll have to use all kinds of retractors and fish it out without bleeding. And this is the excised specimen. And the same lady after surgery. There's no scar. So this is again a young guy, again a software engineer, having a sebaceous cyst of his cheek. So what do? I made follicle sparing incisions in the hairline. You can see bottom right, and excised it at the level of the the connection to the skin. And what you're left with is just a small dot in place of that thing. And this is of course called white magic. A lady with a large lipoma and beautifully placed subgaleal, so you can easily take it out. And that's it, patient very happy. But if most of the lipomas unfortunately are situated in the subcutaneous tissue, supragaleal. So a bit of wrestling is required, as you can see. So today I have, of course, a wider range of instruments to work with, but with basic instrumentation you can actually do most of this work. A bit of smoke, and you have to have a suction for it. Smoke disappears quickly. And then you can deliver it. This was deliberate, this video, because I wanted to get a real feel of how it is when you are actually operating. So one more buzz and then it should be through. Okay, I think we go to the next one. What it affords you is magnification, an unrivaled view of the lesion. Now this is a case where this boy presented with a swelling of the cheek, a firm swelling, and when we went in, I employed a perialar and a vermilion zigzag incision, went in, created a pocket, and this is what you can see so clearly. And when we take it out, you could get a good result without any visible scars. A typical case of a sternoclavicular mastoid, cleidamastoid torticollis, and here it's on the right side. So we make an incision on the anterior axillary fold, just behind it. Initially, the first a few centimeters we go under open vision, and then use the endoscope. Just go above the pectoralis major, the pectoral head and the clavicular head, crest the clavicle, and then you can see that, we're just clearing a path to get there. And in the subsequent steps, you'll see that we are trying to get to the lower end of the tendinous end. So there you are. That's the lower end, clavicular end. And you just circumscribe with a right angle and divide it. And the post-op video. A little too demonstrative, but there he is. This is another technique which I use. I use interpolation muscle flaps, and this is something which you can take the upper part of the rectus. You don't have to take the lower part because you can spare both anterior and posterior rectus sheath. And this is a deep abrasion where the entire metacarpal went out. So we held it to length, harvested this, and did it as a pedicle flap. So the whole dissection was done endoscopic. Give you an idea how it works. The same thing, you just go over the sheath and create a path, and then cut the sheath in the midline and anterior sheath flaps, dissect out the muscle completely and deliver it at the umbilicus. See, that's the anterior sheath we are cutting through, and that's not my hand shaking, that's the speed of the video. So my hands are still steady. That's where we divide the rectus at the upper end and deliver it. This is another case, not the same case, whose video I'm showing. And there you go. That's the pedicle flap. Okay. And this is the same patient. After putting a silicone base, you can see he is able to move the thumb all the way. So we put a new bone graft in there for the entire metacarpal through the muscle flap, and then subsequently did a base arthroplasty. Now he is able to use his hand. Most importantly, can sign a check. So this is a girl with bilateral masseteric hypertrophy. Again, intraoral, use endoscopy, remove the anterior 2/3 in the L-shaped fashion. Yet another case, a girl came to me for rhinoplasty, puffy face. So I counseled her. So what we did was a mid-face liposuction with masseter reduction. You can see the difference. Above series is pre-op, below series is post-op. The angularity of the jaw has been attained, and she has a more streamlined face now than it was before. This is a endoscopic brow lift before and after. So he's struggling. On top right, you can see he's struggling to keep the space between the brow and the upper eyelid edge, and you can see it comes naturally post. And with brow lifts, the improvement happens in increment over the years. Simple thing like a large fibroadenoma, especially in the upper quadrants, where the parenchyma falls away and you can get a small depression. So there, under vision, we can actually mobilize the parenchyma and fill up that space completely. And you can see after surgery, there is no depression left. This is what we use basically, equipment, instruments, these are very standard. The periosteal elevators are important to have, and of course the array of small fine instruments which are used for, like say if there's an entrapment neuropathy of the infraorbital nerve, you don't have to do anything. You just make a small cut, go in, release it, and you're done. This is a picture below with the endoscope just to show the clarity of the structures that you see. Okay, this is not loops. This is endoscopic vision of the of an eye. Again, a case of a lipoma, which was submuscular, intermuscular, and intramuscular. So we just use a top half zigzag intraareolar incision and a axillary incision, used endoscope, got out 3 segments of fat. And post-op you can see there's no visible scar. And so I think from patient perspective, it's a wonderful thing because they don't have a scar. So yeah, I mean, after lunch, you can have active participants and sleepy ones like me. Thank you. I'm done.
Would you like to take some questions now, Dr. Bhartendra? Please. The floor is open for questions, comments. If it's a very big, burning question, then you can actually postpone. If it's a very small and quick question, then you are welcome. Not long ones, Dr. Chaudhary. Very small and brief question, please.
Doctor. Yeah. So,
Doctor, yes.
So what is your say on the carpal tunnel syndrome? Have you used it? Because that is a standard method all over the world as an endoscopic method of
I'm
release.
not an enthusiast for endoscopic carpal tunnel for the simple reason that if there is epidural thickening, you can do precious little about it. So I would rather do an open, a small short open incision, and if you have to track the motor branch, then you can't do anything with an endoscopic.
The problem is the carpal branch, sometimes the radial side you cut it when you do it blindly, or you do it something, the other conventional methods. So in endoscope they tell that you can visualize better.
I just hope that next Aprasocon there will be 2 presentations on endoscopy. Thank you.
Thank you. Dr. Ruchi Gupta, podium is all yours.
Thank you, sir. Good afternoon, everyone. I'm Dr. Ruchi Gupta, and I'll be talking about tips and tricks of breast implant surgery. Aesthetics in breast augmentation surgery is of utmost importance. Breast augmentation is done for hypoplastic breasts, restoring the breast size following pregnancy, weight loss, aging, to correct the breast asymmetries following malignancy excisions, and now that the government is giving more and more rights to LGBTQ community, more and more transgender patients are coming for breast augmentation. The aim of the surgery is to achieve a fullness in the breast, bringing it to aesthetic anatomy, with natural feel, with minimal scars. And like any aesthetic surgery, pre-op planning and counseling of the patient is very important. We talk to the patient about the size of the implant. There is a tapered system to exactly evaluate what size will be good for the patient. The position of the implant, whether it should be put in the subglandular region or the subpectoral region. The access incision should be inframammary, axillary, or transumbilical. Or we have to counsel the patient that in case of, for the malignancies, these breast implants, they cause the distraction in the mammography. Hence, a specific ethical protocol has to be followed to evaluate the patients for malignancies following breast implant. Also, we have to tell them about the capsular contracture and implant rupture. These all things should be taken care of in pre-op counseling and planning. About the size of the implant, when we discuss, we have to, as a doctor, we have to take into account the body frame, the torso size, the breast tissue, skin capacity, and all of them are combined together into tapered system. And most important is the patient's realistic demands. Position of the implant, as all we know that it can be subglandular or subpectoral. The important thing is that subglandular gives aesthetically a better response and it is less painful. But it comes with the problem of implant displacements. Whereas subpectoral are usually done for the following mastectomies in malignancy cases. The fullness is less, the implant displacement is very minimal, but the most important is it gives a better chance of cancer surveillance, recurrence further. So incisions can be inframammary, axillary, periareolar or transumbilical. They all come with their own pros and cons. Inframammary gives a great visualization and control. The surgery is more meticulous, hence capsular contracture chances are less. Axillary gives good visualization with endoscope, but the problem is we cannot put bigger implants. Periareolar gives a good exposure, but as we cut through the breast tissue, the breast tissue bacteria comes in contact with the implant and it causes more of infection. Transumbilical are usually for the inflatable saline implants. Silicone versus saline. Silicone mimics breast tissue better. We have to tell this to the patient and lasts longer, but it takes care of the rupture concerns. And smooth and textured, smooth gives a better natural feel, but textures has less bottoming out and less capsular fracture. I put up this photograph just to show this circle. This circle is very important in implant placement. We use the normal instruments, but these two instruments are my lifesaver. Therefore, I have put them specifically. One is the Ferrero retractor, which has a curved tapered blade, long blade, and another one is the long tip non-polar monopolar cautery with a sleeve. This is a video how it is, how I do it. The most important thing in breast, any aesthetic surgery is the planning, and this is the and how we mark out the pockets for the implant placement. First thing we do is make out the midline, and then from the medial end of the clavicle, I drop down another line which comes along the lateral border of the sternum and takes care of the perforators from the internal mammary artery. Do not go into that region. Next is the midclavicular line on which the nipple falls. This measurement is very important to figure out any asymmetry in the nipple position. Normally we see that no chest is symmetrical. In up to 1 centimeter of asymmetry is always there, and it has to be pointed out to the patient, this asymmetry. And that is how I mark out the pockets. With this marking, the patient goes to the OT. Here the incision is given at the lower border of the pocket marked, and skin and subcutaneous tissue is cut up to the fascia. This is the avascular plane between the muscle and the breast tissue. And we have to move in this plane only, and this I am showing how a long tip monopolar cautery helps me. This improves the vision. I have the luxury of using the laparoscope for the cutting, which gives me a magnified image and longer instruments to cut for the meticulous surgery. So as far as possible, if the bleeding is not there, then we are safe. This is the long retractor which helps to elevate the breast tissue while the cutting is done. After completing the dissection, I always measure out the pocket with the help of sponge and a gauge. This way we remove many bands which may be left during the dissection. This is the implant, the sterile thing. Normally we do not touch the implant, but here I wanted to show this circle, and we always give it a bath with an antibiotic solution. Usually I use 1 ampule of 1 gram micacin. This removal of the packs is done by someone else. We do not touch the skin. Straight away we put the implant into the pocket. And then the most important step is to check that there is no folding of the implant and the circle is right beneath the nipple. Because that is the highest point of projection and circle is right beneath the nipple. The closure of the wound is done in 2 layers, the fascia and the subcutaneous. At times it was said that it should be tucked to the muscle. I did try that, but I found dimpling of the skin. So I do not do that. I do not get the bottoming out of the implant, probably because I do not do any dissection downwards. The whole dissection is above in the pocket. Then the closure is done with the subcuticular skin. This is the result. I always fix the implants with the help of the Dynaplast, not to so that they do not move immediately, because immediately after the surgery there is a maximum chance of its movement. Fix the implant with the Dynaplast. So in post-op care, change of dressing is done after 48 hours. We look for any collections, margins of the wounds, reapply the gauze dressing, and most important is start the support bra. The massage is to be started once the wound heals after 3 weeks. And in complications, as said before, we have to tell the patient about the implant rupture. Implant rupture presents with pain and redness. The MRI shows distortion of the implant with collection, like here. So these things have to be taken care of. Again, I find these words as Bible to aesthetic surgeon. The well-informed patient with realistic expectation is more likely to have positive
Dr.
results.
Ruchi, try to...
Sir, this is the lifeline. Positive results and return to surgeon even in face of complication. Proper planning and meticulous surgery will give you good aesthetic outcome. Thank you.
Breast asymmetry, how do you plan the size of the implants?
Sir, I take it approximately 150 ml of this 1 cup size. So if the patient has 3 C size, then I'll go for somewhere between around 400 cc, something like that. 150 cc is 1 cup. So we measure the cup of the patient, ask the patient which cup size she wears, and according to that I go.
Okay, thank you.
So, do you find allergy to the Dynaplast sometimes?
Dynaplast?
Yeah.
Yeah, sir. We do get, at times the skin peels off. So we use Dynaplast once only and do not use it again. So next time when the patient comes, we have started the support bra for the patient. just a gauze dressing with micropore, and apart from that, I never had this problem. The patient is compliant.
Thank you, Dr. Ruchi.
Thank you, sir.
I'll invite the next speaker, Dr. Bishwajit Mishra. He will speak on my experience of management of gynecology. Dr. Bishwajit.
That we are only 1.5 hours behind the schedule. So please contribute generously so that we can finish up a little early for the rest of the program. Thank you.
So, thank you. It is a post-lunch session. So, what I am going to talk about is not going to explain regarding the detail of the technique, but what I want to tell regarding my finding and what I do. So, why I choose this? Because I am now in a teaching hospital. And though I am now placed in a session where most of the people are doing cosmetic in the private, we are fortunate that in our department we have a liposuction instrument as well, and our students get enough exposure to do even these surgeries. So what is gynecomastia? All of us knows that it is the most commonly classification described in the text is Simmons classification. Grade 1 is small enlargement with no excess skin, 2A is moderate enlargement with no excess skin, 2B is moderate enlargement with excess skin, and 3 is marked enlargement with excess skin. But as all of us are doing and seeing more and more number of cases of gynecomastia nowadays, there are some patients who present with only small enlargement of the breast tissue just below the nipple areolar complex, and some of the people come with axillary fold, some of the people come with the lateral axillary fold, and some of the patients have ptosis. But in this classification, all those things are not been addressed. So I searched the literature, and there is another, I thought that what could be the solution for addressing those problems. And fortunately, there is one classification which has been described by one Indian literature, and it is published in IJPS. And my purpose of presentation is that all of us can follow that, and I am following that. So according to that classification, the grade 1 is there is only increased diameter and slight protrusion which is limited to the areolar region. So these are some of the examples. So what we can see, most of the patients, these are most of the patients who go to office gym, and they come with small complaint that we have a small swelling or puffiness around the only nipple areolar complex, and they come for surgery. So again, as we can see that in the first left side this is bilateral, and in the middle one it is unilateral, and on the right side it is bilateral. Previously probably these people were not coming for the surgery, but nowadays they have come frequently. So this is an additional classification to the previous Simmons classification. So then there is grade 2 where there is moderate hypertrophy of the breast with nipple areolar complexes above the inframammary fold. So this is grade 2. Grade 3 is major hypertrophy where the nipple areolar complex is situated at the same height or at least within 1 centimeter below the nipple inframammary fold. And the last is grade 4, which is when there is major breast hypertrophy with skin redundancy and also the ptosis, and the nipple areolar complex can be positioned more than 1 centimeter below the IMF. So in a summary, we can reclassify the gynecomastia as depending upon the degree of hypertrophy, depending upon the position of the nipple areolar complex, degree of ptosis, and the skin redundancy. which was not addressed in the Simmons classification. So these are the things which I told earlier. These are the additional clinical findings which are not reported, that is the axillary fold, lateral skin fold, asymmetry and the level of the nipple. Also in the previous classification there is no description regarding the asymmetry in the nipple enlargement or the level of the nipple. As we all know, in the female breast the nipple are not placed symmetrically or the enlargement is not same. Also if we look very minutely, when the patients are coming, all of these are unilateral cases. But if you can see, the degree of displacement of the nipple inferiorly as well as the degree of enlargement vary. Of course, it depends on the degree of the enlargement. And another point, the new thing is that you can see when there is a small degree of enlargement, the nipple is projecting forward, whereas in case of large enlargements, the nipple are pointing outward and in a lateral direction. So this is a case of bilateral. If we can go by Simmons classification, they can be placed as grade 1, 2 and 3. But this thing is not described. What is that? That is the nipple projection. It starts from in the low grades, the nipple is usually projected forward, whereas as we go towards the grade 3 and 4, the nipple are projected in the outward and inferior direction. So what is the treatment? So we can simplify that. Grade 1 can be excised through an infraareolar incision. Grade 2 and 3 can be done by a conventional technique, that is liposuction and gland excision. And grade 4, where there is skin redundancy and when there is ptosis is there, we can go in a single stage by giving circumareolar incision. We can do the liposuction, gland excision and the nipple size reduction. So coming to grade 1, sometimes also when we do in our routine OT, we can, for small enlargement where there is only puffiness around the nipple areolar complex, we can do it under LA or intercostal block. And as you can observe, in this patient we have done this locally without any tube. We have done under local anesthesia and intercostal block only with adequate tissue infiltration. Then this is another example of large enlargement of the breast where we have done the conventional liposuction and the gland excision. There are many methods described, but standardly what I follow, I do the infiltration and the liposuction through the inframammary fold excision and do the inferior periolar incision to remove the excess glandular tissue. So this is one of the example what we do in our department. And this is another picture which shows our residents also now doing gynecomastia by their own, and they are being properly trained. Now this is another case, a bilateral case which comes into grade 2, and we have done liposuction and glandular excision and the immediate intra-op result. This is another case of grade 3 where we have done the same procedure, the liposuction and glandular excision. And this is another picture, same thing. And this is my last presentation. So if you can see, this is a male patient and this is another variant of gynecomastia, which you called a tuberous breast kind of thing. But what you can notice is that in this case, the patient has multiple problems. Number one, there is more of a fibrous tissue. Number two, the level of the nipple is different. There is asymmetry in the enlargement of the nipple, and the nipple diameter is also not the same as on the both sides. So what to do? Like in the like in the female breast, I planned for a reduction mammoplasty, and as the vertical or supromedial technique is performed most commonly for the female, I thought that I will go for the same procedure. So from the from the foot end of the table, you can see the projection of the nipple areolar complex, and I marked the level of the nipple, and they were not symmetrical. They were, one side is larger than the other, and the position was also different. So in the first, we did one circumareolar incision, then through one inframammary incision, we did the infiltration, completed the liposuction. The advantage of doing a liposuction is that we can get a good plane above the pectoral fossa. So I removed the entire gland, and apart from the maintaining the pedicle, I removed all of the other breast, and then we fixed. So this is the final result, and this is the picture which the patient sent me 2 years after the post-op follow-up. So to conclude, what I can say that even the gynecomastia surgery can be staged, and we can do the meticulous planning, and we can do the standardize our own technique to get the good results. Thank you.
Talking on autologous breast reconstruction.
I'm speaking on post-mastectomy autologous breast reconstruction. Mostly I work in all cancer hospitals. So, next. So ideal breast architecture is the breast mount is situated over pectoralis major over second and sixth ribs. The important landmarks are to maintain, and contour should be either neither concave or convex. Neither concave or convex, but a plane extends up to the maximum projection at the nipple. This is the ideal markings of the breast. The oncoplastic approach is the onco means tumor, plastic means mold. It blends both the principles of better architecture outcome. When more than 20% of the breast tissues are excised, partial mastectomy, it gives poor outcome. So breast reconstruction improves the result. Partial breast reconstruction, which is done best, is immediate. Delayed means 1 to 2 weeks after. Delayed means delayed after radiation therapy. The techniques are either its volume displacement or volume replacement. Volume displacement, small or medium sized, when the local arrangement of the tissues can be done. Large ptotic breasts, volume displacement or reshaping methods are done. When quadrectomy done, the standard wise pattern resection to be done. The local transposition flap can be repaired like this, or a donut type mastopexy when the tumor is near the nipple, or a batwing type mastopexy can be done when they are near the nipple. So 4 steps of reshaping is the planning of the incision, marking the parental reshaping, reposition of the nipple, and correction of the asymmetry with the contralateral breast. The wise pattern mostly prefer. Lower quadrant tumors, the pedicle should be like superior or supramedial pedicle. Upper quadrant tumor, inferior medial pedicle. Lateral quadrant tumor, supramedial pedicle. This is a wise pattern and the post-op. This is a wise pattern. The volume replacement, either it can be through pedicle flap or free flaps. The pedicle flaps are like tram flap, LD myocutaneous flap, which is workhorse, and omental flap. Or free flaps like DIP flap, which is a gold standard, ALT flap or tram flap or tug flap, or alternate flap like S gap, I gap, or L flap. DIP flap, deep inferior epigastric perforator flap. The favored technique of the reconstruction, the timing is the immediate reconstruction. The flap is almost most of the time should take contralateral. The donut pedicle is the DIP perforators, and recipient vessels mostly I do with the IMA, and dissect at the third and the fourth space, and dissection continues from the lateral to medial always. These are the variations of the tram flap. In some lateral part can be preserved, or medial part can be preserved, or full muscle can be preserved, or no muscle can be preserved. On table planning is that patient to be placed in supine. The skin paddle size is manual. They usually manually estimate the volume, which usually contralaterally we take, and perforators are umbilical perforators. Simultaneous dissection I don't do. Usually after the oncosurgeons do, then I go for the dissection. These are the resection done, and flap was arrived, and the dissection of the perforators done, and usually try to get 2 perforators, because it gives better perfusion and there is less chance of twisting. This is a flap contouring and abdominal closure, and then flap inserting. This post-op. Alternative, you can go for medial to lateral also. That dissection is easier, but I never done. ALT flap is an alternative option. The problem is when the patient comes with recurrent carcinoma over the tumor, and sometimes present the large abdominal scars, or maybe having some comorbidities, or a post-external defects are very large. These are the kind of defect when I get it. The majority patients, they come from low socioeconomic status, and they cannot narrate the proper history, the previous procedure to be done. And so ALT flap is, in that case, I feel is a good option. Easy to harvest, larger vessels, and adequate length of vessels is there. This is a fasciocutaneous flap, as we know everybody. Very large flap can be taken, 12.5 into 38 centimeter can be taken, and vessel length is also okay, good, 8 to 12 centimeter, and diameter is 2 to 2.3 millimeter. This is the landmark central axis of the flap, and the flap I harvested, everybody harvested as from supine position. This is the case 1. The flap harvested, and end-to-end anastomosis is done at the third intercostal space. This is immediate post-op. This is a late post-op. This is the pre-op and a post-op. And another case like that, ALT flap I have done. Tram flap is many of the times and land up in it pedicle tram flap. Either the tram flap can be free tram or pedicle tram. These are the anatomy of the rectus abdominis muscle. This is origin from 5, 6, 7 costal cartilages and inserted into pubic symphysis. It has got dual blood supply, superficial infap and DIP. And flap can be vertically or horizontal. These are the flap harvestings. These are the zones of the flap. It can be the strategic delay of the flap also can be done. Ligation of the major pedicles like 3 days to 3 weeks before the flap elevation also. The pedicle flap, is this a post-mastectomy defect? This is the flap planning. I identify the perforators through Doppler, and the Doppler I identified the perforators, and the flap I harvested, and it subcutaneously tunneled over the defect. And usually in this case you have to close the abdomen with a mesh. That is a problem. And this is the flap inserting. This is the late post-op. Bilateral tram flap can be done, but I have never done. It's only photo. Tug flap transverse upper gracilis flap. When the small defect is there, a subcutaneous pedicle placed on the gracilis mycocutaneous perforators. There is no need to identify the perforators. It's a better thing that I got a hidden scar. And here we have to do the coning of the flap. It's when the defect is moderate, and the recipient vessels, I usually take the second and third perforators. And pedicle is the problem is that pedicle is of limited length. The indication is that it's got immediate reconstruction. Insufficient abdominal tissue is there, abdominal scarring is there, or it's unmarried human with had got a recurrent DIP or failed DIP. In that case, we can do. This is the flap design. This is the defect. Our flap is harvested, and the coning of the flap, and the reconstruction. This the tug flap is just limitations is just adequate size, shorter pedicle 6 centimeter. In darker patients, it has got poor color match, like it has a thigh color. LD flap, can be considered as a primary reconstructive method, high risk for the tram or free flaps. Where skin sparing mastectomy and breast prosthesis is a plan. Partial mastectomy or lumpectomy defects, small to medium sized breasts where the primary reconstruction is needed. Large breasts, primary reconstruction with or without implants, previous irradiation during breast conservative therapy. This is a common skin paddle, or this paddle can be like this, or the design of the skin paddles are like this. The flap is harvested, and this flap is inset, or flap can be folded into a cone. This case one. The flap is harvested here, and primary closure and alternate flap, S gaps, L gap, S gap, I gap, and lap flaps. These are based on this superior gluteal artery perforators based superior and inferior. This is the I gap flap. So I have to go fast. No question. 1 minute, sir. No breast reconstruction is completed without nipple and areolar reconstruction. So majority of the NAC complex is retracted during MAX. So NAC is located in the most projection of the breast mount. Ideal time is 3 to 5 months following the last revisional reconstructive surgery. The options are like the star flap, CV flap, bell flap, top hat flap, double opposing flap, spiral flap, or flap with autologous graft augmentation or allograft augmentation. Modified scat flap, star flap, or CV flap, Areola reconstruction challenges to reconstruct the pigmentation or texture similar to native areola most commonly are the skin grafting, tattooing or combination. Skin grafting immediately at the time of nipple reconstruction, tattooing 6 to 8 weeks following the nipple reconstruction. And last but not the least is the fat grafting to the breast, where some small depressions are there. You can go for fat necrosis, you can go for fat grafting, irregularities, augmentation of inadequate flap, radiation deformities, sharp implant border or lumpectomy deformities. You can go for fat grafting. Thank you.
Thank you, Dr. Krishna. Mentioned to me that you are working as a dedicated plastic surgeon in a cancer reconstruction unit, right? So like our Dr. Prashant, he is one surgeon dedicated to cancer reconstruction. I wish many more young surgeons pick up that challenging area of reconstruction. Thank you very much. Actually, we are running a little fast, and I would always suggest that you speak on one particular technique, because you have very little time and we are not left with any time to discuss. Suppose in nipple areola reconstruction, that itself is a paper, or in any other technique. Thank you, but you have explained many things to our younger colleagues. So can I request Dr. Satyaswarup Tripathi or Dr. Unmesh? Is Dr. Unmesh there? Oh. Then we have 3 more papers to go in this session, right? Satya, Jayant and Santosh. Please.
Good afternoon, everyone. So basically this topic is newer modalities for hair loss versus hair fall, paradigm shift in today's era. So since my session is post-lunch, and we all know that orexin levels would have dropped after a heavy meal, so we can fall asleep at this time and the hair growth cycle gets activated. So with that, I start my intro. Essential component of human identity and self-esteem has always been hair. We have many proverbs like "Baal ki kaal khinchna," "Baal nahi to kuch bhi nahi." So it's all about the confidence and feeling good about oneself, and it's not just about the appearance. The distinction between the natural hair fall and extreme hair loss is one of the individual's main worries, despite the fact that hair-related difficulties are relatively frequent. So there are many hair loss movies which socially will equip you with all the definition of hair loss and the society, how they deal with the hair loss and the baldness issues like Bala, Gonkesh and the Ujra Chaman movies. So starting about the hair growth cycle, we have, as we all know, anagen phase, catagen phase, telogen phase. So anagen phase will last about 2 to 6 years. Catagen phase will last about 2 to 4 weeks, where the active growth of the hair follicles, they stop growing and they detach, slowly start detaching, where there is the cessation of the activity of the hair follicle. And the telogen phase, it will last for 3 to 5 months only, and the follicle will go into the resting phases, and that will prepare the hair for the next cycle. So this shows the hair cycle. Then coming to the proper hair fall versus hair loss. Hair fall is usually temporary and hair loss is mostly permanent. Hair fall is less severe, whereas hair loss is severe. So as plastic surgeons, we should very much be careful about while explaining the patient that you have hair fall or you have hair loss, because they are already equipped with all the Google sort of knowledge and they will try to test you whether you are saying correctly or not. So this is, hair fall is usually seasonal and hair loss has no specific time. Hair fall is usually associated with dietary, seasonal changes, stress and aging, whereas hair loss is mostly genetic and hormonal changes or drug related. So there are types of hair loss like male pattern baldness, female pattern baldness, telogium effluvium, alopecia areata and alopecia totalis. So how do we assess? Assessment is also related A, B, C, D, E, F. So A is, we can go for age. So whether it is normal aging or it is premature aging. If B is baldness history, like how much hair is being lost. Normally, as we know, it is 100 to 150 is the normal hair, and more than 150 is abnormal. So since when, any specific area where it is lost, and any treatment history taken. So C is chronic diseases, thyroid, cancer, epilepsy, PCOS, and D is deficiency, daily sleep cycle. Daily sleep cycle, I would like to enhance that daily sleep cycle, how it affects. Like melatonin is normally maintains the circadian rhythm, and if we do not sleep in the proper time, that is 10 to 5 a.m., so the melatonin they won't make the hair repair cycle growth proper. And the dandruff, of course. So E is exercise related. As Dr. Bishwajit Mishra sir have shown before, that some people, those who are having gynecomastia, they were gym related. So you could very well see the hair loss very much evident among the body weight or bodybuilders. So that is because of whey protein, because that will release more amount of testosterone, which have the direct effect on DHT. So that will cause hair loss. And E is emotion or stress, which is maybe due to related to anxiety and depression. And last is F is food habit, whether we are eating veg, non-veg or junk food, and whether it is Jain or keto diet. Fun habit like alcohol and smoking, and of course F is family history. So this is Norwood scale, everyone will be knowing, up to 7. There is the male hair loss, this is the female hair loss, which is Ludwig's classification. So newer modalities of treatment, we are very much well aware of PRP, that is platelet-rich plasma. Then SPL therapy, which is the very new concept, that is sonicated platelet lysate, which is the, we can say it is the BAP of PRP, because PRP only uses platelet-rich plasma. Here we further sonicate the PRP taken from that in the sonicated machine, and then we release the growth factors, which has more than 450 or 500 growth factors released from that SPL therapy. Whether in PRP we get only 25 to 30 growth factors. So next comes the GFC therapy, then exosome therapy, then low level laser helmet therapy. So that releases red light, which also causes stimulation of the hair follicles. Then the topical androgen, anti-androgen therapy, we are very well aware of, and the micro needling therapy. Micro needling, what it does, it stimulates the collagen production, and we can add it along with the PRP. And then the scalp massage. So there are new discoveries like SCUB3, that is a signal peptide CUB EGF domain, epidermal growth factor domain containing protein 3, which is a very much new discovery, which is still will be coming into the market very soon. And then adult stem cell therapy, then hearts fusion, that is FUESION. It is deliberately made like this, the name, because that is the robotic hair transplant, which I will be telling you in subsequent this one. Then ARTAS AI operated hair transplant and stem cell regenerative therapies. So these are all artificial intelligence operated hair transplant, which I will be showing the video, next video. So this is the AI powered robotic hair transplant, we can see. Sound please. So these are the markings made by the surgeon, and they are speaking about how deliberately the punch holes are made. Okay, no need of sound. So how deliberately the punch holes are made, and the punch holes are made, it is a predefined punch holes which are set by the AI or artificial intelligence. And finally, the job is done in 2 to 3 hours very specifically. So it is AI powered robotic hair transplant. Then PRP, as we know the process, it will be centrifuged. So there will be 3 layers. The last layer will be the RBC layer. The middle layer will be taken for the PRP, but the upper layer will be the platelet poor plasma, which will be discarded, of course. Then this is another SPL therapy, which I've been using in my clinic also. So this SPL therapy, we use our own blood, and then we centrifuge it for 10 minutes. Then we'll extract the PRP, and we put it over the hair loss area, and we'll discard 1/3 of the PRP, and we'll put it and sonicate it. So finally, after all these modalities, we have the hair transplant. So FUE, as we know, it is widely followed nowadays, and FUT, it is reserved for selective patients. Then assessment of the hair, there is hair quality, scalp laxity, donor site, color of hair, recipient site existing hair, and proper consent form, which is very essential. Pre-op medications, we have tablet Alprax and Skyra-D. FUT versus FUE, we have a follicular unit which will be extracted in FUE, whereas FUT, we remove a strip of hair and then we transplant it. So these are the markings, how we do over the vertex as well as over the head, and occiput, and it is during the hair transplant, and these are the post-op 7 days. Sir, I have 30 seconds. These are the post-op care after hair transplant. We should avoid physical contact to the implanted area for 3 days. We should sleep straight for 3 days, wash your body without touching the head, then don't wear any sort of t-shirt or a vest for 1 week. Avoid wearing cap or helmet, only surgical cap is preferred. Hair wash after 1 week, that is Johnson baby shampoo is usually preferred. Stay calm and relaxed. We should tell the patient, and we should also be staying calm and relaxed. Workout or exercise after 1 month. And these are the post-op antibiotics, analgesic, antacid, Vizoline we should be giving. And post-op 15th day medics, that is tablet finasteride, we should start after the 15th day. And tablet Nutri Hair, it is a combination of allium cepa and many Ayurvedic products with minoxidil spray 5% twice a day for lifetime.
I'm sure Dr. Unmesh will have a lot of questions from young aspirants who are trying to train their guns with hair transplant surgery. So we will keep that session to the later part of our fellowship. Okay? So now can I have the next speaker?
Thank you, sir.
Dr. Tripathi, please.
Good afternoon. Since morning you have been discussing about different aspects. Now I will be talking about the psychosocial integration following reconstructive surgery. We do a lot of surgeries, but do all these patients, they socially integrate, psychologically integrate back to the society. That is the topic of discussion. So coming to the case scenario number 1, this is a burn survivor, survived a major burn but left with a very bad hypotopic scar over the anterosperate neck and also over the beard region. So what can we offer to him? Because this is a patient from Punjab, and all the Punjabi people, they want to go to Canada, and there is no scope in India like that. So next, this is a very curious case. This is a picture of the same patient showing the other half of the face. Half of the face is absolute normal. Other half of this face is totally scarred. So what can we offer? And this is a case scenario where the standard of care, you can say, coming in the middle of the night, 2-year-old child, we can go for revision amputation, but will it solve the problem with the child and as well as the parents? So what we can offer? So what comes into play while managing this type of patient is the surgical ethics, which tells, it's a branch of philosophy which defines what is good for the individual and as well as the society. It is the nature of obligations or duties that people owe themselves and to one another, which includes morality, principles, honesty, righteousness, fairness, responsibility, integrity, value, honor, choice, and conscience. So coming to the case scenario number 1, that the postman contracture with the anterosperate neck, this is the patient which I had shown earlier. So the standard of care, you can say, we can release the contracture and put a graft, but that left with so many areas of concern, like scarring over the anterosperate neck and a alopecia area, alopecic patch over the beard region. So we offered him the expansion of the normal skin which is present over the lateral side of the neck. We put 2 tissue expanders and brought the normal tissue to the anterior part of the neck. And the alopecia area, we used that follicular unit hair transplant. And we can see the patient is almost looking like normal, attending social functions, socially integrated back to the society. And we published this, and this got the best short paper award in the NABICON also. So this is another case where the child survived the major burn, but what the child is left with is, he is totally crippled. He is walking like this. So is it fair for the child like this, walking like this? So what we offered is a contracture, release of the contracture, put a graft is not the solution. We applied a skin traction that lengthened the musculoskeletal units. That means the child is able to walk like normal child, does the cycling and goes back to the school. So that is a case of successful rehabilitation. And that is the case scenario number 3, which is a case of childhood hemangioma. You can see the child in the lap of the mother. And when the child grown into adult, of marriageable age, the parents thought about what to do. So they came to us. We see this, we can say it's a curious case of two faces, like in the movie like Satyam Sundaram, the protagonist actor, and what she faced. And we can see similar pictures in the Hollywood movies. So what are the options? Do we put a split thickness skin graft, or the full thickness skin graft, or multiple skin expanders, or resurface the entire area with a free tissue transfer, or a composite tissue allo transplant? So we did a free anterolateral thigh flap for the entire left hemiface. Subsequently, she underwent multiple stages of surgeries like flap thinning and local tissue readjustment to result into something like this, which is much acceptable. The girl got married and now leading a normal life. So this is another case, the patient, elderly diabetic female with hanging paniculars, suffering from a lot of depression with antidepressants, and she's not able to attend any sort of social functions with this sort of look. So what we offered is the lipoabdominoplasty with tummy tuck. You can see the amount of skin which we excised, and the fat we aspirated, and this is the post-operative look the lady had, and she's off antidepressant now and almost going back to the society as a normal human being. So fat is not always enemy. You can use the fat as an implant, autologous implant in form of autologous fat transfer. We use the same principle in case of hemifacial microsomia. You can see the girl presented with a depressed look and half of the face not looking normal. We offered her structural fat grafting, and we harvested the fat, multiple stages of autologous fat transfer. You can see the smile back on her face, and the girl completed her master's in Kathak. Now she's doing the sound is not working. She is a full-blown artist and opened her own dance academy, and now teaching so many students the teaching of dance, confident person, and doing the openly performed in a full stage audience in an auditorium. You can see that. So this is another lady presented with massive gigantomastia with a huge amount of asymmetry. The lady went from pillar to post. She wanted to get married, and everybody offered of that is breast amputation and free nipple areal grafting, but she was not happy. She came to us with hope of some reconstruction so that she can get married. So we undertook a case of supraradial technique breast reduction, and we took out almost 9 kg of breast tissue, 4.5 kg from one side and the other side 3.5 kg. You can see after reduction mamoplasty, the lady is almost looking normal looking breast with breast symmetry, and the lady got married and now leading a normal life. So this is another case of adult brachial plexus injury. You can see the limb, upper limb is non-functional. What the patient in Punjab they want to tie their turban on their own. That is a matter of pride for them. So the patient asked the same thing: can I tie my turban back on my head? So with that question, we undertook this surgery with a nerve transfer, and we can see the post-operative result, the shoulder abduction and elbow flexion, almost like a normal being, and he is carrying out all these activities of daily living, and he is tying his turban on his own hands, and he sent this picture through WhatsApp to me that I am socially and psychologically normal, I am back to the society. So that is the message we can give through the reconstructive procedures. And this is another complex thigh defect. This patient came to my OPD in a stretcher with a complex saucer separate defect over the anterior thigh involving the bone loss, soft tissue loss, and he wanted that I want to walk. There's a grafted skin you can see in the middle part of the thigh with a huge amount of skin and soft tissue defect. So there is a battle scarred area. We undertook the CT angio. We see the recipient vessels. We took a big LT flap from the opposite thigh, and with multiple stage of this bone transfer, we can see that patient is walking pain-free, and with a little bit of shoe raise, he is almost leading a normal life. So this is under few minutes. So case of the 2-year-old child with traumatic amputation. With tissue avulsion, we took this replantation, and we can see the the child is almost leading a normal life and there is no amount of physiotherapy required. He is almost utilizing all these games and all. So this is another older child, 8-year-old child with traumatic amputation in a Toka machine injury. So what I want to say, this old child is okay, but 8-year-old child, when we replanted, the hand we replanted back, but the child is prepared to use this hand because he suffered from post-traumatic stress disorder. So we almost undertook 10 sessions of that is child psychiatric consultation with child-centered play therapy to that post-traumatic stress disorder. Now the child is almost socially and psychologically back to the and is going started going to school, and we published this in the Essence of Psychiatry. So to conclude, what is standard of care? What we need to do is that extra effort which increases the quality of life. It relieves the patient from post-traumatic stress disorder, relieves the patient from depression, from body shaming, and it provides the form and function and aesthesis through constructive, improves confidence, and enables them to be part of the larger society as so useful, productive, and active member, contributing to the society in a positive manner. I thank you for giving me a positive hearing, and thank to all my gurus who have taught me this art to give something to the society back. Thank you.
Thank you, Dr. Tripathi. It is a very important discussion that we always have to remember that they will come in all shapes and sizes with all problems. We have to make them fit as they wish to be. So that is the great job of a plastic surgeon. Thank you. If there is any pointed questions, you may ask, or else we'll go to the next presentation. Thank you again, Dr. Tripathi.
Thank you.
Dr. Jayant, extracorporeal septorhinoplasty for crooked nose.
Very good afternoon, everyone. Respected chairperson. So I would try to finish the talk in time. So this is all about extracorporeal septoplasty for a grossly deviated nose. So now the world is talking about preservation rhinoplasty, but here we are taking out the septum and we are doing the fabrication. After that, we are inserting the new septum into the nose. So it is the deviation of the external nose from the midline. It could be either bony part or cartilaginous part or both. And it is almost always associated with the septal deviation. There is a famous saying by the rhinologist, Maurice Cuttle, as the septum goes, so goes the nose. So it's always associated with the deviated septum. Etiology could be because of the nasal trauma, previous surgery, or congenital malformation, especially unilateral cleft lip or palate. So there is a classification, described classification for this deviated, grossly deviated crooked nose, C-shaped deformity, then inverted C-shaped deformity, I-shaped deformity, and S-shaped deformity. In all, there will be component of cartilaginous part or bony part or both. So it is a procedure described by famous rhinoplasty surgeon, Professor Gewis. So Professor Gewis has described this a long back in 1980s, and he has described it as a complete removal and adequate exposure of the whole septum. Because if you don't correct the deviated septum properly, always there will be residual deformity, which will ensure a good functional as well as cosmetic or aesthetic outcome. So there will be scoring of the cartilage, there will be wedge excision, splinting of the cartilage with the residual cartilage. Then we have to fix that straitened cartilage with the anternasal spine, upper lateral cartilage, and nasal bone. And there are various modifications of this fixation. How you will fix that thing, how will you
strengthen it. So there are various modifications. So what described by Gibbs, which is a very standard procedure. So it's an open approach. So it starts with the infiltration of the adrenaline solution 1 in 2 lakh. We have to wait for 10 to 15 minutes so that your dissection will be almost bloodless. And simultaneously during your waiting period, you have to pack the nostrils with the adrenaline solution. Then the standard inverted V columellar incision is given, and entire skin and the subcutaneous part is deglobed from the osteocartilaginous structure. We have to expose the upper lateral cartilage up to the nasal bone. Also we have to separate the septal cartilage from the upper lateral cartilage, from the mucoperichondrium, and it is tricky. You should know that you should start from the concave side so that you can avoid injury to the mucoperiosteum or mucoperichondrium. So always starts from the concave side to separate the septal cartilage. If there is a dorsal hump, it should be reduced at first. It should be reduced with the osteotome before the upper cartilaginous septum, because the stability will be lost. So it should be reduced before any separation of the upper lateral cartilage. And if required, you can do paramedian osteotomy. And if the oni septum is also required to be removed, then paramedian osteotomy should be done. And all the cartilaginous septum should be removed in toto, entire cartilaginous septum. And we have to recreate a septum as a L-strut neoseptum. And it constitutes two parts, one the long part that is around 3 centimeter length and a short part 2 centimeter length, and the thickness should be adequate, at least 2 millimeter, and width should be 1 centimeter. If you are planning to put spreader graft, it should be harvested from the left out that cartilage, residual septal cartilage, which will stabilize the neoseptum also. And it will reduce the internal nasal valve collapse. And if required, you can do lateral osteotomy on one side or both sides depending upon the patient. So once the neoseptum is grafted, then it is inserted into the place. It is fixed to the nasal bone at the keystone area with a fine drill, and caudal part is fixed to the anterior nasal spine at the maxillary spine, and again it is strengthened by fixation to the upper lateral cartilage with or without spreader graft. And to more strengthen it, you can do it quilting suture will diminish the space between the mucoperichondrium and the cartilage will be, neocartilage will be stabilized. To stabilize the tip, you need a columellar strut. So, because you are exposing everything, you are cutting the pitangui ligament, so to prevent drooping, so you have to stabilize the tip with intradermal suture, interdermal suture and columellar strut. And if there is dorsal irregularity, you can put a dorsal fascial graft or sometimes diced cartilage paste over the it. And after the surgery, after you close everything, you pack the nostril with merocil and a dorsal splint, and merocil is removed after 48 hours and the dorsal splint is removed after 8 days. So there are publications which show there is a modified extracorporeal septoplasty which keep the septum, part of the septum intact, and they have a good follow-up also, 6-year follow-up. But they have concluded that, so now it gives good result, but extracorporeal septoplasty is always better. And there are other 2 papers also, they have compared also that extracorporeal is always, you can get the entire cartilage to manipulate, to fabricate, and you will have the best result. So I'll show photograph of this patient. This is before the anterior view. This is the worm's eye view. And you can see the upper one is the series of pre-operative view and the lower the post-operative view. Finally you can see the result after 1 month and the result after 3 months. Similarly, another patient with grossly deviated septum, you can see the post-op result at 1 month. This is the worm's eye view. And this is the different views. The upper one is the all pre-op views and the lower one the post-op view. And you can see the result at 1 month and at 3 months. So to conclude, extracorporeal septoplasty described by Professor Gibbs, it provides adequate exposure of the catalyst so that you can manipulate for a good functional as well as aesthetic outcome. Yes, there are possible complications because of the septal deformity, collapse of the septum or recurrence, but it achieves our purpose if done correctly in a proper technique. Thank you.
Dr. Jayant, any questions for him? Quick one question.
Long term, yes. Yes, diced catalase I have tried only to augment the dorsum, okay. And the long term I have done almost 6-7 cases in last 2 years. So I am still waiting for the long term, like after 5 years or 10 years. But up to 1 year I have followed the patient. See, most of the time the patient, they have not required any dorsal augmentations. So only the septal, I have harvested the septal cartilage, I have fabricated it, I have reinserted it.
Thank you, Dr. Jayant, for the nice presentation. I will invite Professor Dr. Devi Prasad Mahapatra from JIPMER, who will talk on the regenerative strategies in burn management, JIPMER experience. He is a senior professor and ex-head of the department, Department of Plastic Surgery, JIPMER, Puducherry.
Thank you, Chairperson, and thank you, organizer and President Dr. Lakshmi for giving me this opportunity. My talk will be on regenerative therapies in burn management. It is like a series of studies we did in our hospital and some additional topics. So now, as we know, all the a lot of discussion has been done about acute burns, and most of the good centers in the country, they can provide good outcomes at 50 to 60% burn. So we are getting good survivals. But once we have good survivals, we are landed with scars of burn, the sequelae of burns. So now, coming to a brief background, like we know the incidence, it's wide, everywhere we get burn patients. Mortality has been reduced because of good protocols. Resuscitation protocols have been well defined now. Rehabilitation protocols have been instituted. Now is the time to institute aesthetic protocols. That is the thing which is the next thing into the burn management. So when we see the sequelae of burns, we either have structural sequelae that most of us do, post-burn contractures of various parts of the body, and other part is the functional sequelae, that is pain, itching, burning, discoloration, surface changes. Like Professor Satyasarup showed that how do we rehabilitate patients. So these are functional sequelae, inhibit integration of patients into society. They cannot do their work because of pain, itching, burning. So this presentation is on that. So how do burn scars alter the quality of life? Physically, itching, pain, contracture, and functional limitations, they are limited. Physical limitations is because of that. Social limitations we have because of the scars. Psychological limitations are because of the stigma of the scars, as well as these other functional complaints we had. So what regenerative therapies we have at hand at the moment? One is laser, one is autologous fat grafting, one is autologous non-cultured melanocyte keratinocyte suspension, autologous platelet-rich plasma, and finally stem cells. Laser therapy, it is an innovative thing used in burns and been used for last almost a decade now. It helps in speeding up the healing process and reduces the scar of burn. It can improve both functional and aesthetic outcomes. In our institute, we have got instance pulse light. It is a type of xenon lamp, and it has been found to improve the texture of scars and subsequently the coloration of the scars. We had a study in our hospital, which was a student thesis. We included patients above 18 years of age with healed hypertrophy scar less than 2 year duration with a width of 2 centimeter. And then it was finally we found, what was the conclusion in our study was IPL studies are effective modality in treatment of almost all type of burn scars, all type of scars, and can be an adjunctive to existing scar treatment like silicone gel therapy, massaging, all those things. So this is one benefit of intense pulse light. So what was the conclusion? IPL therapy is efficacy with minimal side effect. IPL can be used over a bigger area, wide areas can be covered, and we can combine it with other therapies with good outcomes. One of the other laser is, this is the erbium YAG laser. This also we have in our institute. Erbium YAG is a fractional laser. We use it for resurfacing of scars. And in this scar also we have found changes in texture, quality, and pliability of the scars. Patients say that there is improvement in itching, and these are the outcomes. And most of the literature reviews have shown that there is improvement in Vancouver scar scale scores in case utilization of lasers. Coming to outcomes again, it has been found to be effective and a versatile tool, and different kind of lasers can be used. We showed the IPL laser, we showed erbium YAG laser, and then we can combine it with other modalities. Coming to autologous fat grafting. We know autologous fat graft is a good source of nano-fat graft when you're talking, it's a good source of mesenchymal stem cells. That they help in remodulation of the scar healing, the proliferation and fibrosis. These phases can be remodulated with the help of autologous nano-fat. The standard procedure of harvesting of nano-fats, I'll not skip the video, but ultimately what we do, we create a nano-fat by filtering out the fat using tumescent, and that nano-fat is injected into the scars. We also had a study based on this, and here we used well-healed burn scars, more than 21 days, less than 1 year, and patients within 12 to 60 years of age, and 3 by 3 centimeters scar size. And we used the POSA score, patient and observer scar assessment scale. That is the Vancouver scar scale, and this is the POSA scale where both patient and observer can assess. We tested for pliability, we tested for mobility, we tested for vascularity, and we found a good amount of improvement in the scar. We don't say excellent, but there was improvement. So so what we see, we change in texture of the scar, and in some cases there was a change in pliability, improvement in vascularity of the scars. This was noted. So coming to again literature review, previous studies have shown that fat grafting has been found to be effective. Few studies have shown that. Some studies have given some negative result. One important point is fat grafting has been found to be effective in neuropathic pain of burns. Neuropathic pain and itching has responded to fat grafting. And why that happens? Probably they said it is because of coating of the fat cells over the free nerve endings which irritate the dermis. Coming to some studies are there which have not done. Further studies can be carried out on this subject. Autologous fat grafting is safe and effective with a small learning curve. Anybody can do it at any place. POSA scale, we found it is a good measure of measurement. And then it improves color, stiffness, thickness, irregularity, vascularity. And as early we see the changes as early as 3 weeks. Pain and itching has also been found to improve. Coming to non-cultured melanocytes, so this has been used for improvement of the pigment rate. We have depigmentation in burns. We create a cell suspension of melanocytes and keratinocytes, and we use it for improvement of pigmentation. So this is a video, I will skip it for concept of time. Basically what we take a small piece of skin, and then we just break it. The epidermis is separated. There is no culture involved in this. We just break into very small particles and then use it as a spray. See, this is a standard image on how the hair follicles give rise to pigmentation in a normal healing wound. But many of them go into leukoderma. So to tackle that, we decided on this kind of therapy. We took, this was also a study in our department, and then we took 12 years above patient with previously untreated burn leukoderma. In this, this was an example of a good result. We didn't have very perfect result, but as you see, there has been change. That non-melanocyte keratinocyte suspension is sprayed over the derma-abraded area on the leukoderma patch, and it gives rise to good pigmentary changes. And on the other hand, we have the option of putting a skin graft also. But the advantage of melanocyte cancer suspension, we can take a small piece of skin for a very big area. So that is the benefit. Coming to autologous platelet-rich plasma, again, it works by stimulating proliferation of fibroblast and keratinocyte and facilitates faster wound healing process. It reduces pain and inflammation associated with burn wounds, enhances collagen synthesis. Standard protocol of PRP is there. We just take the harvested PRP and inject into the scar. And I'll skip this thing. And it has been also found to be effective for mostly for itching of burn scars. It has been found that and when you give it along with autologous fat, it helps in working of the fat also, take up of the autologous fat. And different studies have shown, one of them tells that PRP stimulates fat grafts containing adipocyte-derived stem cells. So PRP with fat grafting is a very good combination, part of regenerative therapy. Finally, stem cells in one. I don't have any experience in our hospital, but it is the latest. If anyone is interested, they can actually explore this. And what is the benefit? Some seconds. Stem cells have their unique regenerative capabilities. They can work through different pathways, and they have a potential. The mechanisms are basically they stimulate different kind of wound healing pathways and regeneration of natural cellular element. It can be given. Studies have shown that it can be given as direct injection or as a scaffold. And preliminary studies have shown that some efficacy is found in this kind of functional scars. Coming to conclusion, all these therapies, what I discussed just now, can be implemented at all levels, all kind of facility. We don't need special facilities for this. And it is time to adopt this kind of protocols in our practice. Thank you very much.
Thank you, Dr. Mahapatra. It was very informative. And he spoke about something which all of us can practice. We have scope of trying these techniques in our cases. So if you have any pertinent question, you can come up with a question.
Devi, you have shown that keratinocyte you have implanted on the hypopigmented areas. Why not take a ultra thin graft, only epidermis, and do the derma abrasion and put it, so that it will give a uniform appearance, not cobblestone appearance.
This was a preliminary study, and like the image I showed, there are limitations in how we do it, but the advantage is for a bigger area, we can take a small piece of skin and break it into epidermal level, and then we sprinkle over a larger area. As you said, the skin graft, canal blister grafts can be used, plain skin grafts can be used. The problem with them is we have to match with the size of the leukoderma patch. Second is there is a peripheral halo we see in all kinds of cases, so that is very difficult to go. The case which we had a good result, you see that wherever the pigment is coming, it is coming uniformly and matching with the surrounding. So that was the advantage of, and there is no culture involved. It's actually a very simple process. You take a skin, you mix it with phosphate buffer saline, you wash it, the epidermis and dermis is separated. Take the epidermis, centrifuge it, one pellet is formed, suspend the pellet in saline and spray over there. This can be done in any area, and for a bigger areas we can do. We are stimulating the spread of
keratinocytes. But that will not give a uniform appearances like
it's all study. We can all study on it and see what can help in their action. Many areas we didn't have pigmentation also. So this is what the study is about. Like where can we get better results, and we can explore these strategies.
Okay, thank you.
So did you do it after dermabraiding the area?
Yeah, we have to dermabrade.
So can you do the same thing if it is a granulating wound and you want to put this graft?
That's right. These are the next things which we can think of. Like when the wound is already about in a stage of healing, simple things. Does it improve outcomes? That's the next step of studies.
Any other question? If not, thank you.
Thank you, sir.
Dr. Mahapatra, we now leave thanking all the speakers for the excellent presentations, and our apologies to make you run through your presentation because of shortage of time. So that blame has to be shared by the organizers, not me. So please come.
Thank you, sir. Thank you. Now 3 announcements. For one announcement, requesting all the delegates to visit the stalls. Without them, the conference is not possible. And I request all the stalls, just in front of this, just nearer to this lawn. All the stalls are there. Almost 27 stalls are there. Please visit, and they request also for this signature for this permissions. Second is tomorrow. Dr. Parasar, sir, Dr. Sanjay Parasar, he has sent this Zoom meeting link to me. and it is not possible today as it is not downloaded today. And if you all will happy that for 3 days it is active, for 3 days. And if all are means that want to see this surgical facelift and also double chin correction, then I will kept a Zoom meeting and I will present his presentation on day after tomorrow. I think tomorrow all will go to their home. They will be busy. So I think I want to keep this presentation of Dr. Sanjay Parasar's top presentation, both the surgical surgical facelift and also the double chin, on day after tomorrow. That is on 13th, 9 o'clock I will keep it also. In the evening, 9 o'clock I will keep a Zoom meeting to all these groups so that they can see this presentation of Dr. Sanjay Parasar. Santosh, Dr. Santosh, please come. And third announcement is that tomorrow we have a cricket match. We have two teams, Dr. Baliar Singh sir's team and another is Dr. Falguni Rai's team. Two teams there. Huh? Then we will keep this cricket match for our plastic surgery Premier League. You will be there, sir, tomorrow. And you have also Santosh as Santosh. You please tell.
So the cricket team has been divided into two teams. One will be led by Sudarshan Baliar Singh sir and the other one by Falguni Rai sir. And whoever gets the jersey colors, the colors have also been divided. So you will get to know you are in which team when you get the t-shirts. So the match starts at 6 o'clock and hopefully we'll be able to finish by 8 o'clock. By 7, okay, by 7 o'clock. And we'll try to accommodate as much as people all delegates who come to play. And the t-shirts most likely will be distributed today once the inaugural program is over. So that the t-shirts will be handed over to you. Venue is here, sir, only, in the lawn. So not much, yes, just beside the sea beach. Volleyball bhi korta na, Zago cricketers ho rahi hai. Okay. Tennis ball. Okay, thank you so much.
I request Ruchismita, come and start this fourth session, our last session, and then we will have our general body meeting.
Quickly heading towards the fourth session, that is limb reconstruction surgery. I would like to call the chairperson to the podium. Please welcome Professor Dr. Vibhuti Nayak sir, Dr. Devi Prasad Mahapatra sir, and Dr. Biswajit Mishra sir. Sir, please. Please welcome them with a huge round of applause. Over to you, sir.
So very good evening. Without much ado, we must start to save time. The first speaker for this session is Dr. Subrat Jana. He needs no introduction. And he's talking on a very common problem. And he has one of the largest experience in this field, salvaging injured hand. Sir.
To break the academic meetings, can I do something like the Trump did in his election meetings? So please, I am going to be very brief, very precise, and let's start. See, the point that I would like to focus is rehabilitation. Much has been spoken about reconstructive surgery without focusing on whether the reconstruction was to the satisfaction and the benefit of the patient. Till the time we have rehabilitated, like you said, psychological, physical, functional rehabilitation, our job is not complete. I'll skip this introduction. Hand is a complex thing, you know, multiple small bones, joints, tendons, nerves, vessels. So, I would like to tell that when a hand injury is received, you again run the protocol of primary survey, secondary survey and tertiary survey. Please remember that in primary survey, Here there is no airway compromise. But the constant problem is that of bleeding and pain. So please address these two important symptoms of bleeding and pain as part of the primary survey of an examination of hand. That to follow is an examination of the hand, which is like secondary survey of trauma patients. In the secondary survey, you examine a patient head to toe. Here you have to examine the patient's hand from shoulder till the tip of the hand. To do that, you definitely need some analgesia. Please do not try to examine a hand multiply injured without giving some kind of anesthesia. Of utmost conservation is the approach in hand surgery. It is not lower limb that the prosthesis is readily available. It is hand. We have the kind of hand that we get today, the prosthetic hands, are very limited, and the best fit is only when the flexor mass is there. If the flexor mass is gone, the prosthesis is a limited use, limited application. So trying to have this thing in mind is utmost conservation. This is a hand which was crushed in a cane crusher machine. So this was the X-ray picture. Now the orthopedic surgeon as usual will say that, oh, not salvageable. But as I said, no amputation can be done in our place without the plastic surgeon's involvement. No. So therefore, what we did is this, putting mini fixators and trying to keep the thumb in abduction, and all along this process of healing, the person was able to move the MP joints of all the four fingers injured. After this healing, the skin soft tissue healing has the place for bone grafting. So we put bone grafts, small matchstick kind of grafts to bridge the gap. Obviously there was no joints, but then the finger started working, it should start working, the vessels are intact, the nerves are intact, the joints are gone, but the MPs are fine. So this is something which is a clear example of salvaging a hand or trying to salvage the hand. So this was a ring avulsion of finger. So we did a revascularization. She was a young lady, a teacher, a lecturer rather, and this is what we got 4 or 5 days later. So this kind of picture is familiar to all the people who attempt revascularization. But as you can see, there is vascularity, sufficient vascularity to prompt further reconstructive procedures. This was the picture after debridement, and this is a deepithelialized cross finger flap, the end result. This is a ghastly injury. Again, a young lady fell from her scooty, but all this was degloving. No skeletal injury was there. So therefore, we did an excellent fixator, and I'm again trying to tell that the abduction has to be maintained through this temporary fixation device, then grafting, then function. So some of these injuries may appear to be unsalvageable, and you'll be tempted and coerced by your colleagues, especially if he's from an orthopedic background, that usko nikalo, ye to rehna hai. So this is what was left after the debridement, and we put our hero of all flaps, groin flap, a pattern groin flap, to give this kind of a result. This is a metacarpal hand put to some basic functions of grasping. Again, this is one picture where you can see that the amputation is done where only one finger looks salvageable, the rest not. So this is what happened. Only one finger was salvaged, but this was gone. So we put a flap, a PIA flap to cover the hand, and the result was this. A 3-fingered hand, but useful. Here in the insert you have the picture of the mangled hand. Here it is the end product. Blast injuries again, quite devastating, looks hopeless at times. After debridement and a flap, a reverse ulnar artery flap. Syndactylized, separated, insert is the pre-operative and the post-operative picture. Salvaging the hand is sometimes, it's like a NASA, like you try to do many things, even though you sometimes have to hear, kal din bhar, raat bhar koshish kiya, aaj din ko kuch nahi, it doesn't matter. See, this is one injury in a young man where the salvage was done by a PIA flap, even if the injury was like, but this is only the one half of the injury. The person has other hand with a similar injury. There the PIA could not be taken. So I have taken the reverse radial artery flap to give 2 flap covers on the individual. Look, on the face of it, everybody, 99 out of 100 people will say, ये हाथ रहेगा नहीं, ये हाथ मुझे दे दे. नहीं ये रहा, ये ऐसा रहा. All complicated fixation and salvaged. Only a small abdominal flap that was taken was put on the elbow. Such an injury in a pinion with exposed vessels and nerves all divided, you repair, but then you have to immediately put an LD flap or a pec major flap to salvage the hand. Okay, yeah. So this is, everybody does it. This is what sometimes you have to do. A bone graft, a groin flap, a nail graft. Result. 4 fingers amputated, no great deal, but make it work. Please remember to repair all the tendons, even if you are tired, or you can ask someone to complete the job, because coming back to repair the tendons is difficult. This is the end result. Amputated hand, a primary flap given to bridge the vessels, the repaired vessel and nerve, medial nerve and nerve. So, okay, so this is a 6-year-old boy, and obviously in double mind. But what happened is, this boy got back his hand, but he was so depressed that he never used his hand for anything. He is now, this is a 20-year post-op. Now he is 26-year-old. He still refuses to use the hand. He is doing a job in Calcutta. So this is again a 2-level amputation high up in the arm, but still this hand could be salvaged. Initially we put these temporary limb salvage shunts, like Dr. Naik puts vein grafts, or sometimes repair, but we put this temporary limb salvage shunts, which are like feeding tubes cut into small sizes and inserted into the proximal and distal end. So this is the hand. He had undergone an intermetacarpal bone grafting to stabilize the hand. This was the post. So this is at the end of this exercise. He was able to use his hand. Pec major was used to provide the biceps function, the flexions of the elbow. Bilateral amputations of a young man. He was 18-year-old when he had this, he was 18-year-old, bilateral hand. And then, he had to go through rigorous occupational therapy to be able to use the hands, both hands, and now he is happy on his bike. So these are some of our patients who come like a crop. Especially this happened before the last general elections, where 2 groups fought with each other and bent up and to do the same, tit for tat. Aapne haath kata hai, mera aapka haath katna hai. So this is what happens. Anyway, every hand deserves its best. Please do not take a quick decision. Please be a little patient and try and take your peer group's opinion. I say initial referral point is your peers of your age, then your seniors, and then somebody working at a distant place who can do some justice. Take his help. Thank you very much.
Thank you, sir. You were given 8 overs, you batted 10 overs, and the hitting was very aggressive. I think it had all the punches, one required in a hand injury.
The players aggressive, the umpires
So tomorrow I think both the team captains will they'll fight amongst themselves to pick up the best batsman in the team. So it was very educative. I think all spectrum of hand injuries displayed very well with excellent results. Thank you, sir.
We go on to the next speaker of the day. Dr. Subhashish is there? No. So we'll go to Dr. J. Srinivas. He will be presenting on tips and tricks of reimplantation. Dr. J. Srinivas.
A very good afternoon to everyone. Thank you, the organizers and Lakshmi for inviting me for the speaker. There couldn't be a better chairpersons for this talk. It would be mediocre to speak about reimplantation across Dr. Vibhuti Naik sir. He is a master in microsurgery. I have Devi Bhai who had mentored me and had his accommodation when I was preparing for MCH in Lucknow, and Bishit Mishra who is my classmate. So all in one. I think since today morning we have been talking about hand surgery, reimplantation and all. At least you have seen 6 to 8 patients who have been reimplanted by various surgeons and various doctors in this group. So I don't want to talk about reimplantation as such because it is about the intent of doing it. If it's in your brain and if you want to do it, you can do it. The procedure is not difficult. You have to have the mindset to get it done. One question for whoever is willing to answer. If you have heard Subrat's speech or talk, the first sugarcane injury and a hand total amputation, which would be more difficult to do it? Any answers? If you ask me, the sugarcane crush injury is more difficult to handle. So even if these injuries of hand amputations are ghastly, they're actually technically easier to do, and the long-term follow-up is also easier. It is the crush injuries that the various photographs that Subrat had shown, those are more difficult to handle. So the idea is it is not how ghastly or how difficult the procedure looks, it's all in your brain. If you want to do it, even those injuries or the hand implant can be done successfully with a good result. And to put the nail on the head, rehabilitation is most important. You do any surgery on the hand, rehabilitation, first web space opposition is extremely important. So I'll run through the presentation telling you only the tips and tricks and the difficulties I faced during the reimplant. I think most of the surgeons during their lifetime will probably get one hand reimplant or uplift implant. So when you get that, you should be mentally prepared to get it done. So I'll tell only the tips and the difficulties we had during the reimplant. So it is a highly specialized procedure because it involves everything in the hand. You have to repair every structure that is cut, including bone, vessels, nerves, tendons, and the skin and soft tissue, making sure that the approximation or the skin contact is there is no vascular necrosis, and you are able to cover with a good soft tissue cover so that the rehabilitation is better and the back to function is easier. So indications, it's well described, clear-cut amputations, finger amputations, and if you see, childhood amputations are easier because the recovery is good. They recover well. The mental build-up of a child is much stronger than adult. So childhood amputations, even if it is technically difficult, you should attempt it. Transportation is important, and preservation, like he said, should not come in direct contact with the ice. It should be stored in preserved in an ice bag and be in contact with the ice. You have to be able to control bleeding. Tourniquet is not allowed. So you have to make sure that when the patient comes to you, he is not on a tourniquet. And if he is in a tourniquet, make sure that you remove it. And for general knowledge, any bleeding in the body, be it femoral vessel or a large vessel, can be controlled with pressure. Patient preparation, as soon as you get a call from the ER about hand implant, make sure you alert everyone involved in the team. That means the nursing team, the anesthetist, and the orthopedician for bone fixation. If I mentioned vascular surgeon as a part of it, I don't think you really need it because you are well capable and trained enough to handle all vessels. So bone fixation is important. Many a times it is better to fix with the primary fixation using plates rather than external fixator because that becomes clumsy and more difficult, and then he will need a revision procedure. If you are very sure about debridement, make sure that it is internally plated and the fixation is done. I am talking about hand implants. Vascular repair, it has to be meticulous. Make sure you repair both the vessels, ulnar and the radial, and then you repair 4 veins, 2 superficial and 2 deep veins. Deep veins are important because they take the chunk of the circulation, and it is important because in our experience we saw when we repaired the superficial veins, it was still bleeding a lot. Once we repaired the deep veins, the bleeding just immediately stopped like that. So I observed that deeper veins reconstruction or the vena completa is extremely important in terms of reimplant. Tendon repairs has to be done. You have to make sure that if possible, you should be able to do the extension tendons first and then the flexors, not the other way around. And make sure that the tendons are repaired in such a way that the functional rehabilitation is possible. And 2, most of the secondary surgeries that are done in reimplantation are for tendon surgeries, so make sure that the tendon reconstruction is good. Shortening is important. So when you do the shortening, a lot of tissue has to be cut so that the tendons are approximated properly. So tension and shortening is important. And shortening also helps in good skin cover and approximation of healthy vessels. So shortening also helps in skin coverage and make sure that the healthy skin and soft tissue. A good soft tissue cover means good rehabilitation and good function. If you are grafting it, or if there is a possibility of multiple flaps and multiple procedures, slowly the morbidity is more and the functional recovery is less. Postoperative care, like any microvascular surgery and implantations, monitoring, early rehabilitation, and functional recovery is extremely important. So you have to, it is not just the success of the procedure. The follow-up is also extremely important. So follow-up with physiotherapy is also necessary. These are the complications that everyone knows, whoever has done microsurgery. So, and then rehabilitation protocols are must. It has to be continued and started as early as possible. This is the patient that you have got. If you can see the tourniquet here, the red color towel that has been tied in the arm, so that had to be removed. The success of the reimplantation is also because the patient was able to arrive in 1 hour of the injury. It is important to publicize and let people know that you do reimplantations, because in the process of changing one hospital to the other, they lose time. So if the people or people in the area know that this is a place for implantation, they'll come directly to you, not wasting time. Primary bone fixation, and then everything repaired. We did a bit of more shortening in terms of 5 centimeters is enough, but we had to do a shortening of 7 to 8 centimeters. The hand looked short, but the coverage was good. There was no skin necrosis, and we started immediate rehabilitation. Post-op physiotherapy, this is the second or third week. I posted this in the Aprasocon group, in the WhatsApp group. I probably just before that or after that, Vibhuti sir had posted a group, and then I thought that I'll talk about this, that reimplantation has to be done. Once in a lifetime opportunity for me, but for others it might be more common, but you should be mentally prepared to do it. Marketing or publicity is important because, like I said, people should know where they have to come when there is a amputation or the finger amputation like this. And once people know, they'll come to you. Wastage in most of the times is because they go to the wrong place at the wrong time, and then retransporting the patient is the place where you lose time. Reset advances, everyone has spoken about it, like hand prosthesis and all. team coordination is extremely important. Find a buddy for yourself. Whenever you are in trouble or a difficult case, find a of you who will help you in whatever circumstances are there, and that should be plastic surgeon. It is complex, but it is doable, much easier than what we think. So I think we should try to implant. This is only to convince people, or at least the new generation, that you should try doing it. Thank you.
Thank you, Srinivas. Any questions?
What should be the warm ischemia time, minimum and a maximum?
So fortunately, in this patient, the patient arrived within 1 hour of injury. But when it is cold ischemia time, it is preserved well, up to 12 hours is fine. If it is warm ischemia, depending on the climate. In North India, a time bed can be longer, but in hot places like ours, it should be earlier. And one more important thing is the amount of tissue in the amputated part. Like more of muscle and soft tissues, the earlier the better. Like in fingers, someone had said, even after 24 hours, people have tried and achieved success.
No, the level of amputation you have shown, it can be also done after 24 hours.
I am not really sure this part of amputation up to 24 hours, but you have got good time because it is all about tendons.
Okay, thank you.
Well, Srinivas is a nice presentation. I have a communication from the journals. In the journals, it has told that even after 12 hours, you can go for replantation. It all depends on what is the situation, what is the climatic environment condition, how the patient brought the amputated part. All those factors are very, very important. And it is not mandatory in all situations. It should be within 6 to 7 hours of warm ischemia or cold ischemia. I think that factor has to be taken off.
I agree,
so,
sir.
In most of the international literature, even national literatures, this has been said. So I think there should not be any barrier or cut-off point after which you should not think of a replantation.
I totally agree with you. One point that I clinically do is observing rigor mortis. I'm not really sure if it is a warm ischemia time of 8 to 10 hours, then once the rigor mortis sets in, you should attempt reimplantation, but rigor mortis probably is a contraindication for reimplantation.
Yeah, one who has seen ischemia reperfusion syndrome in few cases will always be very, very careful when choosing time. So ischemia reperfusion syndrome, once the patient gets in, you are trying to save a limb, you can lose the patient. So that is why we have to be very, very careful. And the duration of reimplantation, if you are reimplanting after 12 hours, suppose you are successful, your function will be much less because all the muscles will have gone. Only these tissues will survive, the skin and tendons will survive, we will have hardly any function. Therefore, time is of paramount importance. And as Dr. Akshay said, so if you are finding a patient in the gray zone area, it's better to revascularize immediately. Either Dr. Jena said, by conduit, I put a vein graft, and you organize your team and save that time so that that ischemia time is certain to your advantage.
Thank you, thank you.
Thank you, Srinivas. Thank you. May I call upon the next speaker, Dr. Rajesh Gantayat. He is now working in IMS Som Hospital. His presentation will be on aesthetic consideration in fingertip reconstruction.
A very good afternoon. Since we have completed two major topics, the mangled hand and reimplantation, I am going to present some smaller injuries like the fingertip injuries. Good afternoon, everybody. Fingertip injuries are very common of the hand injuries, and basically they are associated with occupational hazards, or less commonly in the patients having injury from domestic, like door hinges or through sharp instruments or sharp objects, as well as traumatic. And many of the cases I have seen injury to the fingertip from the bike chain. From the Sunday morning, the patient cleaning the bike, they get injury of the fingertips. So this is a very, appears to be a less severe injury, but it needs very meticulous planning so that you can restore the injury and give a good aesthetic looking fingertip. why at all it is important. These three photographs actually speaks because the first one is our daily, we use our smartphone, we use our fingertips. Another is occupational, that is the patient working on a keyboard, we can see, and the other one is aesthetic. For many people, it is of utmost importance. Fingertip injury, always there is a temptation to shorten the digit and close it. It is very easy, it takes less time, not much of planning required, and basically that encourages many orthopedic and general surgeons to close it by shortening the finger. But this is not what we should do. As a plastic surgeon, we need to be more planned and the approach should be much more scientific. And this picture actually shows, this is left side, this left side photograph shows just stump closure, and the other one is a tip which has been restored by a cross finger flap. The appearance is much more acceptable and it mimics a lot to the normal fingertip. So basically there are many classifications and the classification are based on the level of the injuries. There is another classification, basically this classification which shows the A, B and D, which are oblique transection of the fingertip at various levels, and the C is the transection in the transverse level, and the E is much of a pulp injury. So based on this we can plan our surgeries. So what is the goals of fingertip repair? The goals are maintaining the length, restoring the sensation and the appearance. Nowadays appearance and the maintaining the length has become much more priority, and the second is the sensation. The patient can manage with some sort of less amount of sensation, but aesthetic appearance and the limb length matters to them the most. So what is the aesthetic consideration? Rounded tip, minimal or no scar hypertrophy, color match, minimal length, shortening of the digit and the nail. So basically I have categorized that the level of the injuries, they correspond to what of the types of surgical maneuver we can propose or we can plan. So type A like VY advancement, full thickness skin graft, sometimes they can also heal conservatively because there is no injury to the bone or loss of the. But in category B, we have cross finger, littler, FDMA and neurovascular advancement flap. The C is basically a transverse injury where VY advancement, neurovascular advancement, cross finger, cutler, visor, Moorburg, in case of thumb, all can be used. And there is a D, which is a volar oblique injury, where VY advancement and neurovascular advancement we can propose. So basically they are shown pictures of the VY advancement flap with the result. This is the schematic diagram of the VY flap. This is the VY flap which has been undertaken for a distal tip injury, basically in the transection level, C type. This is another VY advancement for the tip of middle finger and the ring finger, the results. This is another VY advancement flap, the very good looking tip. Coming to the cross finger flap, this is the basic schematic diagram of the cross finger flap. This is a cross finger flap has been done. This is the tip results after the long term follow up. This is another cross finger flap done for the ring finger, and this is the tip. There is some amount of scar hypertrophy, otherwise it is very fine. This is another one which shows the ring finger. There is a cross finger flap has been done. This is for the thumb. I have done a cross finger flap with appreciable results. This is another cross finger for the thumb. This happens to be another case also. A lot many. Coming to the neurovascular advancement flap. Basically, this is based on a digital artery and nerve, and the flap has to be mobilized so as to get a good cover. This is the patient, young patient having an injury to the tip of the middle finger, and I had done a neurovascular advancement flap. Of course, the post-surgical things looks messy, but post-op, this is the result. Patient having a good amount of nail, and the wound has healed very nicely. This is the patient get injured from bullet bike chain from while, and there were 3 fingers. On for 3 of them had done a neurovascular advancement flap. This is a good results for both the middle ring and the little fingers. This is another post-op of neurovascular advancement flap for index 2 numbers. And this is also another for a small child done for a neurovascular advancement flap. Another photograph. Now coming to the visor flap. Visor flap, there was a patient of thumb and gone for a visor flap. Basically it's almost like a transposition flap and the donor site is covered with a skin graft. It's a good result for the thumb. This is another kid having a thumb injury and gone for the visor flap. The results are very good. Coming to the littler flap, this is schematic. This is the patient having a thumb injury. A littler flap has been harvested from the ulnar side aspect of the ring finger, and this is the results after 1 month of surgery. Coming to the thinner flap. Basically, I don't do thinner flap, but this patient had came where cross finger was not possible for the index finger. Middle finger was injured, so I went for a thinner flap. This is the thinner flap harvested and inserted. This is the post-op after division. The patient sent me the recent photograph. It's working and it's appreciable amount of fingertip. So tips for attaining a good result. Planning, magnification. Must use a loop or a magnification while doing the neurovascular flap so that you can get a meticulous counseling, avoid tight sutures, and post-op care. Silicone digital cap is very important. Scar massage and post-op physiotherapy are much more important to get a good flap. This is the patient of the photograph using a silicone digital cap, and the scar has the hypertrophy has reduced to minimal, and it's very much appreciable. So surgery sometimes might look messy, but heals well. Every tip is different, the management also is different. So choose wisely the procedure. Awareness. Fingertip injuries are better managed by plastic surgeons. These are the flaps. You can choose whichever flap has got the best tip result. The neurovascular, thinner, cross finger, and the VY. Thank you.
Thank you. Any questions from the house?
There is another flap designed by Professor Venkat.
Yes, sir. Venkat Sami flap. This is a modification of the VY or the neurovascular advancement. The incision actually basically comes to the MP joint level. So it is mobilized more. I haven't done it, so I haven't showed it. It is another option. There are a lot many options.
You can have in your anatomy.
Okay. Yes. And
advanced plan. If you do that, then you will be able to reproduce the contours of the profile. That is ultimately fingertip distance.
Thank you. Thank you. Thank you.
Okay, this presenter of today is our first student of SCB Medical, first MCA student of SCB Medical College, Dr. Ranjit Kumar Sahu.
Respected chairpersons, my dear teachers, colleagues, and my friends. This is the original work of my department. Earlier, the keystone flap was originally mentored by Dr. Behan, Australian plastic surgeon, only worked on the skin disease like melanoma. But here, we included very newer things into this project. We added all age groups, we added different etiology, we added different sides of the body from head to toe. I think in the step ladder pattern of reconstruction, plastic surgery reconstruction, it will definitely in future get a place. I think it will be, I hope in future it will happen. It's okay. The keystone flap, this particularly the name, this is derived from the Roman architect, and this keystone design of the construction has been taking the name of this flap. So initially Behan, when doing this work in melanoma, he described it is of 4 types. So it is head to toe, we can do any part of the body, and this is the architect, Roman architect, and this is the diagram representing the doing of the flap. Suppose a flap is the wound is the elliptical, then we are making a parallelogram equal to the width of the defect, making to 90 degree touching this to parallelogram. This is the thing, this is the raw area. Now we are doing, this is the only thing is we are reverse dissecting, not cutting to the fascia. So then primary closure with 3 key sutures. This is important, this is the key point, the key sutures. And then laterally the closure by the VOI advancement. This is types, the type 1 equal, not cutting the fascia, only cutting the dermis in type 1. Type 2 cutting the dermis along with the fascia, and 2A, 2B depending upon the need of skin graft. Then type 3, it is when we are bilobe. Then type 4, when we are making it is the movement, when it is rotational or advancement, taking a perforator best, this is type 4. So the physiological basis depends upon the perforators. So depending upon the angiosome concept, the cutaneous nerves incorporated within the flaps, having the advantage towards a sensate flap, increased blood supply after eyelining, that caused by the cutaneous sympathectomy, increased viability. Then the advantage using of this technique is very simplicity in the versatility of the design, less time consuming and a reliable state of a sensate coverage. So what is the aim? So this is a viability and surgical outcome in terms of the complications of the keystone perforator island flaps in resurfacing the soft tissue difference of different etiology. This is our addition to this project. Different etiology we have added, and the objectives, the versatility and the define the keystone flap, the best used in the different regions of the body, assess the severity of the pain and aesthetic outcome, and economic efficiency, definitely the operation time and the hospital stay. The methodology used is a prospective observational study population, the patients being coming to our AIMS of 2 years duration of 44 patients. The inclusion criteria, our age group is 10 to 70 years, and the exclusion infected wound post irradiation, extensive cicatrization of the donor side or medically unfit. The procedure, we take all the consents depending on the characteristic recorded, site, size, shape and etiology of the defect. Then the flap characteristic depending upon the modification of the flap we are using, then the operative time. And flap condition we assess post of day 1, day 3 and at the time of discharge. So what the results we got from the 44 patients, they are male 31, 13 patients are female. The largest size is 150 centimeter, or the smallest size is 6 centimeter, and the largest flap is 18 into 10, or the smallest flap is 4 into 2 centimeter. And the 42%, the survival, complete flap survival is around 95%, and average operative time is 1 hour to 1.5 hours, and the hospital stay is 4 to 5 days. This is the flap conditions. We have very less, we found very less cases we found the partial wound lesion, but complete wound we never found in our study, and the secondary procedure also in only 3 cases, and flap necrosis very less, only 2 cases. This is depend upon the keystone flap of different areas, from scalp, in the head and neck, in the chest, in the abdomen, in the back, in the arm, forearm, hand, gluteal region, thigh, knee and leg. All parts of the body we have included our keystone flap. This is area-wise our study, and this is our types of flap we are used in different type of wound. In type 3, most of the cases, 15 number of cases, and followed by 2A in 17 cases. Then we assess the pay, and very less as per the rank, signed rank test is very minimal. Then Likert scale, we have also assessed the satisfaction level, and the score is very nice in comparison to other flaps. Then some studies, this is behind the ear, there is a row area, type 1. This is a keloid excised and directly go for keystone flap. This is the anterior chest, that with the keystone flap. This is our in the chest area, that is also keystone flap. This is particularly a thumb area, in the thumb. This is the sacral area. This is also sacral area. This is in the thigh region by double. This is in the above knee, below knee. Then our surgical outcomes with this flap is very comparable with other similar studies. But the strength of study is to prove the versatility of flap has covered every major region of the body, successfully demonstrated the utility of the flap with a wide range of defects. The flap characteristic has been studied holistically, with its survivability being the central parameter has been recorded and analyzed. What is the limitation? Though sample size is small, short period of follow-up, and the possibility of operated bias. This is published in the IGPS, and it is pleasure to invite you all to our ear reconstruction, which will going shortly in the first week of the February. So I hope all will come. It's my invitation on behalf of my department. And this is my team, and it's my pleasure to working with my team for this. Thank you.
Thank you, Dr. Ranjit. Excellent presentation. I think everybody wants to end the session early so that the meeting will start. So any questions will be asked during the dinner time.
Thank you.
Thank you very much.
Today, this is the last session. We have bonds and miscellaneous. Dr. Deepak Nanda is unable to come due to his health issue. We are suffering from fever. Dr. Devi already presented. Dr. Bhartendu sir now presenting the bond hand, including the soft tissue distraction. Dr. Sanjay Giri, our secretary, he will present on the bond center AIMS Bhubaneswar. And last, Dr. Syam Sundar Behra, role of dermal substitute in bond management in AIMS experience. I request Dr. Sunil Kumar Raut, Dr. Ranjit Kumar Sahu, and Dr. Bansidhar Mudia to present, to chair this session. And I request all the presenters to present as early as possible so that we will start our general body meeting soon.
Martin sir. So we both the chairpersons welcome you all to the last session of this day. To start immediately, I would request Dr. Bhartendu Swami sir to please come onto the dais and present his paper on burnt hand, including soft tissue distraction. Sir, please. Bhartendu sir is a known name in Odisha plastic surgery community, so no need for introduction for sir. Although he is based at Hyderabad and he is having his own setup and very senior practitioner in our plastic surgery. Sir, please.
Now, with respect to the time, I'll be skipping quite quickly. In contractures of the hand, for flexion contractures, I use what's called a bridge flap. Very simple. We have made modifications in it by splitting it obliquely, incorporating a proximal V to Y and distraction. So yeah, I'll just quickly go. Now with the acutely flexed finger, you'll find that the transverse circumference is always greater than in a normal finger. So we utilize that. So if you split it, the bridge, then you will get much wider coverage than you would otherwise. I'll just show you some examples. So a bridge basically leaves a scar over the volar joint surface, and the skin grafting is done proximal and distal. These are split skin grafts. So I'll just show you some examples quickly. That was the same patient and post-operative, no splintage. Moderate burns contracture, same principle, split bridge, early mobilization. Single finger, severe post burns, multiple fingers. Here you can see they are able to flex and extend properly. So if you, even in recurrent contractures, one can use the bridge principle. Okay. So, and neglected burns contractures with a web creep, you can always do on both the sides and bridge flaps, and then the web actually drops down. But most importantly, I would like to speak about distraction. And if you look at distraction, nature produces distraction. And if you have ever done a cesarean, this is one of the most terrible operations, bleeds all over the place. In a cesarean, you'll find that the recti are divaricated because of the stretch. So stretch applies to all segments of tissue, not just the skin. So we use that. And we use expanders, expand, and sometimes skin stretching. This is a exposed tendo Achilles, so I just apply graded gradual distraction of skin, able to cover it completely. Look at this acutely flexed finger, and we need soft tissue distraction, otherwise it won't come out all the way. And the same patient, very early, you can see post-operative video. Severe recurrent contractures of the left hand. So this is multiplanar. This is almost like there is a centripetal force of contraction. So you apply centrifugal distraction, and post-operatively you can achieve actually a fair level of hand span. Soft tissue distraction is not new. You know, we have done serial casting. Vrisha Madhuri described a single case. Dr. Joshi's team had described a large series of finger contractures distracted. Now in distraction, what happens? Initially, the streamlining of the fibers happens for the fibrous tissue. For muscles, the actin-myosin complexes stretch out, and then regeneration occurs. In other tissues as well, nerve and fascia, similar changes happen, myelinization happens. And in vessels, of course, vessels have a lot of elasticity, though, so they stretch. Now what we do here with in our unit is that we do not use any calibrated distractors. We use simple external distractors, external fixators, and do manual distraction. So we look at improving range of motion, which we check with a goniometer at every stage, 2PD, and ultimately ADL. Here's a very severe burns contracture, a guy whose thumb you can see digging into the forearm skin. And see, 22nd we first released, put him in the distractor, slowly started stretching him out, getting other fingers in sync, slowly healing. Over a month plus, he's healed, And then, after about 3 months, he's back, he's riding a scooter. So you can always do something if you use distractors. Wrist distraction, grafting, and there she is. Very severe recurrent contractures. This man didn't want his elbow done, so we talked him into it, and then we did a 5-flap Z-plasty. Slowly we started distracting and he got back. I'll just take you back. Here, this is at the bottom, extension and flexion. Some recurrence of extension occurred, recurrence of flexion occurred at the elbow. Now this is the armamentarium we use. This is available in any hospital. You'll have rods, couplers, and pins, Shan's pins, normal K-wires. Look at this boy who had acute flexion contracture of the knee. We just did a, same similar split bridge, grafting proximally distally, and slow distraction. Same thing here, almost impossible case. Had this sprouting granulations, got it under control, released. This is a foot in leg Burns deformity where the foot is, you can see that the calcaneum has gone into the plantar aspect, and so we have to restore it back. Slowly we get it down, and this is 6 months later at an orphanage. I could see her, she was walking normally. So I have to cut this short because it's a long presentation. So just to say that, distraction can produce normal or near normal extension in even the most impossible Burns contractures. Thank you.
Thank you, sir, for a nice presentation. Any question from the audience? If no, then, sir, I have a small doubt. Regarding the breeze flap, I have observed in few cases when doing breeze flap in fingers particularly, once either proximal or distal when I release completely, the other release when I proceed, then usually it is so much straightened that it's almost like an incision only, hardly produces any defect to be grafted. So do you have the similar experience or any other specific technique?
When both joints are involved, both PIP, DIP.
No, sir. When one joint even affected, and we are keeping a breeze segment, a breeze flap in between, we will do 2 releases, one proximal and one distal. So suppose first I do the proximal release, then I mean the release is complete. Then almost the release is complete, so that the distal incision when I make, so hardly anything there to be straightened.
Okay.
So
what I do is balance out the two. So I do proximally, distally, both. And make sure that the bridge sits almost on the joint. And sometimes it doesn't, it migrates.
Yeah.
Then you split it and lay them across.
Okay.
And then you actually cover the entire joint.
Okay.
The advantage is your follow-up is less.
Okay, thank you so much, sir.
Now our next speaker will be Dr. Sanjay Kumar Giri, who will be presenting on Bone Center, AIMS Bhubaneswar, a state-of-art unit.
Respected chairpersons and seniors, my dear friends. So this is about our Burn Center, which have just started 2 years back. The struggle, the thing behind it is a team, and what we have done and what is our future, just in 5 minutes I will go. This is our Burn Center. NTPC is 36 beds, but we have not yet started full things. We have started with, this is the date in 2022, we have inaugurated this with a lot of difficulty. It took about 2 to 3 years to complete the Burn Center. Then we started admission patients with 12 beds in February 2023 with a lot of difficulty, with lot of fighting with administrations, because it is easy to open, but to start it's not so easy. We have to take a lot of paramedical walkers, even we have to take some of the critical care things. Then after that, we just 2-3 days before, we are just seeing what is our census. So when we start with 12 beds, then we start with 16 beds, now we have 21 beds. We have opened it up, and in 2 years, we just see, we have admitted about 535 patients. We have done about 330 surgeries, and patients discharged 458, still death is 77. So even if giving whatever the best treatment, we are not able to survive the patients, or 77 patients are dead. So it's about nearly 15% patient has been dead. So this has to be also discussed. These are the census of whatever we have. Every time all the beds are full, but still then death is so high, 77. So we are just now also we are discussing with our team what should we do to prevent those deaths, to prevent the complications. But also a good amount of number of burns are also being healed. Even 50 to 60% burns are being healed. So we saw that about 46% are male, 50% are female. Although the dowry deaths are decreased, but dia burns has much more, and electrical burns has much more increased. Also, if we see these type of burns and the educations, and we are just seeing most of the patients are illiterates, and also they don't know what to do, what not to do during the time of this injuries. And we saw this etiology, and we found that mostly thermal, although thermal is high, but still then 117 and 93 electrical burns is very significantly increased, we saw. And out of these thermal burns, most of the burns are dia burns. It is due to any festivals or any of the events like where any cracker blast injuries, these are the things which found in, this is a census of 2 years only. And burn surface area, if you see, 80% is 11, 70 to 79 is 17, 60 to 69 is 29. So the death which has happened mostly in 60 to 80%. We saw that we are not able to make them survive, even though we are giving the ICU facility. We have started tangential excision, we have done this BTM also we have started now. So all these things we have started, but still then we are not able to, that 60 to 80% that we are not able to make them survive. Time of presentation, also we are just seeing what is the time of presentation they are coming to our center. We found in less than 12 hours, 66% are coming, but in 12 to 24. So most of the patients are coming in between one day, but still then people are not able to know where they should go, and they should even referred from different hospitals after being exhausted there. So those type of patients are nearly 87 patients. They are going to some places where the money is exhausted, then they come to here. But it was late. At that time, the resuscitation was not done, or we are not able to do this tangential excision. Whatever the treatment should be given as early as possible. And also, this is a graph in anatomical location, so I will go first. These are some of the cases where we have done this tangential excision, transposition flap, and patient has survived. They have also, this is a baby which we have presented with 40 to 50%, although his limb is not, we are not able to survive or amputate in the right hand, but patient survived and the parents are happy also. This is also similarly case where electrical burn, transfusion flap has been given. We have also started using dermal substitutes, which is also giving good results. This is similarly tangential excision. Now we have started in all the cases in 24 to 48 hours, the tangential excision we started, and along with that the autograft is there. And in some cases, nearly about 10 cases, we have used allografts, which we have, although we do not have skin banks, which is in our future plan. The skins are being mostly from the National Burn Center Airoli or Ganga Hospital, or from Karnataka. These 3 places we are taking these skins. And we have used it, and this is a similarly 30 to 40% burn, tangential excision, and autograft here. This is also tangential excision, STSC. This is a 55% burn. This is our Khordha burn incident from which this patient survived, and it has made a good highlight of this burn center. Amputation of the left, all these are electrical burns. This is also, I am just going fast due to time here. So this is also a case of burns, so 35% electrical burns and tangential excision. STSG, we have done some flaps, patient survived. This is allograft we have used in some cases. This patient, 45% thermal burns, patient survived, this patient. So 60% electrical burns, we have used the autografts, and patient has survived. And this is a good case, about 60% thermal burn, inhalational, and our critical care team, they have immediately intubated, and patient, this 48 to 72 hours, they have remained very good condition. Then after that, patient stay with us for nearly 2 to 3 months, and patient survived and gone. And while it was some good times with the patient was emotionally attached to the also department. So he left while his birthday cake was cut, like this. This is the same patient, 35% thermal burn, 30 years. And almost in all the cases we started tangential excision and put autograft. Now we are giving this, this is our burn survivors day, when in World Plastic Surgery Day, on that day we have used all the burn survivors and felicitate them. And that day our Secretary APSI was also there with our President AIMS was there. It was being highlighted in proper ways. And recently I have just visited Royal Adelaide Hospital, Australia, to have some interactions with regarding the management of burns, advanced burns, and they are using 60% burn. They are telling that they are going to make them survive. More than 60%, they are telling below 60%, they never allow to patient to succumb. And he is Marcus Wagstaff. He is a very fine gentleman. He is doing a lot of work in BTM. That is, they are mostly putting this after tangential excision. They are putting dermal substitutes. No concept of skin bank. They are using that procedures and making all, mostly I saw 2-3 cases. I just observed how they are using it and how they are putting it. And although I am not able to take the pictures, but it was very good to with him, because I saw some cases where they are properly doing tangential excision and putting this BTM, that polynova, like these things, and these are helping. And after that 2 to 3, I saw 2-3 cases where this BTM is being removed and the wound is being healed. And there is a burns unit, and the burns unit is properly maintained with a lot of paramedical workers, like nursing staffs. Everyone is dedicated to every little bit of works. What is their work, they know it. This is the research unit. With him I am there for some time. There is a very good, beautiful research unit. They are doing a lot of work in composite skin, which is going to come next in the part. And we are going to collaborate with this Royal Adelaide Hospital. Marcus is very pleased to accept our, and he is coming also in February 11. I will going to make a meeting with all our plastic surgeons of Odisha on 11th evening. And he is going to say something about how to manage these burns cases. And the next is these are the 4 things which we are going to do in this year: hyperbaric oxygen therapy and skin bank. And we are going to get a teleconference room, because Odisha state government has given us to make a tele thing to all the district headquarters. It has already come to us, and we are going to make all the district headquarters to attach to our one center, so that they can take the advice what to do initial part, and after that they can send to center. Like this we are planning it. And next is we are planning to collaborate with our Royal Adelaide Hospital. I hope after this collaboration we are going to get a lot of benefit this patient management. Thank you. This is my team. This is, we are going to this year workshop. You know, Padams B.S. Bandari sir, Mohit sir, and Parag Telang sir is coming. It is 6, 7, 8, 9, 2 days, full day workshop. 9th is for carving. So all set. Only we are ready to welcome these 3 stalwarts. Thank you.
Thank you, Dr. Giri, for your consistent effort, making a dream project now a reality at AIMS Bhubaneswar. And this is really a big thing our AIMS is providing to the people of Odisha. And it is one of the best in Odisha also, now I supposed to be. And this burn center, with a few, very less time, it will be changed to Institute of Burn. Under one roof, everything will be available. Now laser, only hyperbaric, as Dr. Giri is telling, something is left, almost everything is compiled now. It will, very soon will be seen as Institute of Burn at AIMS Bhubaneswar. So I request everybody, whenever giving a time, please come and visit our burn center, and let's propagate. Thank you.
Thank you, Dr. Giri. Now I welcome an assistant professor in the Department of Burns and Plastic Surgery, AIMS Bhubaneswar, to present his paper. It's the role of dermal substitutes in modern burn management. It's up to you.
Respected chairpersons, my teachers, seniors and juniors. Our Giri sir has told regarding the modern burn center in Eastern India, which is equipped with all modern burn care infrastructure facilities. Now, the bone injury, which is a global significant problem both in developing and industrialized country. It is the first leading cause of trauma. In India, around 70 lakh bone injury were recorded annually, out of which 1.4 lakhs death and 2.4 lakhs will cripple into different type of reconstructive surgery, and out of which 70% bones are belong to productive age group, that is 15 to 40 years, and around 4 out of 5 cases are women and children. But the recent treatment, already our Professor Devi Prasad Mahapatra sir has told, recently the treatment protocol of the bone patient has changed, that is shifted from the long-term functional outcome and aesthetic outcome along with the survivability. Because the limitation of the normal traditional treatment, either after tangential excision, we are doing regularly by the autograft and allograft, the traditional treatment limitations is only the donor side morbidity, availability, prolonged hospital stay, and increased risk of infection and complication, and chances of rejection in allograft. In order to overcome all these things, dermal substitute, these are the scaffold material which increase the patient improvement. Normally, there is long-term functional outcome and aesthetic outcome in acute bone particularly, and in chronic bone cases, they decrease the quality of the scar and the defect due to bone. So the dermal substitute play a new paradigm to improve the patient outcome and quality of the life. They reduce the healthcare cost and provide a novel treatment option for acute bone. The benefit of the dermal substitute, they promote the wound healing, reduce the wound healing time, decrease the incident of wound complication, and third is they promote the tissue regeneration and collagen synthesis, already Devi sir has discussed. The reduction in the pain, discomfort, already significant improvement in the range of movement post-operatively, that decrease the hypertrophic scar formation and contracture. Then clinical application, they're used in the 3 paradigm, only the reconstructive surgery, acute bone, chronic wound. In our bone center, we are used regularly in post-bone contracture in different functional area like neck, elbow, ankle, knee, or the clinical application. This is a 42-year female patient, bilateral knee contracture, more than 1 year. After we are doing in 2 stages, we release the contracture, application of the polynova, after that NPWT, and after that NPWT, we have after 21 days, we have done the STSC, immediately apply the NPWT again. So this is the pre-operative video. In the next video. This is the photograph during discharge. Similarly, this is a 13-year female child presented with post-bone contracture of the foot. We have released pre-operative photograph, all the toe flexion contracture release, KOR fixation, polynova application, and after 21 days, polynova outer cell removal and applied with STSC. Similarly, this is a 40-year male patient presented with contracture of the right hand. We have done release of the contracture, KOR fixation, polynova application, and after 21 days, removal of the outer cell, and this is after 2-month post-operative photograph. This is a case of post-bone contraction neck. After releasing, we have applied the Polynova and VAC application, and this is after 21 days, remove the cell, and this is post-operative after 2 months. This is a case of acute burn. We have done tangential excision, and immediately autograft, STSG, but after, due to some infective cause, the graft is lost, and we are again regular saline dressing done, and after 1 month, we are applied the dermal substitute, and again after 21 days, remove the dermal substitute, outer cell layer, and this is the post-operative photograph after 2 months. This is the quality of the scar as compared to the normal STSC. And this is again a case of dermal post-bone contracture neck. We have released the contracture, applied the dermal substitute, and this is after 21 days application. This is a post-bone contracture elbow. We released the contracture and applied the Polynova dermal substitute and NPWT after 21 days. Again, we are doing remove the outer cell layer and do the STSC. Similarly, this is a case of anterior electrical bone injury, 9-year-old boy, electrical bone injury with anterior chest wall exposed rib. We are doing single stage dermal substitute with STSC, and this is the follow-up post-operative photograph after 6 months. This is again a case of 10-year child with post-bone contracture PBC right hand. We have removed the contracture, give the KOR fixation, applied the Polynova, NPWT, again after 21 days remove the outer cell, and this is the immediate post-operative photograph. This is again electrical bone injury with the exposed frontal bone with a tissue defect in the right side cheek. We have applied the dermal substitute and followed by STSG. And these are the acute bone cases. Normally, we are already done the stage 1 only, not we have removed the Polynova and STSG. This is the case 1. The case 2, around 45% thermal bone. Already autograph, whatever available, we have done the tangential excision, and remaining area covered with dermal substitute. This is, so the conclusion, the main goal of the treatment for survival but the lifelong post-bone scar revision and reconstructive need of bone patients should not be ignored, and the quality of life should be improved. So dermal substitute implantation following STSG after early resection in the deep bone, involving functional or mobile area, is a good option for preventing hypertrophy scar and functional loss in the post-bone period. So the dermal substitute have revolutionized the bone care, because normally in deep bone and full thickness bone, the dermal component never be replaced by STSC in the normal protocol. So ongoing research will drive further innovation and improvement. The dermal substitute hold a great promise for the future bone management. Thank you.
Thank you, Dr. Behra, for a nice presentation on application of dermal substitute over acute as well as chronic, post-bone deformity reconstruction. I hope there must be several questions from the floor, but because of the paucity of time, we are winding up. So anybody having any doubt, you can discuss with Dr. Behra or AIMS team in person. Okay, so there is no doubt that dermal substitute is definitely bringing new revolution to the treatment of bone patients. Thank you so much. And we are winding up this session here. Mic is handed over to the organizers. Thank you.
Thank you so much. Thank you so much, sir. Now moving forward, I would like to request Dr. Sanjay Giri, sir, to proceed for the hand surgery fellowship felicitation.
Respected delegates, I am very privileged to say that we have started this observership or fellowship, whatever money we have saved, little bit of in our ISHCon, and I must be thankful to Biswajit Mishra Bhai, Subrachana sir, Arun Chaudhary sir. At that time we have decided that from this interest we will start to send some of our young colleagues to outside to have visit some centers and have a good thing about the training of hand surgery. With a lot of difficulty, we started it and it has become successful. I don't know whether it is success or not that they will start, because this is the first time we have started, and 2 fellows from 2022-23, whatever interest we come, and we have used that one. So for 22-23, Dr. Ahana has been last time selected, 23-24 Dr. Vishnu has been selected, and 24-25 that next year whoever will be given, I think the committee has decided Dr. Sivaram from MKCG has been selected. So now for the time they will give their report, whatever they have gone to the institute and what they have seen, and after that we will. Thank you. I think now Dr. Ahana is being invited for 22-23 regarding her experience. You are ready?
Respected dignitaries, seniors and my colleagues, this is a brief review of my stint which I was able to do because of the Aprasocon 11th Hand Fellowship. At the outset, I'd like to express my deep gratitude to Apraso for giving me this opportunity. Next slide, please. Oh, okay. I attended Ganga Hospital from 9 to 19 December 2024. During my tenure there, I was able to see multiple procedures, majorly related to brachial plexus, hand, pediatric hand, and trauma reconstruction. I was also able to attend the OPD clinics, which gave a better overview regarding the cases there and their follow-ups there, as well as how holistically the physiotherapy department worked along with the consultants. I was fortunate to have a closer view about the post-operative protocols and the documentation, and also we discussed regarding what all changes that could be brought about in our post-operative protocols and documentation as well. There was a lot of teamwork and brainstorming. They always encouraged the co-observers and co-fellows to be a part of. I was very lucky to be associated with multiple other co-observers and fellows from national as well as international, who shared a lot of enthusiasm. They inspired me every day. I was also lucky that Dr. Vishnu, my colleague, was able to join me on the last day. So that was also a cherry on top of the cake. I'd like to thank the entire Ganga team, especially Dr. Hari sir, Dr. SRS sir, and Dr. Praveen sir for their graciousness and magnanimity. And definitely, without fail, I'd like to thank my alma mater, my AIMS family, all my teachers, all my colleagues, especially my mentor, Dr. S.K. Giri sir, and my guru, Dr. Shantanu Subha sir, all my fellow residents, my colleagues and my juniors. This is a clip that I had taken from one of their morning classes. Thank you very much.
Good evening, everyone. So first of all, I would like to thank the Apraso Hand Fellowship Committee for giving me this opportunity to go to Ganga Hospital in Coimbatore for the traveling fellowship. So I attended Ganga Hospital from 19th of December to 29th of December. In this tenure, I attended the morning teaching sessions, ward rounds, outpatient clinics, operating theatres, and there was Christmas celebrations. Highlights of this were, they start the day very early. There was a session early morning at around 7:30 daily. So it was a consultant-led teaching. Active participation of the consultants were there in it. There was a high volume of cases with varying complexity of injuries that we have seen. There were 16 dedicated operating rooms for the plastic surgery department. Remarkable patient-centered care was seen. Regional anesthesia to assess patients immediately. This was the learning point for me. It was very swift approach in handling emergency cases, directing them towards OT. And interactions with observers from various countries, this was the highlight point. How to implement our learnings into our setups. So you should be a leader first and bring a complementing skillful team together. Make small changes that give big results. You have to spend more time with the patients and the system. You should get involved more to the administration. You have to keep the cost down. It doesn't mean that even in government setup we can use our own own time. So even in government setup it matters a lot because overall to the system it brings that cost down. And repetition that is mother of success. Focus should be on how to give the best result rather than concentrating more on what to operate and how to operate. So these were the whole cases, broader way which I have seen. Brachial plexus, mainly of global brachial plexus, the protocols and holistic approach, how they proceed for the case. And secondary procedures in brachial plexus I have seen. Use of Botox, this was a new thing for me, which I have seen in birth brachial plexus injuries. A role of a surgeon in physiotherapy, how he himself personally educates the patients. And wide use of abdominal and groin flaps in complex upper limb defects. There's a wide use of gracilis muscle flaps in trauma. Internal splinting and diabetic foot surgeries. And the use of CAD-CAM technology I've seen in complex facial fractures. Like in this, the first picture shows how complex the facial fracture is, which with CAD-CAM technology, it has modified to the good visual approach. And these are few cases which I have observed. And I have learned the importance of photography record, how to maintain. And no work is small and no person is big. Everyone has to do everything. We should prioritize things and stick to our basics and excel towards the growth. And patient counseling is very important. Take home message, one should actually bring a good team together. We all know too many cooks spoil the broth. But a well-trained, skillful cooks under a good leader can make an elixir out of nothing. Thank you, Ganga team. I would like to thank my department, my HOD, my guide, and all my mentors and my colleagues for giving me this opportunity. This was a great learning for me. Thank you very much.
Team, that is fellowship team, Viswajit Bhai, Subrat sir, Arun sir, please come to the stage and give the certificate and the check which has been decided. Dr. Jayant, I think committee was of 5 and with great difficulty we have done it. Let us continue this one and I hope this is going to benefit all the residents. So I will ask all the residents to put, because I am putting this in our group many times, so you apply it so that you can get it. This time 4 has applied, but whatever rule is there, according to it, only Dr. Sibram was qualified. So he is being sent for 2024-25. Anyway, come, sir. Arun sir. So, Lakshmi bhai, please come to stage and so that we can give the tickets and we can give the we can give the certificates and the money. So Ahana come and Ahana is for 2022-23. Samir and which one? Second floor. Second floor they are going to have give the preliminary, and we can have our GBM here.
We will start our general body meeting now. I think all the delegates should sit here and we will discuss very important part of our association, how we will grow. A lot of things to be discussed, and our secretary has already, Dr. Sanjay Giri has already prepared the agendas for the general body meeting, and it is very important for all of us how to progress in the future. Dr. Sanjay, please start this meeting, and we can call also the treasurer, Dr. Satyabrat Rautray, and Vice President Dr. Ruchi Gupta, Madam. Inaugural. All are requested to sit here, and we will start our inaugural function after 15 to 20 minutes. Actually, the CEO and DMS of Apollo Hospital Bhubaneswar, Dr. Alok Srivastava, he will come as a chief guest, and our guest of honors, Dr. Subodh Singh sir, Dr. Vijay Kumar sir are there also. We will start this inaugural function within 15 to 20 minutes after completion of this general body meeting. Already we are in the scarcity of the times. We want to complete as early as possible. Then we will plan for these cultural events like Goti Puo, and followed by we have a melody program by Dr. Anjan, who is an anesthetist in Utkala Hospital. He is a very professional fellow in singing and melody. And I request Dr. Sanjay to start this general body meeting as early as possible.
Agenda was approval of the last proceedings of the last executive committee meeting, which we haven't circulated. So these were the EC meetings. Is approved or not? I think someone has to approve to tell. Last EC meeting that has to be approved, na? Who is writing? I think last executive committee meeting, which we have done in the Zoom, it was circulated in the EC that there we made certain guidelines for making the, you are writing, for making the bi-monthly meetings and the because there is a problem with the financial transactions, so whatever the problem is there, it has to be sorted out, and who will take over the charge for if he wants to do any type of conference or whether they will use the Apraso account or not. That was the main agenda was there, because there was a lot of hodgepodge in between different things, because Apraso, so that was one thing, and second is about the office in IMA which we have taken. So for the office in IMA, it's already in process. I think by 2 to 3 months we will get our own office of Apraso in IMA. I think maximum 2 months. Already we have given 15 lakhs, and another 10 lakhs is required, for which we have already deposited about, because Sunil sir has saved 5 lakhs and has given to that one, and he has told that it has to be utilized in the office purpose. And along with that, Ruchi madam has given 50,000, and Lakshmi sir has also given 50. So we have nearly about 7 lakhs. So another 3 to 4 lakhs required maximum. So that is why I have repeatedly requested all the esteemed members to contribute 10,000, those who have not given. Except that Subrat sir and Vibhuti sir has told that they are going to contribute little, and Akshay sir is not there. Sir, apna check test debe. Check. Again? 5 lakhs. How is Akshay? Akshay sir has. Sir.
Really, it's a problem. Actually, I have also faced many of the companies are asking the same questions, whatever you have also told me, and it's a duty of not the president, not a single man's jobs. It's the duty of our association. Everyone should be think for this this sponsors.
Yeah, at least,
Otherwise, it's
at
difficult
least
to
few,
continue in the future.
Yeah,
Even I faced the same problem, and I think the association and the senior members of this our association should advise us what to progress in the future. That too, the younger generation should not get a problem in the future programs like Apraso. And mostly I have seen also when someone is contributing like in aesthetic surgery conference which was organized by Joint in the last 6 months back. These companies are not cooperating for this annual conference. So what is your suggestion for, I am asking from Dr. Vibhuti Naik sir, but what is your suggestion? Someone is organizing a function like rhinoplastic means aesthetic surgery conference or cleft conference. It should be merged with the our association this annual chapter, or it should be a separate if someone is doing like someone is doing a separate conference of the aesthetic surgery, it should be separate from the this one, and otherwise it should be merged. We will give a 1-day program for the aesthetic, like today I have done for 2 days. If you will keep 1 more days for the aesthetic surgery, then the sponsors will be participated in a more number and it will be a fruitful for us. In future, I have seen also many of the aesthetic, those who are sponsoring, like this cosmetic surgery products like laser sir, they are already we have done this 6 months back. We cannot participate here. So I need your suggestion from you all, like we should merge in a single conference program, or otherwise multiple programs should be done.
See, if we merge, obviously it's going to be beneficial to us. But whether the aesthetic part they are going to, they are willing to merge with us. Same thing happens at the national level also. The aesthetic unit is different, and their sponsorship is much better, and they conduct it in a much better way, because in aesthetics there is a lot of products and lot of companies supporting it. But in plastic surgery, in Aprasocon, it becomes difficult. So if you merge, obviously plastic surgery is going to gain, but will the aesthetic counterpart agree? That's one. But since here we don't have exclusive aesthetics, so we can combine and it will be beneficial for us. So
What is your suggestion, Jayant?
Since you have pointed out my name, so I will definitely answer it. So it is not like that. The 6 months back, I organized one conference. Most of the sponsorship was because of my prescription. Okay. So it was not like say everybody is prescribing that thing. Okay. And I have selected a few companies whom I am supporting, and for that I had to purchase certain medication in my clinic also. That is the problem I faced. Okay. And for sponsorship of Aprasocon, always there is a different groups of company, like Ethicon did not sponsor my conference. Okay. So it was a different thing. So we cannot, just because the conference happened 6 months back, the company was, so it's not the right thing to say that the company did not sponsor because of the conference. And second thing is, there are many conferences going on throughout the year, like Dr. Vishwajit Mishra organized one conference, Dr. Giri I think organized 3-4 conferences in last year. So these are on different topic based conferences related to specific things, specific theme. And Aprasocon is our general conference. Yes, I agree, if you conduct some conferences just 2 months or 3 months in a very short period, that's a different thing. But Aprasocon, the sponsorship is a different thing. And always we should combinedly sit together, and we should have a protocol to call all companies also as a group, not as in individual. Suppose you are the president, you conduct a committee to approach all the companies for the conference. Then they will sponsor definitely. It's not that I will tell, suppose I told Menarini to sponsor. He sponsored the thing for you. But it's not like that. But if you work in a group. Suppose we will work in a group that we are conducting our conference for our association and you please, they will definitely sponsor. So that is the thing.
What is your, I want to know from Dr. Ruchi Gupta, madam, and she will be the next president and she will face the problem. She has to answer for this one. She has to rectify, and what is your opinion for this one?
I think my opinion in this case will be like we cannot, it is not possible and it will not be good that we do not do any conferences in the year. But I think we should limit the number, one thing, and it should, we should limit the number and we should take care that it involves all the branches of the plastic surgery. It should not be like body contouring or aesthetics only. It should involve all the branches. And I don't think it should be more than 3 or 4 in a year. So that we can get the sponsors for the Aprasocon also, and all the year we are excited to look forward for something.
Thank you for suggestion. And Arun sir?
Actually, we should not mix up the two things. Certain academic programs will be endorsed by Apraso. I mean, they should be conducted under the banner of Apraso. And other than that we can have a restriction on that. But we cannot restrict individual institutions carrying out any workshop or any academic program. Like Dr. Jayant told, he has an agenda, he is running an academic program. In AIMS, AIMS team is having regular academics. Tomorrow I may run an academic program in my institution. Similarly in SCB, Vibhuti sir may, or Vishwajit Vibhuti sir, they may, obviously everybody will be interested to have some academic program in his or her own department once in a while, maybe once in a year. So we cannot restrict that, don't mix up with that, because every practicing team or surgeon has their own clients, own supporting companies to whom like I can demand certain companies to sponsor for my event. But the other thing I would request all the members sincerely that we also keep it, we should keep it in mind that at the end of the year we are having an Aprasocon annual conference. So whichever company we are in personal relationship we are demanding to support our event, we also take some responsibility for the annual event also. And at the time of annual event also we will request those companies please contribute to our annual conference because that is our parent body. Sir.
Yes, I agree with Dr. Sunil. Everybody should, besides conducting their own meeting, should help the Aprasocon. So all of us who have tie up with particular companies who we are supporting, we should pressurize them to sponsor our main Aprasocon in addition to whatever meetings we do.
You see, as a whole, all companies have their resources and they are business people. When they invest single pie, they want to get return of it. So reciprocation has to come from us. So they very much evaluate and reevaluate ourselves. Who is going to give us the business? So considering that main is the money factor. It is not our sponsoring as such. So the money factor that makes a difference. So what I feel with my short experience that whatever meetings or anything we are going to have it, let us have it a planning. At least one, as being done by Ganga Hospital, any hospital in the country, discipline place, 1 year back you should have plans with you. When you come up for general body or in the executive body itself, we should have discerned, yes, this institution is going to have this CME, symposium or live operative workshops, whatever. So that what happens, then we can tell the companies that this company is going to sponsor that event, that company is going to come to the Aprasocon or for that, so that there is no doubling or confusions. That is what is happening. If already somebody had drawn out in the month of February,
In the next January, when Ruchi is going to have the conference, you tell, sir, in this year we don't have budgets. We have already adjusted. So I hope anybody coming with any proposal, he should come by the time of general body and executive body. So that, like in national conference, national what you are doing, every 3 months or 4 months anybody is going to, they invite, officially they write to the executive council, executive committee, yes, I am going to have a CME. Like suppose in AIMS they are going to have next month. I think it should not be arbitrarily made out without the knowledge of the members. So what happens? The companies, they withdraw. And by personal capacity, somebody is drawing good amount, may, suppose join does it. He has a better hold with the companies. He will have it. But when somebody else does in a medical college, suppose in Berhampur, then he had to struggle. So with these differences, I think with this, there must be some planning and some protocol has to be made out, I hope. If that is made out, in the future may not be everything is possible in one day. In the long run, we will achieve what problems we are facing by our last experiences. That is rule. Rule is always rule when it is followed and implemented.
One thing is,
Once it is not implemented, it is not a rule then.
no, the thing arises here because we usually previously bi-monthly meeting do. So bi-monthly what we are doing now, we are in this GB, we decided who will do what. Every 2 months we have a 1 hour meeting and that was like academic like that one. But suddenly last 2 years, we have lot of workshop and conferences in different institutes. What it is good, but the thing, their problem arises when annual conference we arise because it is too difficult to organize. Just we are discussing, we are also seeing people are ready to give only 30-40,000. And so what to do? So that is why these things has come out. So if we are doing bi-monthly previously like 1 hour and otherwise we can do like that one bi-monthly meeting can be sorted out like this academic feast of the different institutes. So that is the thing arises.
Bi-monthly should continue, bi-monthly should not be mixed up with this issue. Because bi-monthly, as we started, bi-monthly meeting is a responsibility of one of our member. One member should take the effort, should arrange the money from his own pocket or from sponsorship, whatever we don't mind. That is why we give usually one member the responsibility to hold a bi-monthly meeting. And that is also not forced on any member. It is voluntarily from the members if the member agrees. So bi-monthly meeting is not an issue. If the member who is arranging or organizing the bi-monthly meeting, if he can arrange some sponsor for the event, doesn't matter. But
What has happened now? What
Sir,
has happened?
so it is replaced by, I understand, it is now replaced by the academic event, day-long event or like that.
Sir, I suggest that, as Sunil sir said, ki if the institution wants to do a conference, they can do the conference. Like the one we used to do bi-monthly, it was supported by one person, the person who is doing it. Do not use the sponsors. If you are using the sponsors, it has to be under Aprasocon and we cannot have more than 3 conferences in a year and it has to be charted out beforehand that in these 3 conferences will be done by this person and in that a small number of sponsors can be used and then the rest of the sponsors will be used in the Aprasocon. We can chart it like that.
So if you will do like that one, if bi-monthly will be done by one person, 1 hour or 2 hour, whatever is done, then whatever workshop and all those things are being held by the institutes or what. So should we include Apraso logo there or not? If you are using Apraso accounts, then it is too difficult to manage. I know how difficult we are managing. I am managing for last 10 years. I know it's not an easy job. He is helping me, but till now all accounts are with me for last 10 years. So if anybody, my question, because now we are growing. Previously it was 5 lakhs. I have seen from 1,000, now it is 30 lakhs like that one. So if we are doing it like that one, then the person who is doing the workshop or any other than this, they should not be amalgamated with Apraso. This has to be taken decision. Huh.
Also the sponsors should be limited.
has to have a accountability. Otherwise, single person, either bi-monthly meeting or that workshop or whatever, single person will arrange, like you are arranging in your institute and institute support is there. But those who are in private,
That is
they don't have any support. So the company who contributed it, they asked that why sir you are not writing. They are cheap way also they are giving comments and मेरा पैसा तो बेकार चला गया. So who
No,
will
no.
be responsible for that?
No, that way, sir. Sir.
See, about the company, it's a very standard rule. And when they participate, they are for to exhibit their product. And it's not the reverse that because they are coming, we have to oblige. There is no such thing. See, because they participate continuously, and we feel obliged to support them. See, I know among the 100 members, it may not be possible for everybody to support. Somebody may be using some X company's product, somebody may be Y company's product, and like that only they will get supported. And about the workshops, see, one thing is very clear. If institute is doing it, let them do it, because many departments, they have their own account. They manage. It's all right. And so also we do in our department. We don't take, we don't inform APSI, or we don't even inform Maharashtra State Chapter. We do our own. And when we do that, there is no onus on us about APSI or MAPSCON. That is clear. But the workshops we do, apart from because these are done by the institute, they are mostly educative, for education purpose, and they don't involve much cost. That is well. And with small amount of money, it can be managed. That is one. And second thing is, what we also do is, we take help of the companies. See, many companies have also supported us in the beginning, where we were not able to give them any, support. But subsequently, also when we had a chance, we supported them. And also when we conduct more courses, we also oblige them, not paying anything, but they can display their product or come forward also. And I think one more thing is workshop, we can take sponsorship. It's not sponsorship. It is sponsored by, or what you call is, support. That is, there is a particular term is there. So that is means, suppose it is supported or approved by Aprasocon. Endorsement. That can be done.
Many companies, they ask for GST number, and if a person is a private one, doesn't have any existing GST number, then it's difficult to do transaction with the X or Y companies.
No, it's...
No, GST is only up to 50 lakhs.
See,
if your transaction is more than 50 lakhs, then GST number is required.
No, it's not necessary
you don't need to have a GST number.
No, it's not necessary to have a GST number. They can support, because they have to provide a PAN number. Without that they can't do. GST number, suppose I don't have a GST number. So I can tell them that I don't have a GST number. They will pay GST, but will not get that credit. It is like this.
But individual PAN, they may not pay also.
No, individual PAN means that is their lookout. Even many private hospitals also, they have an account, they allow them to money from the workshop to be conducted, and that PAN they can use.
You have to have a PAN number for that particular conference or workshop.
That also can be done. Suppose I want to conduct a workshop. No. That I tell you one thing, very easy thing. What we do is, see, they can do a AOP, Association of Persons. 3, 4 or 5 people, they can form a AOP, they can get it registered, and they can apply for a PAN number they will get. Even as a AOP, they can get a GST number also. But it is a onus on them. When they open a PAN, they take a PAN number, they have to submit account and also pay due income tax, And also GST, if they collect any GST from the company, they have to settle it. They can apply for that, can be done.
Thank you. Second agenda.
Sanjay, I have a doubt. Suppose one conference is organized by somebody in a private institute or government, and Apraso is supporting that. We are attaching the Apraso logo also. And it's not easy to open one new account, as you said. But my question is, why Apraso will not support as academy?
I have not.
Because
No, when you are doing a functions, we are also supporting. You have seen also both the years, all the members were there. When you will come to the functions, when you will be the president of Apraso, you will face the sponsors will be.
You don't understand my question.
Okay.
My question is the account part, because it's not, Prithviraj Bhai told, that it's not very easy to open one account. Unless until somebody is like conducting one annual conference, that's a basis. If somebody is conducting one workshop, is it easy to open one account?
No. I think Apraso logo should be.
Can I
When it is our small state and very few members are there, I think separate.
Dear President, can I intervene in this matter for 1 minute?
Lakshmi, that is my question, because I have a workshop for 2 times and Apraso has supported me a lot. Okay, and I am obliged to the association because I think it's my right because I am a member of this Apraso, and because I did not open one account, and that was easy for me. And Satya also, he has helped me a lot because of all the transactions. I think for small workshop we can conduct through Apraso.
Definitely. It's a good thing.
We can open
Jan,
one account.
Your suggestion.
In that matter, same issue, I have an opinion. I don't know the House will agree or not. For those kind of events which needs the support of Apraso and endorsement by Apraso as proposed by Chaudhary sir, our trustee, it should have a prior plan submission and approval from Apraso. And Apraso will fix the guideline. This is with all bigger associations.
Yes, that
The association, parent association will fix the guidelines and when to do. It should not affect our main conference. So those things will be handled by the individual organizer will manage everything, but to use the Apraso PAN and Apraso logo, then it should be approved by the Apraso Executive Committee.
And as said by Kochi Madam, there should be spacing of the date. Spacing of the date.
See, may I say something? See, endorsement is different. Using Apraso PAN or GST number is different issue. Apraso can endorse a event, but may not allow to use their PAN number or GST number. They can. And the person who is managing it, they can have their own account, own PAN number, GST number, they can manage. See, like Dr. Lakshmi, I ask you one thing. You are working in Apollo Hospital. They must be having an academic account where money can be deposited. They can use the hospital PAN for that. They must be having inquiry. Like that, most of the institute or private hospital, they have their own account for supporting meetings and all. They have. That can be used.
Thank you, sir.
Then about the bi-monthly meeting, I think this year also we have to streamline for the whole year, so that things will be streamlined and there will be no problem in the future. And if somebody is in the mind that they want to do workshop or that thing, that can be amalgamated in that bi-monthly. I think this year we can do that one. And next year, whatever sir is telling, we can make a committee and we'll make some guidelines. And after that we can do accordingly. Anything? For bi-monthly volunteers? Bi-monthly, actually, I would have just, sir has told that about the, for your kind information, because you know that we are trying for that year workshop. So February we are doing it. Okay. So if everybody house is ready, then February month we are already in the verge of making it finally, if allowed already, then we will do it in February.
I think it is allowed. I think that can be taken up.
February aims. Yes. Then March, April is there. No? April. That is. March. I am telling you, basically, what is problem is there, so much of conferences. In March, we have aesthetic conferences. Again, in February, we have Nabicon. Then what you will do? What was previously? But it was, previously it was done what in November we are not keeping it because Aprasocon is always there. Then all right. If you can continue like this, then there is no problem. Because if you see in bi-monthly what is happening, 10, 20 people are coming, and so we have to be like that so that it will be useful. If you are telling like that, then if you will do it in today, this is January. So if February I am doing it, then in the month of March there will be workshop. Then all right, March. It will be too difficult to do. Because if you see last 2 years, Aristo is the only pharmaceutical who is giving for the bi-monthly meeting. You must have seen for last 2 years, all the bi-monthly he has sponsored. All bi-monthly he has sponsored. So if you want to do like that one, March, May, July and September and November is Aprasocon, we are not doing on that year.
I think Dr. Sanjay, I will agree with Dr. Biswajit. So let us fix that thing, March, May, July, September and November. So there is a gap.
But whatever you are telling, just see, because no, March bi-monthly there is aesthetic workshop. You people will not be there because that is in the just listen. Second week because second week is the aesthetic, na? Aesthetic. 5 to 10.
So how we can do the next week? So our bi-monthly schedule should not be disturbed for any workshop.
Sir, I have to say one thing, sir. Sir, there is a difference between a workshop where we come for academics bi-monthly, as sir saying that we can do small gathering of the plastic surgeons in Cuttack, Bhubaneswar.
Right.
So I will say we can raise hands because according to Giri, in last few bi-monthly meets, hardly 10 or 20 was the attendance. The person arranges for 50 people and 10 people reach. That has been the situation. It has been with me also. So I want to say how many people want bi-monthly to be combined with conferences, workshops, and how many people want bi-monthly to be separated?
Yes, that is
Raise your hand.
Yes.
How many people want bi-monthly to be combined with workshop?
Bi-monthly to be combined with workshop.
हाथ ऊंचा करो. So I think
only bi-monthly.
And how many wants bi-monthly to be combined with away from individual?
4, 5.
5.
So what to be done?
So I think the number is that majority wins.
Oh, that is the thing we are just discussing there.
That is the thing we can do is making it tri-monthly. Then it is as such we will be, if we are doing 3 conferences, so it comes to be close to.
That
Okay.
you can do it.
Okay.
Those who have not raised their hand, they are not attending bi-monthly meeting.
No, that is
It should be tri-monthly.
Why I just changed to the...
As proposed by Vibhuti Bhai and Akhay Bhai, I think bi-monthly or tri?
Sir, so what is the, I take the vote for tri-monthly, separate from conference.
Yeah, tri-monthly.
Separate from conference. So tri-monthly, separate from conference, second Saturday of every third month. Okay.
So March,
So tri-monthly means January is the annual conference.
Sir.
So April, July and October. There will be three tri-monthly meetings in a year. Right?
Apart from the workshops, huh?
April, July and October. Three.
January, February, March, April, May, June, July.
So there will be enough
August,
space
October.
from October to January
So
for the workshop.
so we will have bi-monthly on April, we will have bi-monthly on July, and October, tri-monthly.
Tri-monthly. Tri-monthly.
ठीक है तो no, that is, Aprasocon is always November. Change that can change. So again we will go to February if we are doing the AIMS workshop. So we have nothing in the March, we will go to the April. April tri-monthly, who is going to hold?
Katak.
Katak, who is there to?
Bhubaneswar.
SBM last time, so it comes to the turn of the Bhubaneswar.
Tri-monthly April, Bhubaneswar.
Okay, Jayant. Great.
Then anybody who was planned for any workshop, then he can tell. Otherwise, we will go to the next tri-monthly.
Anybody having any plan?
Any plan for workshop?
Out here, so that everybody
I think,
Sir, we have to. Sir,
but
but
whenever
sir, we have to chart down the calendar today
So
for
that
the next one full year.
actually it's not very easy. Somebody have an idea depending upon the availability of the faculty.
Acha.
So it's very cumbersome. So yes, there will be a protocol if anybody is organizing the conference or workshop individually with the Apraso logo, he or she should apply to the Apraso that I am conducting well before the time.
So for
Okay,
the
so
time being,
you want to do? Unmesh, you want to do one? July. So that is fixed.
no, July is, we are now, just no confusion. We are here discussing about the tri-monthly, whatever decided, that is April, July, October. But you are telling that you want to convert that aesthetic part. That is totally different from the tri-monthly academic, 1 hour. That is on the only evening. So that is not any related. He wants to do that aesthetic.
Now we have decided to separate the tri-monthly with other.
That is why I am telling. So why?
We are talking of the
So if April is a joint sir, then July is by Katak. So who is doing to from Katak? And October is Bhubaneswar, 2 part. ठीक है, that is your team only. That is tri-monthly 1 or 2 hour. That is in the night only, evening. Yeah. So October is from Bhubaneswar. So these are the tri-monthly finalized. I am telling you. Everybody says yes, then there will be no confusion. April by the Giant sir, and July is Satya in Katak, and October is very right. That is all evening 1 to 2 hours, nothing else. Other than the workshop till now is only February of our year reconstruction. Other things you can apply. That will be decided.
Anybody interested for any workshop, seminar, CAB, live operating, whatever, you should apply to the
Executive and
secretary.
then it will be
we are
decided.
going to conduct so that whole Aprasocon will support you in every aspect. Otherwise, what happens last moment, 1 month before, you want to conduct something, then you are in problem and we are also, as a whole, will be in trouble.
I also want to say that what conferences will be decided, I think it should be done on the first come first basis in one particular field. Like for aesthetic, 2 people are applying, we will take it on first come first basis. Otherwise, the other person will say that yes.
Madam, I will suggest we are very less people.
Don't
Very less few
Madam,
people.
Madam, don't be so much strict like it.
So let it be in combined way. Let it be combined way. Nothing like that.
So let everybody explore the things.
Sanjay, we are going on third
Next.
agenda. Huh?
discussion regarding office in IMA house already discussed. I have already told.
Vibhuti sir will, Vibhuti bhai will donate 1 lakh rupees for this our association.
Yes.
We request also.
Sir, because I am telling you the fact, the office is in the verge of completion and we have to take him from them immediately. And I am in touch with Mrityunjay sir. He has already told that to come for our tile selection. I think by another 1 or 2 months we are getting it. So we have to be ready with money. Money is with me, whatever we are discussing. It is about 7 to 8 lakhs. So another 2 to 3 lakhs required. So those persons like some of the esteemed members, if they contribute 10,000, I think we will get it with sponsor from Vibhuti sir 1 lakh and Akshay bhai 50,000 and 1 lakh is from 1 lakh from Subrat sir. At least I think we would request all this so that it will be easy and we will get our own office of Aprasocon.
We have also decided who are paying a good amount,
Sir,
their names will be inscripted there.
Sir, I think everybody is agreed. Sir, if you will give, I think it will be going to sorted it and we will take it because we should not keep so much of money. We have already whatever we have saved like 15 lakhs, we have deposited there. And all esteemed members have contributed 50,000, 1 lakh, Saraj 1 lakh, Saraj also 50,000.
Thanks to senior and junior.
They have also, everybody has contributed. So I think little bit is required and if we will go and we will get our.
Also, he has given us 5 lakhs. Sorry.
Sunil. So, Aprasocon.
He has given 5 lakhs.
So many members, no sir, even I think we have got from 35 members 10,000. So it's a huge achievement. From a such small association like 60 to 70, although number is 113, but many are PGs. So to be frank, it is about 60 to 70 members. And 60 to 70 members, 35 people have given 10,000. So it's a huge response and good response. So I think we can take this office from.
Now, who want to voluntarily give, please give it.
So by 2026 in the annual conference, I was just discussing with Lakshmi sir this time, President and Secretary of APSI is coming. We should inaugurate our office, but unfortunately we are not able to do just a little bit of work left. Definitely 2026 in annual conference. Definitely we are going to inaugurate this one. This is from my side.
Thank you.
I think because the things are in the good year, I think we will get it.
A very important thing everybody should know in the GB, that as per the room, we are getting the room in the IMA house. They are charging about 6 to 7 lakhs as GST. I think that part we are taking care and we see that many of us are IMA members. So we are making it with the advocates and getting it waived out. So that part I think everybody should know. I have already circulated in our Executive Council WhatsApp, but for knowledge of everybody, that was being charged for us, but that is being waived out. So I think the Secretary and President are good enough to tackle that, how to waive that GST. Thank you very much.
Fourth agenda.
Next is, one is about the honorary membership for all associations.
Honorary member.
We are discussing about the workshop. See, you would like to sponsor a workshop. Okay? So we'll bring with the faculties, transportation part. Only local hospitality you all have to manage. Tell us the topic.
Thank you very much.
2 or 3 faculty we can bring. We shall manage about their, airfare and transportation.
Thank you, sir.
Okay, tell us the date in 3-4 months in advance and we will organize. Tell also the place. Topic. That faculty I will organize.
Then honorary member.
The one honorary member for our association. It was a question, it was asked by many members. So what we go through this honorary member, it can be happen. It is in our bylaw. The thing is that I think we have discussed in the EC meeting and we have decided that we can take it. So their provision is there. We can take honorary member, but they cannot vote or they cannot be, but they will be remaining in all our conferences, everything like that one. But some esteemed members of our association, they will propose so that honorary member certificate can be given in the in our state annual conference.
Now only one thing is, he must be a renowned person in our association.
It is there also.
National.
There it is there.
And secondly, he must be acceptable to all our members. I am not telling by writing, but by acceptance. Secondly, he should be actively participating in our events. That was the clauses, and if somebody is satisfied with that, I think he can
I
be
think
entered
the
to
past
as
honorary member, Dr. Rajat Gupta has told 2 times, and I think he has also told last IFs or before IFs. So if now GB is agreed, we can take him as a past honorary member of our association. If everybody is agreed. I don't know because it is there. We have discussed in the EC, this is case convey. And he has also coming every frequently and he has told that. So if GB is agreed, we will take him as an honorary member, first honorary member of our Aprasocon.
Yes.
Great.
So everybody said, put your hands, that makes a difference. Yes.
So write it down and proposer you can write one of two of our.
Jayant proposed and seconded by Sunil.
Write the proposer and second.
Then?
This is about this and now any other.
Website actually very important. We are facing a lot of problem for the website. Up to date of this website is very essential. Last time when I asked to our previous secretary Ashish regarding the website, actually when Santosh was preparing for this souvenir, so he doesn't know about Dr. Mahesh Mandal, whether he is the assistant professor or associate professor. I want to tell the every 6 monthly the website should be up to date, and he has actually he has some agent he is having the for the website. He is looking for this website, our website, and he is demanding for the space of around 20 to 30,000 for the space. If GB will allow, then we can contact that for the space of the. I don't know for 1 year or it will continue for 5 months, 5 years.
I think Dr. Patnaik, Ashish has taken the responsibility about the website, its functioning, its maintenance. All that,
And up to date of this.
Now I request everybody, please open your mobile, log on. Please open your mobile. And please open your mobile, go to Google. Sir, put www.apraso.com. You will find that there our conference, Aprasocon 2025 registration is already there. Next, previous photographs, some previous photographs is also there. www.apraso.com.
It's true that
Please
now you have started Ashish.
Please
But when I was planning to prepare a video for this last 10 years program. I requested several times to Sir Arun sir and you also for the photograph. If all the photographs, this year photograph, if I will up to date.
Sir, I'm telling, let I finish it. So, sir, yes. Sir, please show others, sir.
Everybody is willing. The thing is that it's coming, whatever President sir is telling, he is telling that the website has to be more
updated.
He wanted the website to be updated. So it's all right, whatever you have done a marvelous job.
Thank you.
Yes, Ashish.
Okay.
Sir,
Thank you.
No, President sir is telling it should be more vibrant, with more information, more photograph, and if possible, the association will provide one secretary to you.
Yes. All the members' number, please go. Sir, I'm telling. All the members till 1 to 106 is there. Please go through it. Please open it, sir.
It's okay, we believe you.
No, believe me. खोल के दिखाई दूँ.
We have already proved you, that's why we don't have to.
Continue.
Then one official member whom we will give minimum 5,000 or 6,000 rupees per year, so he can maintain all these things, official things and all those things. So it will be easy for all these.
I think once our official association room is made, all these things can be stored there.
Next is.
Yes, sir. And another is videographs. What Lakshmi sir is told to me, video can be uploaded and all the videos can be there. It needs some space. That's why we need some money.
Yes, anyway.
So I think we can go further.
Now I will tell that some of our members have finished their tenures. First of all, I am thankful to our executive committee members, Unmesh and Rasmi,
and Prasad. They have done excellently very good job for last 2 years.
There must be at least applause for them.
Thank you for their completion of their executive member tenure. And then treasurer. And I think Satya has done a
Marvelous job.
He has 2 tenures finished. He has done an excellent job. And whatever is required at night, midnight, anytime, call me. Give me back on. I am not going to do. So
He
has
is to
done-
continue, may not be on chair, but
Yeah,
he will
I think he
continue
may
to
be there or he may help somebody who is going to be in. I am also finishing my tenure of 2 years. So these things has to be elected like vice president, treasurer, secretary, EC. So I would request Akhir sir to be election officer and just discuss who are the
Next Vice President
First is
from
Vice
your point.
election officer. So these are the, you just wind it up so that we will. Executive trustee has also finished their tenure. Sorry to, I just forgot. All 3. So that has to be also executive trustees 3 because second repeat, they can continue.
Regarding executive trustee, my wish is that 3 previous ones should continue. If anybody don't means agree or disagree, they can give the opinion.
Sir, ଆପଣ propose କରିବେ?
No, I am asking that one only. Yeah. Agrees.
Propose seconded.
Name is Dr. Baliyar Singh Senior Sir, Dr. Falguni Rai Sir and Dr. Arun Chaudhary Sir.
Propose the seconded ना लिखो. Propose by Vibhuti sir propose. Seconded by
Sunil.
Sunil Kumar Rao. लिखो.
Sunil.
Kumar Rao.
Then comes to the Vice President post. Is Dr. Binayak Bhai. He will be the next President.
Proposed. Sir, proposed.
Then comes to the Secretary. Giri is doing the good work. He will continue.
Raise your hand. Seconded. Dr. Girna seconded.
Unmesh.
Dee
Biswajit. Okay.
Proposed and seconded.
And treasurer, I propose Dr. Deves.
They proposed and seconded. हाँ लिखो लिखो.
And coming to the EC members, that is 3 posts is vacant.
I would request Lopa to be there.
Okay. Satya. And 3 EC member post is vacant. From ladies side, it's Lopamudra will be the choice, first choice.
Rasmi.
Lopamudra proposed by? Debesh seconded by K. Debesh proposed.
No, proposed by joint executive member.
Seconded. Lopamudra seconded. Debi Datta.
And Rashmi.
Rashmi Salan. Veda. No, Vishnu Pada Naik.
Vishnu has already done.
No, Veda Hava.
Let him. What, you are ready to?
Vedo, is he ready or not? Okay.
Seconded K. Rashmi was proposed. Vishnu I proposed. Rashmi seconded. Third post.
Third post, it should go to Samprit.
Proposed.
Say, okay. Samar search na? हाँ Sam.
Samo already है.
हाँ इसी member सरलानी
Samo
था.
तमे इसी ही थिला. है ना? सामना दे दियो तो. आओ सामना दे दियो.
ना बड़ा रही जाई छी. Okay.
अच्छा सामना तमे है ना नहीं सी. नहीं है नहीं सी. नहीं बेद सइलानी. थर्ड पोस्ट.
संप्रीत तो सर से नेक्स्ट कर दबो गण छी. सीनियर किए तांगा भीतर हाँ सीनियर अच्छी तो से श्यामा से
I am telling you, whoever be EC member be work. I have these 2 years, if I am going to secretary, I am not going to leave. Just listen. Yes. Because this time a lot of top decisions will be taken. Yes, yes. You cannot tell XCC. Nobody is there. Ornamental position. No ornamental. Accordingly you be. Otherwise I will remove from second. Are you ready? Because the law.
संप्रीत हो से बहुत बड़ा
नहीं देव तंबा समिति पे
अरे रोमा कहीं दियो रो काम करो दियो बस रेडी हो
नहीं लास्ट टाइम वी हैव प्रपोज्ड टू इंक्रीज आवर एक्सक्यूटिव मेंबर कोर्स
ठीक है
डोंट प्रपोज समथिंग व्हिच इज नॉट इन द no it has to be made by EC then only it is elected member do not make proposal election officer appoint
come to Vinayak sir, you can come to stand. Vinayak sir, secretary to be.
The elected members they can come to the front of the dais and I request Bolyar Singh sir and at least Falguni sir he can EC members and treasurer and secretary everybody come here. Editor. Sushant.
अच्छा वन पोस्ट सर गोटे अछि एडिटर सुशांत रिपीट कर
सुशांत काई
से रहइबो तार किछ इलेक्शन नै एथरा
सुशांत नाही
नेक्स्ट इज एडिटर पोस्ट सुशांत विल कंटिन्यू नाही ये जोरता तार गोटे टर्म सरी गलानी सर आपण कंटिन्यू करेबे ना नुवा का इलेक्ट करेबे
नहीं कंटिन्यू
हेल्प अस
हेलो
लोपा हम अच्छी पूरा हाँ से क्विज रे अच्छी बोली
मोना नले दे देले भी हम
एडिटर एडिटर एडिटर
Editor, let it Sushant continue. If he is not agree, then Satya. Okay.
Thank you, thank you, thank you, Akshay sir. Thank you, Akshay sir.
No, Sushant should continue. Okay. Sushant.
So esteemed members, I would be thanking all the members of the Apraso to make this Aprasocon a very successful one. I will be thanking our President APSI Subodh Singh sir and General Secretary Dr. Vijay Kumar sir to attend and make the and attended this function, and I will be also thanking our supporters and sponsors, and at the last I will be thanking Apollo Group becoming our supporter and Lakshmi sir, so that our function has become and willing it to be a great success. Thanking you. Long live Apraso.
There is some changes. Actually, instead of Sushant, the Samprit interested to be editor, and he will join here.
propose करना
Are tu Devesh propose?
Sir, sir, आप propose कौन तुम second कर दो उससे? Sir, आप propose कौन तुम second?
No, I propose that.
I am seconding it.
Hospital Bhubaneswar. Your presence adds immense value to our gathering, and we are truly grateful to have you with us, sir. A warm welcome to you, sir. And now moving forward, we are very privileged to have with us the guest of honor, Dr. Subodh Singh, sir, Director and Senior Consultant of GS Memorial Hospital, Varanasi, and President of AAPSI. Your leadership and dedication to advancing our specialty are exemplary. A heartfelt welcome to you, sir. Additionally, I extend a warm welcome to our another guest of honor, Professor Dr. Vijay Kumar, sir, a distinguished professor from KGMC, Lucknow. Sir, your academic contributions and expertise have been instrumental in shaping the future of our field. So no introduction is complete without acknowledging our organizing chairperson of Aprasocon 2025, Dr. Lakshmikantar Misra, sir. He is also the senior consultant at Apollo Hospital, Bhubaneswar. Sir, your guidance and relentless efforts have been the cornerstone of this conference. Now I would like to request Dr. Sanjay Giri, sir, Secretary of Aprasocon, and Dr. Satyabrata Raut, sir, Organizing Secretary, and Dr. Santosh Panigrahi, sir, Organizing Secretary of Aprasocon. Your contribution to the conference is truly commendable. I request all to join the podium. Now may I kindly request Sangeeta to felicitate our esteemed guest with a bouquet as a token of our appreciation and gratitude. Now may I request our Vice President, Dr. Ruchi Gupta ma'am, to join the podium. As we embark on this wonderful occasion, let us invoke the blessings of the divine and illuminate the path of knowledge, wisdom, and enlightenment. The lamp lighting ceremony holds a special significance and symbolizing the dispelling of darkness and the ushering in of hope and positivity. May I now humbly request our esteemed guest to kindly step forward and grace this moment by lighting the ceremonial lamp.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तु ते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठेत् गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
Now I would like to
शुभं
request our
कुरुत्वं
chief guest, Dr.
कल्याणम्
CEO,
आरोग्यं
DMS of Apollo Hospital,
धनसम्पदः
to address the gathering. Please, sir.
जनगणमन अधिनायक जय हे भारत मराठा
Guest on the dais, delegates of the dais, namaskar. When initially the conference was getting conceived along with Dr. Lakshmi and Dr. Santosh, they came across for a certain amount of support. So I was only wondering, when we give support, we always in corporate start looking at what exactly is the return. And truly today, when I had last 1 hour session with, or interaction I would say with Dr. Santosh, we were discussing on to build this up to a level where it gets recognized. Why I'm saying so? Because today, plastic surgery and reconstructive surgery or cosmetic surgery has got very limited recognition in private institutions especially. Where we look at the concept of burns ward, most of the hospital won't be having it. When I visit industrial units, since Odisha has dominance of industrial units, but I find that we don't have burns ward to tackle. So everything can't be ROI, but it's very important today when we are building an institution is to integrate practices, what can be generated from inside and what can be built depending on certain things outside. Why I think so is for a particular reason, because we are trying to build an institution at our end, and a lot of opportunity exists in the world today or in the country today. When you operate in the region where you are, as the experts, unless there is integration of practices with other clinicians, the real recognition of the specialty would be missing. And I definitely see, well, the kind of forum, Dr. Lakshmi, I would compliment. I was not aware that such a vast education forum is existing on plastic surgery or reconstructive surgery, where certain
not just few things, but entire topic of limb reconstruction, head and neck reconstruction, and everything is present. So it's more of a truly educative session. I think what today we need, because kind of challenges we deal in day-to-day practice when industrial burns or industrial accidents happen or road traffic accident happen or oncology cases are there, where right focus or right awareness is missing at the patient end. That's number one. Number two, the integrated practice among the clinician is truly missing. Why? Because in a state level when we operate, plastic surgery, dominant of patients in most of the hospitals are state scheme patients. And what is the need of the hour is to actually turn it in the other way around in building it on a robust model, whether whatever form it is available is only possible if right awareness is created. So this forum is absolutely right in place, but we are not aware what exactly we need to do in order to integrate the practice. So I think if we can expand this forum where involvement of administrators or people who are decision makers are also involved in forum like this, actually growth of plastic and reconstructive surgery would be much better. That's what my opinion is. But the way it is growing today, it's only visible in certain government hospitals, because government hospitals have got good fund, and Dr. Giri is already doing such a huge task or along with the support. But in private hospitals, it's totally missing. So I would recommend that whatever forum you have created and running, this being the 11th chapter, is wonderful to be a part of this forum. I feel truly honored and privileged to be part of this August gathering. But my suggestion and simple recommendation would be as a message that if we can take it to a level where hospitals start building it in a sense of reconstructive and plastic surgery, it would be a best outcome in which you can grow it more visibly. Thank you.
Sir, to give the address to the
Jai Jagannath, good evening. Welcome to the holy city Puri. Honorable Chief Guest Dr. Alok Srivastava, CEO and DMS of our hospital, Apollo Hospital, Bhubaneswar. Guest of honor, Dr. Sanjay Parasar, he is not there. And Dr. Subodh Singh, the President of APSI and also the Director of Hospital, GS Memorial Hospital, Varanasi. Then Dr. Vijay Kumar, he is the Secretary of APSI and Professor and Head of the Department of KGMC Lucknow. Distinguished guests, esteemed delegates, ladies and gentlemen. It is both a privilege and honor to stand before you today as we gather for the inaugural ceremony of Odisha Plastic Conference in the beautiful city of Puri. This is a moment not just for the field of plastic surgery, but the broader medical community, where innovation of the excellence convergence to shape the future of the health. Plastic surgery as a discipline has evolved significantly over the years. It is no longer just about the reconstructive procedures. It has expanded into the realms that enhances the lives, boosts the self-esteem, restore dignity to the individuals and affected by the trauma, congenital anomalies and various other conditions. The work we do in the field is not only the medical but deeply human. It is a work of art, healing and transformation. The theme of our conference, I told you that it's educate, improvise and evolve. That means it emphasizes both technological advancements, ethical considerations, which is timely and essential. Odisha which is rich cultural heritage, strong traditions of the healthcare, has long been at the forefront of the medical innovations and patient cares. Hosting this conference in Puri, a city known for its spiritual significance and resilience. And we have organized these functions in 2011 when our department has not started and we are in the infancy phase. Now it is a privilege and by the blessing of Jagannath, we have done this program in 2025 after almost 14 years of this program. Now, I can say now I can invite means Dr. Alok Srivastav, the CEO and DMS of our hospital. He always in the positive for us and inspires for the growth of the plastic surgery in our hospitals. He supported a lot for our growth. I remember in the year 2023, we have organized a workshop on maxillofacial surgery, and he was also invited as a chief guest, where he inspired me and Dr. Santosh, both of us, that you should do great activities, greater number of activities in our hospital, so that this plastic surgery fraternity in our hospital and also outside of this field will be recognized everywhere. He advises to the doctors to share the knowledge and difficulties in the procedures should be discussed in the seminar and conference and will get good solutions. We also expect more support from him in the future. Thank you, sir, for agreeing and attended as a chief guest in our conference in spite of your busy schedule. Dr. Subodh Singh, sir, he is our president of our Association of Plastic Surgeons of the India, and he is the director of GS Memorial Hospital, Varanasi. I know, sir, since last 2006, after my just completion of the MCS from Safdarjung Hospital, New Delhi. Immediately, I got an opportunity to work, Subodh, sir. I have joined as a consultant in esteemed hospitals, Varanasi. I have got opportunity to work Subodh, sir, for more than 6 months. I have learned a lot of techniques from cleft lip palate and the techniques from Subodh, sir, as his center is high volume center in the world. Due to some familial issues, I returned back to my own state, Odisha, in 2007. Now, coincidentally, Subodh, sir, is the president of APSI and I am the president of Apraso. Very nice coordination. It's a blessing from Lord Jagannath to Lord Vishwanath. It's Puri to Varanasi. Dr. Sanjay Parasar, sir, he is not here in the program, but yesterday his workshop was excellent and most of the juniors learned a lot of techniques from basic. He has explained from basic to advanced courses in the body contouring procedures. We missed him as he had some immigration issues in the airport, but he has supported a lot. Dr. Subodh Kumar, sir, is presently, he is the professor and head of department KGMC. He is also secretary of our association APSI. I know, sir, during my MCS preparation in the time 2001 to 2002, when I was attending the MCS examination in KGMC, Lucknow. He is always a student friendly and helps any difficulties you will call, he will rectify our problems. Even in odd hours, if you will call, he will immediately respond to the phone call and answer your solutions. Thank you, sir, for coming to our association and helps us to grow, how to grow in the future. Thank you again. Now, I also invite this NRO session, first time we have started it, non-resident Odisha, those plastic surgeons who are in the outside Odisha, they are agreed. Most of this, our plastic surgeons, like starting from Dr. Bhartendu sir, Dr. Amresh Baliyar Singh sir, Dr. Deepak Nanda, he was some fever, that's why he couldn't come, and we have Dr. KP Prushti, Dr. Satya Tripathi, Dr. Devi Mahapatra, Dr. J. Jamula Srinivas, Dr. Satyabrat Mahanti, all agreed, and they have come. When I called him, definitely we will come and attended this program and made it successful. And they have shared their knowledge today morning in the conference. Thank you to all for attending this conference. I would like to extend my deepest gratitude to the organizing committee, Dr. Santosh, Dr. Satyabrat, my secretary, Dr. Sanjay Giri, and all the sponsors, volunteers, and whose effort has made the conference possible. I also thank to all these doctors like PG students, surgeons, my friends, Sunil, Vibhuti Bhai, all seniors like Sudarshan Baliyar Singh, even in all my health condition, he has attended this program. Falguni sir, Arun sir, Subrat Jana sir, all attended this program and made it successful. Thank you for attending this conference. Last but not the least, I am truly owed to my family for the unconditional support and tolerating me every now. Then for all my success throughout this life, for giving me the freedom to concentrate on my work. And of course, to the Almighty God and my parents for everything. Today is the last day of my tenure. I am going to complete my presidencyship. My wife is also there. She was also tolerating when the association given me the opportunity that in 2000, I remember in 2023 that all the association members told that you will be the vice president. On that day, I have thought that what I will do for my functions in 25. Now, in the last 1 month, I was totally upset how to do. Even in the middle of the night, I thought how it will be fruitful. But by the blessing of the Lord Jagannath, everything is going smoothly, and perhaps tomorrow will be completed very successfully. Thank you, and I wish a fruitful and inspiring conference. Jai Hind, Jai Jagannath.
I'd like to request our organizing secretary, Dr. Santosh Panigrahi sir, to address the gathering.
Good evening, everyone. Without taking much of your time, I would like to welcome you all on behalf of the organizing committee of Aprasocon 2025. We have put our heart and soul into organizing this event, and I hope these 2 days of conference is something that you take away with a lot of fond memories and something to take away from it. So thanking you all. Welcome to Aprasocon 25. Thank you.
Thank you so much, sir. Now may I request Dr. Ruchi Gupta ma'am, Vice President, to say a few words to the gathering.
Welcome all. As Dr. Lakshmi said that he is completing his tenure, so I'll be taking the baton. I need the best wishes from all my seniors and the support from my juniors. And I know this conference, he has set a very high level to match, and that, as he said that for last month he has not been able to sleep comfortably. I can very well see I have another year not to sleep comfortably. So I again request for best wishes from everyone that I am able to carry out the responsibility comfortably. Thank you.
I request Dr. Sanjay Kumar Giri sir, Secretary of Apraso, to give the report.
Good evening, everyone. Respected esteemed members and the dignitaries, seniors, my dear colleagues. It is my honor to give the annual report of Apraso for consecutively third time. So, first of all, I am very much thankful to CEO Apollo for taking our gracious this occasion. Thank you, sir, for coming and giving your time. Then I am thankful to, it is our fortunate that we have made a customary for last 10 years that president of FC to present in all our Apraso. And it is maintaining, but first time in the Apraso we got president and secretary of FC. So thank you both of you, sir, for giving time and graciously occasioning this occasion. It is not easy to get both president and secretary of FC. And then I am thankful to both the organizing secretary who is there for working for last 15 days, and also thankful to vice president for being guiding what to do, what not to do me in many times. So in this way I am welcoming everyone for this annual report. And also I am seeing some of the senior members from East Zones, like Dr. Palin is there. Thank you, sir, for coming to attend that one. It's a very honorary thing that he has come to attend our annual conference from such a long distance. And thanks to all the NROs who has received the invitation from the idea behind Lakshmi sir to come, all the Odisha people who are working outside and show their works. Thanks for giving the time and attending this conference. So my report is like this because this 1 year it is so hectic and all the months were very active by the Apraso. If we start from the month of May, first March actually Dr. Sunil sir has completed his tenure and he has, our last time first the conference was done in March. It was a very beautiful conference done in the KIMS. Then after that by May we have done the bi-monthly meeting first time outside Twin City, that is in Berhampur, which is very beautifully done by Pothiraj sir in MKCG Medical College. And almost 30 to 40 people have gone in the severe hot it was. So that was the first bi-monthly meeting. Then we have in the June, there was a very good meeting of in SCV Medical College. We have the Dr. Biswajit Mishra has done our micro lab for the juniors, the micro to learn the micro things, and which was being held by the faculties like Mohammed Baliyar Singh sir, Nilesh Satbhai sir. They have come and trained many of our young persons how to do the micros. Then in the July, we have as usual, consecutively second time we have completed this IAPS course, which is well accredited by IAPS also. Even they have accredited this part one day, IAPS. So thanks to Dr. Jayant and team, and also the Apraso members are also involved. It has completed in the July. It was a 1 day whole full video workshop like that one. Then we also come to, on the November, we have done Aprasocon in AIIMS Bhubaneswar. First time it has been given to me, and 450 delegates, highest number of delegates has attended in the Aprasocon in the history of Aprasocon. That was conducted in AIIMS Bhubaneswar. And in December, bi-monthly meeting, Dr. Assis has done the bi-monthly meeting in SBM Medical College. So this way we have completed all the academic things. And if we go to the achievements, many of our esteemed members, they have been invited as a faculty. Dr. Sunil, Dr. Jayant, Dr. Vibhuti sir, Arun sir, everybody, all of the senior members, they have been asked outside for faculties and to give their experiences in different activities. Dr. Pothiraj sir has been invited for APSI PG CME, and Dr. Biswajit Mishra also is invited. Some of the academic activities he has mentioned here. And if we come to the residents, it was a beautiful year for us, because if you go to the achievements of our residents, they have gone to a little bit of high level. In the February, in Nabicon, our AIIMS resident, they have won the Nabicon second, they have won the quiz second, they have the best paper also in the Nabicon by the AIIMS group. That was the first achievement in the February. Then in the Aprasocon also, plastic waste, our resident, they have also won the best plastic waste team. As you know, it has been started. And also in the best paper category, MKCG resident Dr. Jyoti's paper has been selected, which is good for our residents. So we are getting a good number of papers in our national forum, which was the main motto while we start these academic activities. So in this way, we have almost completed our 1 year. And the best part is we are in the verge of getting our own office, Apraso's office, in just, I think by 2 months. We just missed it this year. And we will definitely going to get it by this 2 year. And we have also started the hand fellowship course. We are so much of difficult that whether we can start it or not, but by God's grace and by the team of the fellowship team, that is by Subrat sir is not there, Subrat sir, Arun sir, and they have given the good idea and we have started it and it has gone through well, and I think it will go. It will help definitely to all the residents. We are also in the plan of starting this aesthetic also aesthetic fellowship from next year onwards. So these two things we will go on from by, although we have whatever amount is there, we are trying to make it benefit to all the young residents. So these are some of the achievements we have done it, and the next thing which we are going to do, that is as we we have also increased our members from 102 to 113. Now Apraso has 113 members. When I was doing postgraduate, we were just starting the just 1, 2 like that, 1, 5, 7, how the members will go so that we can register the association just 10 years back. And in 10 years we have got 113 members. It's a great achievement for all the members and all the associations. 113 is a good number. And next our association has discussed many times, so as both president and secretary is there. So we have requested to them that we do not able to get executive members from East zones. So we are going to give we are going to give from association that executive members should be zone wise. It is again one of our request to make it in the EC meetings. Executive members, so throughout the zones it should be represented. In all the association it is there, and I think these things can be put up. Because if you see executive members, very less in East zones. Till now we have 3 executive members. So it is request from all the members of our Odisha association, even all East zones, that it should be made it zone wise, and you can increase it from 4 to 8 so that that can be done. I think this proposal President Secretary can take it. And about our association, the next 1 year, as you have decided, we are going to do lot of events, academic events in the coming year under the banners, under the presidency of Dr. Ruchi Madam. Ruchi Madam is very passionate about aesthetics. So definitely this year is going to be aesthetic year, I know. So, but anyway, we are going to starting with February with your live workshop of year. And thanks to Valiyar Singh sir, who was coordinated to make all the 3 faculty to come to one plane, because we have previously planned to do it in November, but again sir has coordinated because to get 3 faculty at one time, it is not easy. So they are going, and I requesting all the members of Apraso to attend that live workshop of year, which is going to be held in 6, 7, 8. And about our, this is all the reports of our association. Thank you, Lakshmi sir, for having a nice 1 year with you, and hope your guidance will make us this association more vibrant. Thank you all the members for giving me the opportunity to say a few words and to work for the association, and hope we will grow much better and we will do much more in the national platform. Thank you, Lord.
Thank you so much, President of APSI, to address the gathering.
Mr. President, Dr. Alok, Dr. Vijay, other dignitaries on the dais and in the August gathering here. So coming to Odisha has always been for me like a homecoming. Some of you may not know, but when I was doing my residency in general surgery, Dr. Ramesh Das was doing his MCH in Varanasi, and that is how I got introduced to plastic surgery. My boss was also in plastic surgery. Then I came to know that many senior Odisha plastic surgeons had their training from BHU. So that included Jagan Mohan Das, Dr. Jena, Dr. Chaudhary, and my immediate senior, Dr. Amresh Balyar Singh. He was like a guru for me because I learned maximum from him. And then a big number of other younger plastic surgeons also got trained to them. But besides them also, I know almost all the senior plastic surgeons of Odisha and most of the junior plastic surgeons from Odisha. And there is a warmth when I meet them, when I see them wherever in Odisha or outside. They meet me with a lot of warmth. So that is very special about the Odisha people. And I saw that in the different conferences that were held in Odisha, and even today, as a state chapter, and I was going through the entire the scientific program today, and I witnessed almost all the presentations today, and I have no hesitation in saying that they were all of the top level, the world class, and surgeons from Odisha, those who are working anywhere else outside Odisha, and also those who are working in Odisha, they are doing the work, the job, the quality of work is not less than anybody else in the country, and they are doing the top level work. So earlier, when I look back 30 years ago, the growth of plastic surgery was a bit slow in Odisha. But there has been a rapid increase in last 2 decades. And not only in number of plastic surgeons, but also in the quality of work that is being done in Odisha. It is no less than anywhere else. So I compliment all the surgeons of Odisha and all the members of the association, and I have my all the best wishes for the future. And also I noticed that I attended the general body partially. So looking at the general body, they said it will last 20 minutes. It lasted 1 hour and 20 minutes. So when the general body in an association is lasting more than 1 hour, I can safely say that the association has become mature now, because everybody is taking interest in the activities of the general body, of the association. And a lot of things that were being discussed were the academic programs for the throughout the year. So I can say, and I also know there are micro labs, micro training, there is a huge burn center. So every senior is involved in creating and curating the education program for the younger generation, and this is the best thing that can happen, because it is our responsibility to train our juniors, our students, much better than that we were trained, and that is being done all by all seniors and all teachers in Odisha. There is just one last point that I want to mention and bring your attention to that NMC advocates 3 months of outstation training. It is there in the plastic surgery curriculum. And the student should be sent out for 1 month, 2 months or 3 months at different places on a paid leave. And so that even if you are doing the best, they need to see how other people do it, the other aspects of it. And I know that no center does everything in a best possible way. And even if they do, the students must see other people doing it. So just for the reason that who will do the ward work, we do not have enough people, there is no exchange program. These should not be limiting the training of the MCH program, and I urge all of you, those who are in a training institution, to see to it that your students are best trained in the country, and wherever they go, they uplift the name of your institution and their mentors. Thank you so much.
Thank you so much, sir, for your encouraging and motivating words. Now may I request Professor Dr. Vijay Kumar, sir, Secretary of APSI, to address the gathering.
Aprasocon 2025 के इनॉग्रेशन के चीफ गेस्ट आलोक श्रीवास्तव जी, सीओई अपोलो, एपीएसआई प्रेसिडेंट डॉक्टर सुबोध कुमार सिंह, एप्रासो प्रेसिडेंट डॉक्टर लक्ष्मीकांत, डॉक्टर संतोष, डॉक्टर सदब्रत, डॉक्टर रुचि जी, डॉक्टर संजय, ऑफ द स्टेज डॉक्टर सुदर्शन बलियार सिंह सर, फाल्गुनी रे सर, अरुण चौधरी साहब, डॉक्टर पालिन, डॉक्टर अमरीश बलियार सिंह, डॉक्टर सुनील राउत, डॉक्टर विभूति भूषण जी, अन्य प्लास्टिक सर्जन्स एवं नेक्स्ट भविष्य के प्लास्टिक सर्जन, रेजिडेंट्स एंड लेडीज एंड जेंटलमैन, ये मेरे सौभाग्य का विषय है कि मैं आज यहाँ पे एज ए गेस्ट ऑफ ऑनर सेक्रेटरी की हैसियत से आया हूँ। मेरा सेक्रेटरीशिप 2019 में शुरू हुआ था डॉक्टर अमरीश बलियार सिंह की प्रेसिडेंटशिप में, जिसकी शुरुआत भी पुरी और भुवनेश्वर से ही हुई थी। सर आपके साथ ही मैं फर्स्ट ईयर कर रहा था, और दिस विल बी माई लास्ट ईयर ऑफ सेक्रेटरीशिप. आई विल बी फिनिशिंग इन 2025. सो अगेन आई एम इन द पुरी. So this will help. The Lord Jagannath will be blessing me for next future endeavor, I think so. जो स्तर आज मैंने यहाँ का देखा, इस एप्रोस्कॉन का, जो जैसे डॉक्टर सुबोध सिंह ने भी बताया कि जो टॉपिक्स जो रखे गए, जो जिन्होंने व्याख्यान दिए, वो इस प्रकार थे कि प्लास्टिक सर्जरी की वाइड वैरायटी जो है, रेंज ऑफ प्लास्टिक सर्जरी में क्लेफ्ट का काम भी था, बर्न्स भी थे, हैंड भी था, एस्थेटिक भी था, हाइपरबैरिक भी मैंने बोला, कैंसर सर्जरी पे भी बोला गया, कैंसर सर्जरी का जो रिकंस्ट्रक्शन एस्थेटिकली होना है वो भी बोला गया। तो जिस चैप्टर के एनुअल कॉन्फ्रेंस में, व्याख्यान में इस प्रकार के विषय हर व्यक्ति में पूरा किया, तो मैं आज दावे से कह सकता हूं, दिस हैज बीन अ मोस्ट वाइब्रेंट चैप्टर ऑफ द इंडिया एपीएसआई। जब मैं प्रेसिडेंसी कर रहा था 1997 से 1999 में, सो हमारे पास उस समय डॉक्टर एनसी नंदा सर, फाल्गुनी रे सर, सुदर्शन बलियार सिंह, अरुण चौधरी सर, ये 4 या 5 ही नाम थे। और जब मैं MCH में 97 में घुसा था तो उसी समय डॉक्टर रमेश चंद्रा सर ने APSI की कॉन्फ्रेंस कराई थी। एज ए रेजिडेंट वॉलंटियर आई वॉज देयर एंड ओनली 4 or 5 नेम्स फ्रॉम उड़ीसा वर देयर। उसका ट्रेनिंग देखते देखते डॉक्टर लक्ष्मीकांत मिले, डॉक्टर नंदा, दीपक नंदा वॉज माई बैचमेट, ही वॉज फ्रॉम उड़ीसा कटक। देखते देखते फिर धीरे धीरे विभूति भूषण सर से मिले, सुनील राउत जी मिले, लक्ष्मीकांत तो सफदरजंग में थे तो अक्सर हम लोग कॉन्फ्रेंसेस में साथ रहे। देवी प्रसाद वॉज माई स्टूडेंट, आई वॉज हिज थीसिस गाइड एट KGMU। डॉक्टर सत्या AMU से कर रहे थे, तो वी गॉट इंटरेक्शन विद योर फ्रेंड्स, सो आई बिकम फ्रेंड्स। नाउ आई कम टू द संजय गिरीज टॉक, जो उन्होंने कहा कि हम एग्जीक्यूटिव मेंबर नहीं बन पा रहे हैं। आप देखिए कि आपने अभी 113 मेंबर्स बताए, हमारे कितने उड़ीसा के मेंबर्स आर APSI मेंबर्स? ओनली मुझे लगता है 50-60 से ज़्यादा नहीं होंगे। सो वी आर लूजिंग 65 वोट्स। 1, आपके चैप्टर चाहे डॉक्टर सुनील राउत हों, चाहे आशीष पटनायक जी हों, चाहे अरुण चौधरी सर हों, जिसने भी मुझे APSI में पिछले 6 साल में मुझे लेटर दिया है, मैंने उस लेटर को प्राथमिकता से एग्जीक्यूटिव में और GB में लड़ झगड़ के रखा है और लड़ा है, और मैं लड़ता रहूँगा इस साल पूरे। और मैं डॉक्टर सुबोध सर से कहता हूं कि जो उड़ीसा चैप्टर की जो मांग है जोन वाइज करने की, आपकी रेजिडेंसी में नहीं होगी तो सर कब होगी? यही भाई उड़ीसा ईस्ट जोन, लेकिन मांग यहीं से उठ रही है। बीज जो उस मांग का जो बीज की उत्पत्ति है वो उड़ीसा से आ रही है। तो उस मांग की पूरी करने की जिम्मेदारी अब एसोसिएशन की है। पिछली बार लगभग हम इसको निकाल ले गए थे, लास्ट मोमेंट पे वी आर नॉट, बट हाँ डॉक्टर संजय गिरी जी, इस बार आप सक्सेस होने चाहिए, क्योंकि इस बार हमने एक चीज़ आपकी मानी है, करवाई है लड़ झगड़ के। GB में डॉक्टर अरुण चौधरी सर का भी साथ दिया, उन्होंने लास्ट में खड़े होकर बोला था GB में, याद करिए, कि एक आदमी एक वोट नहीं देगा। वो हमारे साथ छल होता था, एक वोट देते थे, हमारे 3 वोट्स नहीं पड़ते थे। अब जब चौथा वोट, तीसरा वोट देगा तो संजय को, और सत्या को नहीं देगा तो किसको देगा? जस्ट यार मार्जिन पे जाके रह रहे हैं। तो ये मांग आपकी पूरी हुई है, और जो जोन वाइज मांग है वो भी पूरी होगी। मेरा साथ, मैं अब सेक्रेटरीशिप खत्म होगी, मैं आगे और पद पे हो सकता हूँ, या एज ए प्लास्टिक सर्जन मैं आपके साथ हमेशा उड़ीसा चैप्टर के साथ रहूँगा। एज ए हेड प्लास्टिक सर्जरी हूँ या जहाँ भी रहूँगा तो मैं आपके साथ हमेशा हूँ, मेरा साथ हमेशा आपके साथ रहेगा। और आप जो मांग उठाएंगे इस साल, वो पूरी मांग फिर मैं प्राथमिकता से, प्रमुखता से, और इस बार तो प्रेसिडेंट भी अपने हैं साथ हैं, तो उसको हम कर पाएंगे सर। क्योंकि प्रेसिडेंट जो होता है, जो इंजन होता है, उसकी बोगी जो पीछे एग्जीक्यूटिव मेंबर्स होते हैं ज़्यादातर उसी से चलते हैं, पीछे नहीं जा सकते, जहाँ इंजन जाएगा बोगियाँ वहीं जाएंगी। तो एग्जीक्यूटिव भी ज़्यादातर वही डिसीजन लेगी। आशीष जी, आपकी मांग भी पूरी होगी। यू हैव केप्ट जोनल वाइज, तो आई हैव ट्राइड माई बेस्ट। आप लोग में से नहीं थे, मैं बहुत लड़ा एग्जीक्यूटिव में, बट एक्चुअली में they were not ready to allow me to put in the GB, but I forcefully put in the GB as a secretary. और मैं वादा करता हूँ मैं करूँगा, और hopefully we will succeed। और इन सभी बातों से कभी भी जरूरत मेरी पड़े, मैं हूँ। इन्हीं बातों से मैं अपनी वाणी को विराम देता हूँ। धन्यवाद। जय हिंद, जय भारत।
I just have to say one more sentence about the topic that Vijay raised and your demand also. I want Ruchi to give this responsibility with all your team members to make as many APSI members in the East Zone as possible. Talk to every plastic surgeon individually and try to do it before the EC meeting, which will be held in the end of the March. As Dr. Vijay said, we tried in the last EC and general body meeting, and I was there. So we succeeded in some of the thing, but could not succeed in this. And if you come in big numbers, this will help all of us. Thank you.
का जो इशू है दैट इज़ वेरी इंपॉर्टेंट, और मैं जो हेड्स हैं, जो हमारे उड़ीसा के या जो भी हेड्स हैं, उनसे रिक्वेस्ट करता हूं, जो कि हमने प्लास्टिक सर्जरी में हमारे डॉक्टर एस के भटनागर से हमने सीखा था, Dr. S.K. Bhatnagar used to make us member in first year. और आजकल after becoming secretary, I have made, there was a difference between fees of associate life member and full life. I have succeeded in getting the both fees at same level. So if one becomes an associate life member, as soon as he passes, he has to send the degree and his membership will be converted into the full life. So जो बीच का 560 रुपए का गैप था वो खत्म करा दिया. 560 रुपए ना जमा करने की, जानबूझ के नहीं जमा करता, मालूम नहीं होता था, तो उसकी मेंबरशिप फुल लाइफ नहीं होता थी. ही वॉज नॉट हैविंग द वोटर राइट्स. तो वो हमने खत्म कर दिया. मेंबरशिप फीस इज सेम. सो एज सुन एज पास, सेंड टू द सेक्रेटरी, सेक्रेटरी विल पुट इन द जीबी कि ये पास हो गए, कन्वर्ट कर दीजिए, मेंबरशिप बन जाएगी. इसलिए ऑल द हेड्स, ऑल द फैकल्टी, नॉट ओनली हेड्स, ऑल द फैकल्टी की जिम्मेदारी है कि फर्स्ट ईयर में ही आते ही उसको मेंबर बनवा दे एसोसिएट लाइफ, ताकि वो कन्वर्ट हो पाए, ताकि हमारी जो रुकावट आ रही है, संजय गिरी भाई साहब और सुनील जी नहीं पहुंच पा रहे हैं, तो उसकी रुकावट, या सत्या नहीं पहुंच पा रहे हमारे, तो उसकी रुकावट बंद हो, खत्म हो और हम लोग सक्सीड हो. धन्यवाद.
Experience and encouraging us. Now may I request Dr. Sanjay Kumar Giri sir to proceed for the felicitation.
Every year it is our tradition to felicitate some of our senior members. So this time it is I am very much privileged to felicitate. This time will be Professor Arun Chaudhary sir, who is our founder member of Apraso. He will be felicited. So it's a great honor for our association to felicitate in the Lord Jagannath. So I am just going to felicitate, read the felicitation here. So on behalf of the Executive Council members and honorable members of the association, So on behalf of the Executive Council members and honorable members of the Association of Plastic Reconstructive and Aesthetic Surgeons of Odisha, express our deepest gratitude for the profound impact you had on your association and esteemed members. Born on 16th June 1954 at Cuttack town, you completed your schooling in Revensa Collegiate and Revensa College at Cuttack. You completed your MBBS from Bhimsar and MKCC Medical College in 1977, PG Diploma at IPGMR at SSKM Hospital, Kolkata in 1982, postgraduate degree in 1984 from SCB Medical College, MCH in Plastic Surgery from IMS BHU in 1988, joined in the OMHS in 1985, OMS as faculty for 35 years in teaching as professor and HOD in the plastic surgery. You started in the first MCH course in plastic surgery at SCB Medical College, Cuttack in 2006, first burn center in 2009 and ICU in 2022. You have guided 30 MCH students who are now placed in prestigious institutions of the country. You have been academically interested in presenting more than 100 scientific papers in last 3 decades, more than 30 publications in national and international journals, including acid burns in apps in 2024. Your passion to be advisor, Students Union, Chairman, Council of Wardens, Member, MCI, State Nodal Officer for Trauma and Burns. The mass burn tragedy of spiritually congregation at Varipada in 1997, you as a HOD has managed to make your discipline proud. You have been bestowed Mahatma Gandhi Award by His Excellency Governor and Honorable Chief Minister of Odisha, awarded Mr. Phulan Devi Gupta, APSWB, late Professor Dr. R.N. South Trophy on Academic Council, SV Medical College, first to devise the upper limb computerized myoelectric prosthesis in the country. You became the founder president at APRAS of 2014, ex-co-member of AFC 2016, President NABI 2016, President-elect EASAPS 2024. You have a hobby of playing basketball, cricketball, tennis and TV programs. Through your leadership, you have not enhanced our learning environment but also paved the way for many more. Your kindness and support created a nurturing environment where we felt valued and motivated to excel. We are extremely grateful to you for leaving behind a legacy of excellence, innovation and inspiration. As you embark on new chapter of life, we pray God for your good health, happiness and success in the future. Sir, the Executive Council members and esteemed member of APRASO consider it a great opportunity to felicitate you on this occasion of 11th Annual Conference of APRASO 2025 in Lord Jagannath Dham, Puri.
But at the outset, I must thank all my esteemed members of Aprasocon because they are the ground level people who does the work. And on the dais, today is moderated by the President of Aprasocon, Dr. Lakshmikanta Mishra from Apollo Hospital, and the chief guest is Dr. Alok Srivastava. I am really overwhelmed that at least a doctor been heading an institution like Apollo, and a lot of professional things he must be dealing with. So he is being the chief guest is our privilege, and I am also feeling very much proud of it. And we have our President APSI, whom we have made it right from the beginning, first meeting, that the President of the APSI, Association of Plastic Surgeons of India, should be one of the guests, chief guest, or Dr. Bajaj was the first guest in 2014. He was the heading department of Subsurgeon. Then next was Malati Gupta from Mumbai TMH. So likewise, I am very much grateful to the committee, organizing committee, that they have maintained that. And I am General Secretary Dr. Vijay Kumar. He is very close to my heart. And अभी वो इतना बढ़िया भाषण दिए तो हम सोच रहे हैं कि हम क्यों थोड़ा हिंदी नहीं बोल सकेंगे. तो हिंदी में जो मज़ा है, जो मिठास है, वो तो दूसरे में इंग्लिश में नहीं मिलता है. तो मदर टंग इज ऑलवेज मदर टंग, है ना. तो इंडिया का लैंग्वेज जो अभी प्रवासी भारत दिवस हुआ ना, तो ये प्रवासी भारत दिवस में आप तो बहुत कुछ सुने होंगे, प्राइम मिनिस्टर, प्रेसिडेंट, सबसे. तो they have talked so much about Orissa. I didn't have to speak about Orissa, in fact. That is a good thing. Then the secretary, Dr. Sanjay Giri, who was one of my students, and not only he is an all-rounder. I don't know, I was like Dhoni, or I was the opening batsman of doing something of the association. But he has always been a good player, like Tendulkar, or maybe somebody else, like young generations people, because I don't want to make him old. And treasurer Dr. Satya Rautrai was one of my students. So I am not going to talk about my students who have passed over 30, and out of which 4 are in the AIMS as HODs or as senior faculties. So these are the credits. I don't know, with 40 years of my journey in this profession in the state, it not be possible to speak out everything. But about me, really I am pleased that some of my, from my birth up to now, something has been already expressed by the executive committee and also the esteemed members of the association. So thank you very much for that. And in fact, if I go back to my journey of my professional and personal career, in 1967, the Department of Plastic Surgery started in Orissa in SCB Medical College. Professor N.C. Nanda, then the department was a small unit. Then when I came out in 92 to Cuttack, I found something new has to be made out. When I was a small kid, my father used to tell, अरे यार कुछ भी तो बनो, जो भी बनो पहला बनो, फर्स्ट बनो. आपको अगर आप भी शराबी बनते चाहते हो तो नंबर 1 शराबी बनो, गैम्बलिंग करने चाहते हो तो 1 नंबर गैम्बल के सब बोले भाई भाई देखो कितना बढ़िया आदमी है, कितना फर्स्ट हो रहा है, क्रिकेट खेलना है या प्रोफेशन करना है। तो बोलने का मतलब है कि आप कुछ भी करो मगर फर्स्ट बनो। That was my father's talk in my childhood, I remember still. And you have known what I have got on that. And you know, who plants a seed, he should not take the credit. When I planted the seed of starting a MCH course coming from Banaras, when I was doing my in early 80s in Banaras, we used to see from the 5th floor was our floor. When Dr. Pandey, who got the Padma Shri for doing the highest number of kidney transplant in India, I think most people know him. From that, Dr. B.N.P. Tripathi was there. Dr. J.K. Sinha was my professor, and Dr. F.M. Tripathi and Dr. B. Bhattacharya. We used to see that Sankat Mochan. Whenever we feel little nervous, we have to see Sankat Mochan. And in the evening, when you get all the bombardments from the bosses and all the patients, we used to go to the Lanka and then go to the Blasi and go to Vishwanath to show that, sir, please bless us. So the Banaras experiences cannot be taken away from your mind. I think that was the best period of my career as a professional person. And then when the MCH course started in 2006, out of 12 departments in SCB, it is the only plastic surgery in SCB who started with the course in the first time. So maybe God's grace, Jagannath, and I was a MCI member, so maybe I have fed properly all the documents and everything what was needed that time, or the department. So we had a good burn unit to start with, and we had the only ICU in the whole Eastern India in SCB, till now dedicated ICU for only burns. So as the CEO, as Dr. Srivastava was talking about, you see, plastic surgery do not remain up to only a reconstruction of a particular part. It is not an organ surgery like other departments. It starts from the hair up to the toes. So a lot of things, I think in every department, discipline, institutions, teaching or hospital or corporate setups, plastic surgeons should be given importance. The reason being, it is a PWD, PhD and electrical department. So everywhere you do to have a repair. So any repair of these things of any kind, it is very difficult to speak out all details about plastic surgery. I am not going to promote, in fact, everybody knows. But what Dr. Srivastava has told rightly, that plastic surgery should take a lead. And what we are lacking in our association is we want more young leaders. So taking a leadership is something different. What I mentioned previously about Mr. Dhoni. From Eastern India, there was no captain in the cricket, and he became one of the successful captain. And Mr. Ganguly was there, but he was the most successful and got the World Cup. I mean to say, everybody is potentially competent enough and has the capacity to make out, but you have to explore yourself and start doing. So with this, I told you, I hope, and the awards and everything, that was all encouragements. I remember in scooter with my Professor HOD, Professor Baliyar Singh is there, his friend Dr. Vijay Lakshmi Naik, who used to run 3 to 4 days a week to the government to pursue what is plastic surgery, not a cosmetics. We need to have a burn unit. Then suddenly in 97 we had the burn in Baripada, which are really eye-opener for the government of Orissa. Then I became nodal officer for burns and also trauma. So trauma is a big subject for everybody, and Orissa is number 3 in trauma as per the number of mortality and morbidity in trauma is concerned. So the government of India is very much sensitive about Orissa, and 2 times the Supreme Court has also called for physical appearance of the government officials. So I was also heading one of the health department in that. So with why I am telling all this, because all these years, my missus is there, Professor Dr. Pratima Sahu, she is heading the Biochemistry and Molecular Biology Department of SC Medical College, Cuttack. She always speaks, you remain about 18 hours, 20 hours in the department. 24 into 7, 365 days. Why you come to house? Better you stay there, have a good room, and stay there in the department. Because that means what I mean to convey is, you have to make a balanced life of your profession and family. That is, but she has supported a lot
in that situations. And Dr. Singh was very much there with me about 8 to 10 years. So Dr. Vibhuti Naik now heading the department. So they have all seen my activities. Sometimes they get irritated, sir, why you are getting so much serious? And from day, night, every time you are here available and the students are not able to go away. But I think sometime when you plant a seed and when you see the tree is growing, every day you want to give some fertilizer, some water. Otherwise that tree will not grow. And now the tree has grown up, the fruits have come. Now the second generation or third generation is going to be ready to again plant the seeds to get new trees. So these are my experiences of my life. And regarding academic, rightly told, we started some protocols for the association. I am very happy that it is still going, like bi-monthly meeting from 2011 till date, on record, we have been doing. So this is a big boost to the young surgeons to learn the newer conception in the surgery, in the subject, and to also attend all the national and international conference. It is not an astonishing thing. When I told in the national conference last that they didn't believe, from 87 till date, I have never missed any national or international conferences. For that I must have spent more, today's currency maybe more than 10 crores. So why I am telling you, presenting papers, and I never gone to any conference without a presentation. The reason is not the personal. Reason is whatever your experience may be very small, you have to share it with others. Because you may not be there always, but your knowledge and experience, if you share, others will carry on and they will improve in the rest of their lives and they will also do the same thing. So it is just to make something different from others. I started with, as Dr. Vijay Kumar told, we got 4 or 5 names. So when I go to outside, सब बोलते हैं अरे अरुण कुमार जी हम जानते हैं आपको. So unless you make such gatherings and have your exchange of ideas and share your experiences, whatever may be, otherwise you cannot get to the name. What you told, why Eastern Zone? Now I have been elected as the president of the Eastern Zone, which you are going to have the first conference maybe next year in Odisha or somewhere in the Eastern Zone. So Eastern Zone means constitute 12 states, highest state in the country. So zonal means we are involving the Calcutta, the Chhattisgarh, the Jharkhand, Bihar, Manipur, Mizoram, Sikkim, Meghalaya, Tripura, all these states are involved. So you see, we are going to have a good academic body and we will be exchange of ideas and future course we will have different. So our representation in last 30 years, there had not been a national conference in Eastern India. I am not talking. Dr. Baliar Singh did it in Bhubaneswar. That is a destination conference, like destination marriages, no? He made it from Mumbai to here. But there have been no conference in 30 years. Last conference was in 98 by Dr. Siti Rai Chaudhary. I am not giving histories because why history is given? Just to improve how to do it in the future. So the awards given by our honorable chief guest, Dr. Alok Srivastav, will be remembered for the rest of my life. I have been working about 4 decades in a government system in Cuttack, Berhampur and all that, being involved with so many administrative work also, as I have told the principal, superintendent charges, chairman, so and so. So this is an occasion. Apollo, I have something soft corner, I am telling you just as one incident. Whenever the Apollo hospital started, first day I remember in 2011, when the P.C. Reddy and Dr. Vijay Misra, myself, Pratap Ratha, they were sitting in one table, we were discussing what is the future of Apollo hospital. And Dr. P.C. Reddy never takes any cold drinks. So he was taking green coconut water. That is his favorite. So green coconut water came and he took, and his daughter was there also. So the discussion was, the Apollo hospital, what will happen after 10 years, after 20 years. So why I am telling you, any institution, the foresight and the planning should be made for like the decades after, 1 decade, 2nd decade, 3rd decade, like that. So now Apollo has grown up to a very big stature and it has its own brand names. So it is nothing
It is not a corporate, I don't have much experience to talk about corporate setups, but I know that different varieties, status of people will be there. But what more important is, as a doctor, as a plastic surgeon, or as an institution, you should develop a brand name. As I have been told in AIMS Bhubaneswar, that is getting some brand name as per the plastic surgery burns are managed. And one thing, the money which was given, was Dr. Srivastava was talking, is given by National Thermal Corporation. So it is not just government pays money for anything. Even in corporates, I know in Tata Memorial Hospital there is a ward in the name of Nargis Dutt. When Nargis Dutt suffered from carcinoma, so she donated money, Sunil Dutt, and that was made. So in any hospital in the state, you can have words in the name. There are a lot of people to donate for that. So it is matter of, again, leadership, planning and management. And my friend, good friend, Dr. Jaina is there. He has also shown the path to young plastic surgeons. Dr. Bibhuti Naik is also there. That yes, there is a scope for making private setups individually, taking loans, money, problems, still you can grow. And what is today, I am telling you, if you plant a seed, you will get the fruit, but it takes its own time. You should have patience, perseverance, dedication, passion. And the most important is your passion. If you don't have passion for something, I don't think you can grow. So most of the young surgeons I am talking, this meeting is not just for, it is a meeting for exchanging our professional ideas and personal experience and ideas. So I am at the last, not the least, I am all grateful to all the members that since 2014 I have been president for 2 times. Now I am executive trustee, I don't know. Today I am really feeling little old because you have given me so many hours. Because I was giving hours together for so many, 1 decade at least. So now first time I am taking so much of hours. But obviously I feel very much encouraged, and that too in front of my better half. That is also another opportunity. Because they have never been acknowledged that much, because unless there is a lady behind you and who takes all the sacrifices she takes, you cannot grow. So with that note, Jai Jagannath, Jai Utkala Janani, Jai Hind.
Madam, please come. Felicitate here. So, Professor Chaudhary sir being the founder president, I will request APSI president to felicitate also. We have made some orations like that one actually started from last year. So, all the past presidents we are giving these from our association so that it will be remembered for them. Then, then our next past president who is being, that is Akshay Raut, Dr. Akshay Raut, he is there from 2015 to 16. So I will ask Akshay Raut sir to come, and our APSI president and secretary to, and also the speakers to come. Vibhuti Bhushan Naik. Vibhuti Bhushan Naik. Professor Vibhuti Bhushan Naik, 2016-17. Professor Dr. Subrat Jenna, President Apraso 2017-18. Professor Dr. Falguni Rai, sir. Falguni sir, receive करेंगे. कागज कौन? इसी ना ऊपर. रमेश दास. Professor Dr. Ramesh.
Actually, now we are going to our beloved late Professor Dr. Ananda Prasad Patnaik sir, and he has already passed away. Now I request Dr. Sam Sundar to receive and give him. Dr. Sam. Sam ne
Ashish, you can receive, no? Ashish, you can receive, and because sir, our beloved sir, everybody knows that he has passed away, but he has a lot of contribution to our association, and I think Ashish can give. As you know, बाकी तो already हो गया है. राजेंद्र सर को कर दीजिए. As you know, we have started felicitating those, last appreciating some of our members who do their contributions. So I will go name one by one. Puthiraj sir, who has done marvelously the bi-monthly meeting in the month of May. Puthiraj sir. Then Biswajit Misra, please come to the, please. Biswajit, he has done the micro lab there. Then Jan sir, Jan bhai, you have done that IF course.
Dr. Sanjay Kumar Giri. And last one is myself, Dr. Ashish Patnaik, who has done a bi-monthly meeting successfully in December 2024.
We are felicitating some of our residents who are presenting the in national podium presentation. Some from Barampur, M. Sivaram Krishnan in Aprasocon. He has presented his paper. Dr. Jyoti from Barampur, is he there?
Dr. Sivaram Krishnan.
Dr. Gayatri Mahali from SCV. Dr. Surya Malik from SCV Medical College. They have all presented their podium in Aprasocon. Then I'll come one by one. Surya SSC from AIMS Bhubaneswar. He has presented his paper in Aprasocon podium presentation. Then Priyanka, he has her presentation in Navicon 2024 as a second Navicon Plastic Waste, also quiz ON, second prize. So Dr. Gopika and for jaldi. Gopika for her presentation and being the plastic waste champion. Jyoti can be taken by Puthiraj sir. Then Akanksha for getting the fellowship in Ganga Hospital, microvascular. Then Ahana being presentation in Aprasocon, best paper in Navicon, plastic waste champion, second Navicon KVCC, second in Navicon plastic waste. She has undergone all these things in this last year. Thank you. Souvenir.
Now, time for the release of our souvenir, Aprasocon 2025. Now I request our chief guest to release the souvenir. All members are requested to receive their copy from the registration site from tomorrow morning onwards.
Of our residents, some of our delegates who has come from Dr. Palin, please take the moment of appreciation. Dr. Palin,
Professor Palin sir, he has passed from MCH from PGI Chandigarh, and interesting to show that he is a owner of a private medical college and he has a own 400-bedded hospital in the northeast. And he is the one of the richest plastic surgeons in India.
Take the felicited by our FC President, Chief Guest. Sir, sir, okay, okay, okay. Srinivas. Right, exactly. Satya bhai. Ekasane pole asun namaste. Ekasane pole asun. Aau kichi kohontu ni. Okay na. Okay na. Felicitation to the guest na. Vote of thanks. Okay. Now this is the time for our felicitation of our guests.
Now I would like to request our General Secretary of APSI and President of APSI to felicitate our Dr. Alok Srivastava sir.
Now I request our President L.K. Mishra sir to felicitate our President APSI Subodh Singh sir. Vijay Kumar. Now I request our Secretary Apraso, Dr. Sanjay Kumar Giri, to felicitate Secretary APSI, Professor Vijay Kumar sir.
Now may I request our Organizing Secretary Dr. Satyavrata Rautrai sir to give the vote of thanks.
Good evening, everyone. Respected member, I would like to thank our President APSI, Dr. Subodh Singh sir, General Secretary APSI, Professor Dr. Vijay Kumar sir for attending Aprasocon 25. I would like to thank Dr. L.K. Mishra sir, our President Apraso and Chief Guest, Dr. Alok Srivastava, CEO Apollo Bhubaneswar, for organizing this Aprasocon 2025. We will also thank our senior faculties, teachers for attending this Aprasocon 2025. We also thank in this evening to our supporters and sponsors. Without them, our Aprasocon would not have been possible. We will also thank the hotel staff and all supporting staff who have supported us in this Aprasocon 25. Finally, I will thank all the members of the Apraso to make this Aprasocon 2025 a very successful Aprasocon. Thanking you all. Long live Apraso.
Now it is time for be silence, close the aristo counter and stand from your chair for national anthem.
अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you. Meeting is over now.